We can pause the recording.
Good morning, everyone. See some old faces and some new faces. And it's nice to see all of you. So welcome to the 4th annual symposium. Our first speaker, I'm going to do a little bio for him. He likes long walks on the beaches, golden reach. Oh, no, sorry, wrong bio. Rich was trained as a clinical audiologist at the University of Western Ontario, completed his PhD in psychoacoustics at the University of Iowa. He worked initially at the Institute of Hearing Research in the United Kingdom and is currently a professor in both the Department of Otolaryngology, Head and Neck Surgery, and in the Department of Communication Sciences and Disorders at the University of Iowa. I'm proud to introduce Dr. Richard Tyler.
Thank you. Glad to be here. So, does anybody know why he is screaming? You're all wrong. Sorry. We'll come back to that later. So how am I controlling this?
Okay.
Now I've lost the next button.
It's not working.
Give him the right to do that. No. No.
I have the memory stick here, if that helps. I sometimes say that the one tool that I need for my smartphone is a hammer. I'm going to go with this.
Still here.
I don't see it.
There.
So I have to move this every time?
She's taking it. They didn't talk.
Yeah, but Carl is taking over.
Okay.
Okay,
Let's go back to that.
I can always nod if that helps. Or
yeah, here. Okay, right here. If that disappeared, I think when you just click, that will show. Okay. Okay. Yeah, that's
And then this other arrow
should be
is
fine.
this second arrow over here. That'll get you through. Okay. Can we get rid of this?
Should be able to hide. Where do you see that? This one? Okay, thank you.
Okay. Now I don't see the. Do I have to hit this in order to see that?
That's forward and the one to the left.
Yeah, but that's not always visible, so I have to
You
click
have clicked somewhere.
on there. Okay. Okay, so we're going to talk about tinnitus activities treatment. And this covers 4 different areas: thoughts and emotions, hearing, sleep, and concentration. And it depends on the individual that we're working with. And we usually have 4 or 5 different counseling sessions and focus on one session, one topic per session. And they have homework, we practice in the clinic, and then send them home. And when we come back, we review how things went and see what happens next. So it's important to connect where the patient is. They're all different. We want to know where they're at and what problems they're having. So where do you want to start? What do you think caused your tinnitus? A lot of the times it's unknown. Of course, noise exposure, aging, and medications are the most common cause, but what do you think caused it? When your tinnitus began, what was your life like? What were things happening at work or at home? How has tinnitus influenced your life? So I want to be a good listener here. I want to see where the patient is at. I want to know what's happening with them. How do you think we might be able to help you? So I'm sometimes worried because patients come in with expectations that I can't deal with. And so I just want to know what their expectations are. And this is the first thing to start. So there's 4 different areas that might be affected by tinnitus that we can try and help with: thoughts and emotions, hearing and communication, sleep, and concentration. So thoughts and emotions, hearing loss, and tinnitus, attention, behavior, and your emotions. And we want to see if we can help you change your reactions. When we're going to focus on hearing is really important for communicating with people. And we're going to see how tinnitus can affect communication and how you can improve your hearing. And sleep. So we're going to go over normal sleep patterns, how tinnitus affects sleep, some things that you can do to facilitate sleep, and what happens when you wake up at night with your tinnitus. And the 4th area is concentration. So there are lots of things that affect all of our concentration, including tinnitus, how that can affect your concentration, and some things that you can do to improve your concentration. So that's sort of an overview that we would present to the patient when they first come in about what the options are for our counseling strategies. So thoughts and emotions, this is the first section. Then we're going to cover hearing and hearing loss, tinnitus, attention and behavior, and changing your reactions and activities at home. And all these pictures, by the way, are available free, downloading from our university website. So we go through how we hear. We want to make sure they understand about the outer ear and the middle ear and the sensory neural system and information up to the brain. And we're going to talk about nerve activity. So we show them the hair cells, and then I often say this is a little spike. It's like a flashlight going off, or like a on and off. And it carries these little nervous impulses up to the brain, and that's the nervous activity that enables us to hear. So even when there's no sound, there's some activity on these nerve fibers, spontaneous activity, and our brain ignores that spontaneous activity. It's just low level and there all the time. So there's spontaneous activity with no sound. If we hear a word like table, then lots of our nerve fibers become active and our brain interprets that as table. We've learned to understand that nerve activity. For a cricket sound, that's different activity on different nerve fibers, and we hear cricket. So lots and lots of activity going on 20,000 nerve fibers in a normal hearing individual. When we have a hearing loss, we lose some of these nerve fibers, and on some of the nerve fibers, the activity is decreased. So let's have a look at your audiogram. So we talked to the patients and about normal hearing and their hearing loss, as you do already. And then we're going to focus on tinnitus. So what does it sound? It's like for you. It's different for different people. What does your tinnitus sound like? What do you think caused your tinnitus? There's lots of different causes: noise exposure, medications. A lot of the times it's unknown, but what do you think caused your tinnitus? It turns out it's common. You probably have friends that have tinnitus, but you don't know it because you can't see it. And so it's amazing that probably 15% of the population, maybe 30% of the population over the age of 60 actually has tinnitus. So at this point, there's no drug or surgery that has been shown to reliably eliminate tinnitus, nothing approved. However, there are some things that you can do and that we can help you to change your reactions to your tinnitus and how it affects you. So we'll go back to the spontaneous activity on these normal nerve fibers, spontaneous activity. You have a hearing loss. Without tinnitus, you lose some of the activity. When you have tinnitus, some of these nerve fibers are active even without sound. And this is sometimes important for patients because they're sort of worried they're making this up and they're imagining something. So you can give them something concrete. There's some spontaneous activity going on and your brain is doing what it's supposed to do. Your brain is interpreting that spontaneous activity as a sound. So you don't have a mental illness, you're not making this up. And so for a lot of patients, it's really important to show them that they're just some spontaneous activity on their nerve fibers that they're hearing. And that's what tinnitus is. So we're also going to talk about attention and different parts of attention and how some things capture our attention and how our general emotions can have an effect on our interpretation and our attention. So lots of things coming in at the same time. We're always aware of sounds and vision and sometimes smell and touching things, and they all can capture our attention at different points in time, depending upon their strength. So if it's an important sound, like if a police car drove by that we could all hear, we would all focus our attention on the police car going by. And that's, again, important to focus the intention of your tinnitus. If it's a sound that's not supposed to be there, it's quite reasonable that it's going to capture your attention. Tinnitus does not make you deaf. It doesn't mean you're getting older. It's not a sign of mental illness. And if you're worrying about some things, then you can become preoccupied with your tinnitus. You're thinking about that. Sometimes I tell the patients, the more you're thinking about your tinnitus, the more you're thinking about your tinnitus. So we've got to help them in some ways to change their reactions here. So this is an example of cognitive behavior therapy that we use in our strategies. Doorbell goes off. No big deal, it's a doorbell. 2 weeks go by and the doorbell goes off. It's a fire next door. The next day the doorbell goes off, a car accident outside your home. The next day, the doorbell goes off and one of your trees has fallen on the neighbor's lot. 2 weeks go by, the doorbell goes off, a friend sends you flowers. The next day, the doorbell goes off, a friend arrives. The next day, the doorbell goes off and someone sent you a present. It's all the same sound. It's not a good sound or a bad sound. It's your association and thoughts and emotions with that sound that leads to your interpretation of what that sound is. So what kind of thoughts have you had about your tinnitus? Tell me how it's influencing your life. Are there situations where it's more bothersome? Are there situations where you don't notice it as much? How do you feel about your tinnitus? How long have you had it for? How is it changing your life? So we're going to try and help you refocus your activities in your life. So do you have any hobbies? Are there times during the day when you're not noticing your tinnitus? What are you doing at that time? Have you ever tried any new activities that you might consider becoming involved in and not thinking about your tinnitus as much? So we're also going to talk about reducing the contrast between tinnitus and background sounds, and now that might have an impact as well. So if there's a candle going off in a dark room, that candle is very bright. It stands really out. But if the candle is in a window where there's light behind it, the candle is not so prominent. It might be the same candle. And so the same thing applies to tinnitus. There's some low-level background sound. Your tinnitus isn't going to stand out in the same way. So that's important. So it's a dog barking in the room. It's not your dog and you don't like dogs. You turn on a fan in the background, you get busy at your work, and eventually both the fan and the dog fade away into the background. So there are lots of background sounds that can be used. And for example, recorded material, CDs, smartphone apps, nature sounds, different kind of background music, and that can make your tinnitus less prominent. Have you explored any sounds that make your tinnitus less noticeable? For example, rain, waterfalls, music, just static sounds. Have you found anything yourself that's been helpful? So we also give them homework at the end of that session. And so we're going to ask them, I'm simplifying things for this presentation, but you're going to make things, try some different things. We're going to give them some activities. They go home with a diary and try some different things that have an impact on your tinnitus. So this is an example where you're going for a walk in the park. The patient says, well, I heard birds chirping. I like listening to that. And when I noticed that I was listening to all these sounds on my walk, I wasn't listening to my tinnitus. So that's an example. They go home with a diary to try and explore what makes their tinnitus less prominent. So the second session here then is hearing and communication. So we're going to talk about hearing and communication and how important it is, and how hearing loss and tinnitus can affect your communication ability, and things that you can do to improve it. So this is an audiogram that we go through with the patients. Of course, they will have their own audiogram, and we use that to go through things. But I'd like to point out, this is, of course, associated with noise-induced hearing loss. This is referred to as normal hearing, but this actually might be the beginning of somebody who's worked in a factory for 3 or 4 or 5 years. And you'll also note these days there's a lot of, say, marketing about hidden hearing loss. So 0 dBHL is the average of 19-year-olds. So that means some people, when they were 19, had hearing thresholds of -10 dBHL. And if their hearing thresholds are now 0 dBHL, they have a hearing loss. You don't know what their hearing was like when they were 19 years old. And of course, the pure tone thresholds are ability to hear pure tones. They don't capture the effects of hearing and noise and spatial hearing and different things. But it's interesting how this has come forward over time. So there are lots of things that affect our communication, not just your hearing loss, but also background noise, ability to see the speaker, how familiar you are with their speech, if you know the topic or not, and if you're under stress. So these are just general things that we often talk about with our hearing impaired patients as well. It's not just about your hearing ability, it's about many different factors that contribute to communication. So background noise. So this is difficult for everybody if there's a lot of background noise. So can you move away from the background noise? Can you turn the noise down? What can you do when there's background noise? The second factor is the ability to see the speaker. So you might not appreciate it, but you often look at people's faces and watch their lips moving up and down. And sometimes there's body language and they emphasize different parts of speech. So it's really important to be able to see the speaker. So tell me about your situation. What situations do you think cause the most difficulty for you? Have you tried anything to improve your communication skills? Has anything been successful? Have you tried some things that haven't worked that you thought might work? And practice some of these things in the clinic and go over with them and have them sign some homework. So tinnitus can also affect your hearing. The tinnitus itself is not damaging your hearing, but it certainly is reasonable that having some tonal sound in the background is going to be distracting, and it also could mask or cover up some sounds. So it's reasonable that this tinnitus sound also affects your hearing. Hearing aids are a wonderful thing. They have to be fit for you so you can hear better. Different sounds of speech and environmental sounds. And it's not about hearing per se, it's about communicating and interacting and socializing. Localizing where sounds are coming from. So have you thought about hearing aids yet? And of course, some will already have hearing aids, some have just considered it. Some, of course, as you know, don't think they have a hearing loss when they actually do, and they come in because of their tinnitus, not because of their hearing loss. Important to watch faces, and we can give them some examples in the clinic and see what it's like when they're not watching your face. And so background noise is important. There might be some visual distractions going on. So we can show and walk the patient through these in the clinic. So for the activities, we're going to have you, when you go home, we want you to practice some of these things. And again, there'll be a diary, being able to see the talker's face, what's the lighting like. Can you move around and practice improving your communication situation? Can you hear different sounds? Practice some repair strategies with them. So there are some things that they can do. So the 4 sessions I mentioned, thoughts and emotions, sleep, hearing, and concentration. Not everybody has all of these, but many of them do. And we just go through the ones after we go through our questionnaire to focus on which ones are important for them. Sleep. So we're going to go over normal sleep patterns, things that affect sleep, daytime activities to facilitate sleep in the evening, what to do to prepare, what happens if you wake up at night, and in the morning as your tinnitus works. And so there are lots of issues for different people. So we all have different sleep patterns. We don't all sleep the same. For some people, it's 6 hours or so, and some it's 9. It's for people often wake up in the middle of the night. I usually wake up once or twice. Sometimes people wake up more than that. And usually tinnitus doesn't wake them up. But if you wake up in the middle of the night in a quiet room, and all of a sudden now you have this ringing sound going on, that can be very disturbing for a lot of people. So for all of us, if we're upset about something, concerned about something, if there's noise outside, if it's lighting, the temperature changes, if our work schedule is changed. So there's different things that can affect all of us in terms of our sleep patterns. And this is quite normal. Sleeping is really, really important, but that's critical. So we go through things that can affect sleep, including medications, caffeine, smoking. So there's going to be some strategies to avoid, for example, exercising and coffee and things within an hour or 2 hours before bedtime, including eating and drinking and things. Just calm things down before you're going to go to sleep. Develop a pattern that works for you. You can also play some different sounds in your bedtime, waves, music, and of course there are lots of people that have difficulty sleeping even without tinnitus that have bedside sounds going on. At our tinnitus conference every year, we have exhibitors come through and give presentations, and one of the guys has when he was in college in the 1970s, he thought all of his fellow students would want to rock and roll all night long. So he built a loudspeaker in the pillow. It turns out that his fellow college students did not want to rock and roll all night long, but his father had tinnitus. And he then developed what is still available, a sound pillow. So there's a system you can get, and now it's sophisticated, connecting with your smartphone and play sounds through the loudspeaker in the pillow. We also sometimes tell patients that sometimes it's good just to have a sound in your bedroom all the time. So when you go to your bedroom at night, you're not doing something to remind yourself that you have tinnitus. So different for different people. We're going to give some examples about some things people can do to prepare for sleep. Progressive muscle relaxation and visual imagery. So progressive muscle relaxation, and I've had different people come over the years to my conference and talk about some of these things, and I've actually experienced some now, going to some of the classes to learn, and now we can do some of these things. So practicing about focusing on your muscles and how that can help and relax, and I think we have a demonstration here. So everybody can hold out their arm, please, and just hold it out gently, gently. And now squeeze your wrists together, squeeze it together slowly, squeeze it together, tighter, tighter, tighter. Now gently, gently relax it, relax it, relax it, relax it. Okay, so that's an example of how when you're focusing on these things, you're not focused on your tinnitus. And that's obviously a very quick and simple way of one of the ways that people can focus on your feet and your arms and focusing on something else and being in control of your situation, not letting tinnitus take control over your situation. I always like this one, this visual imagery, where I close my eyes. I think I'm on the beach in Jamaica. I can feel that sand. I can hear the waves. Ooh, good palm trees. And it's really relaxing for me when I'm thinking about some of those fond memories. It's very, very helpful. And again, everybody's different, but the patient can go through these things on their own. So they're going to go home with some homework, looking at some things that affect their sleep. Again, we're all different. Practice some activities before bed and what works and what doesn't work. And when they come back a week later or a month later, depending upon how far away they live, we would go through their sleep diary and see what happened. Okay, the next session is concentration. And again, not everybody has problems with concentration, but many do. So what are the things that affect your concentration and how tinnitus can affect your concentration? It's reasonable that it would. What strategies can you try to improve your concentration ability? So lots of things can affect our concentration. These include noise, different distractions in the room, sometimes the temperature, the lighting, background. So there's lots of things that can affect all of our concentration, including tinnitus. So as I say to my patients, the more we're thinking about our tinnitus, the more we're thinking about our tinnitus. So if there's this background sound and we're trying to do something, we're trying to fight it all the time, or we're worried about it, then that's going to get in the way of us performing different tasks. And that's reasonable. So the question here then is, how can we change our attention? How can we move away and not focus so much on the tinnitus but focus on something else. What can we do to accomplish that? So one of the things is to interpret your tinnitus as not being so important. It's not a sound, it's not a good sound or a bad sound, it's just a sound in the background. Maybe for all of us, eliminating distractions, helping us stay focused. That might mean changing some of the work habits we do and decreasing the prominence of your tinnitus. We're going to talk more about that, and taking control of your attention. So that's really helpful for all of us. So staying focused, taking notes, actively participating, sometimes repeating information, organizing things, important strategies for all of us. Decreasing the prominence of our tinnitus. Well, we can do that with background sound in the environment, maybe even just a fan or some kind of music going on in the background. That takes away the prominence of the tinnitus, and if the other sound is not important, we can focus on the activity we need to focus on. So focus your attention is a voluntary control. So we can control what things we're looking at and concentrating on. And we're going to practice some of this now by looking at different things. And if we're distressed and worried about our tinnitus, and that captures our attention, that's going to get in the way. So we need to be able to focus this. So switching attention from one thing to the other. So for example, I might say to the patients, well, I want you to focus on the light in the ceiling over there. Now I want you to focus on this microphone right here. Now I want you to focus on the sound in the room, the fan. Now I want you to focus on your tinnitus. Now focus on the fan. So taking charge of what they're listening to, what they're attending to, is one way, including focusing on their tinnitus, can give them more control. Some other examples, the heater, the people talking, different sounds in the room. When they're listening to some sounds, they're not hearing other sounds, and just pointing that out to them can give them some control over things in a positive way. So this is some of the other examples we have given, including focusing on their tinnitus, not focusing on their tinnitus, and focusing on something else. So the activities that they will go home with is going to be practicing with their attention control exercise, and practicing on visual attention, practicing on attending to different sounds. They'll have sounds plus their tinnitus and sound plus reading. So they're going to have different things they'll go home with in our tinnitus activities treatment to help them deal with their attention exercises, focusing on things. So the next thing I'll want to talk about is hearing aids for tinnitus. So this is a survey we did many years ago, and here 43% of the population with tinnitus did not have hearing aids. 13% did, and this is, you can't see this, these are the almost 13% that said they had normal hearing, but they didn't. Okay. So this is an interesting observation. And the next part of this is we actually asked those who did get hearing aids how it affected their tinnitus. And so about half of them said, well, I got hearing aids and I can hear better now, but it hasn't really changed my tinnitus. That's okay. 4% here said it made their tinnitus worse, and that can be corrected by changing the gain control. But half of the patients who got hearing aids said that it actually helped them with their tinnitus as well. So this is a great opportunity for you and a great opportunity for the patients to have their tinnitus less prominent and less of an impact on their life. So hearing aids can help because they improve communication, and that's important for all of us, reducing stress. Hearing aids also amplify some background noise in the room, and for a lot of tinnitus patients, that's actually a good thing. amplifying this background noise. And that could be a good thing for patients. For a lot of patients, when they take their hearing aids off, the tinnitus is gone for a while. And so there can be some post-masking effects of hearing aid use and also maskers, which we'll talk about in a minute. But not for everybody, but for some patients, that's pretty amazing. I always remember when I worked in England, I was doing some research on some of these tinnitus patients and had this man about 30 years old in the soundproof booth and was exploring some noise and did some experiments with him. And he came out of the soundproof booth crying. He said, "This is the first time in 5 years I have not heard my tinnitus." So it was really amazing to hear somebody have an expect like that because his tinnitus had disappeared after listening to noise for 10 minutes in a row. That was pretty amazing. Doesn't happen very often if the tinnitus is worse. It can be during hearing aid use, maybe amplified sound, it reduces it. So turn down the gain, reduce the maximum output. They won't hear as well, but you can adjust that gradually over several months, perhaps to increase their dynamic range again. And for some people, actually, tactile sensations can make their tinnitus worse. So at least be aware of that. And we'll try out different ear mold strategies, for example. And I'll talk more about that later on. So sound therapy now is everyday experience. It's wonderful how things have changed over the past years. Jack Vernon, who did a lot of physiological work on tinnitus in the 1980s, had a patient take him to this fountain in Portland, Oregon, and said to Jack, "This is the only place where I don't hear my tinnitus." And that's what motivated Jack Vernon to promote and design for the first time, work with the company to develop sound therapy, tinnitus maskers. So that was amazing. Lots of different neurophysiological models of tinnitus. I use the term plural here, and it has to be some change in spontaneous activity. And by adding some background sound, you can change the spontaneous activity going on. So again, going back for the patient, we show them that their tinnitus is real. They're not making it up. There's some extra spontaneous activity going on in the background. And here's their nerve fibers with some tonal sound that they hear. When you play a low-level background noise, there's some random activity on some of these nerve fibers. And if you have tinnitus, then that random noise that you play, background sound therapy, can take away the prominence of your tinnitus. So there's some promise here to go in the right direction to reduce the prominence of your tinnitus. Many different kinds of sound therapies. We can change the level, change the sound quality. The philosophy behind some of these, the reactions to the tinnitus itself, lots of different mechanisms for tinnitus, and background sound can change in different ways for different mechanisms. So we can use background sound in different ways. One way is referred to as total masking. And my background is in psychoacoustics. So in total masking, you can cover up one sound, a pure tone, with another sound, a noise, if it's intense enough. And for a lot of patients, not everybody, but you can totally mask the patient's tinnitus in many of them. And the other approach to masking is partial masking. So in my, when I was a student, we learned that if you play a pure tone to a normal listener and measure its loudness, you can then play a background noise and the loudness of the pure tone goes down when you've got some background noise going on. And that's what gave me the idea of using partial masking for tinnitus patients. So it doesn't have to cover it up, doesn't have to mask it. It can be a lower level noise. So some examples here. Here's your tinnitus sticking out all by itself. You can play a noise to cover it up and you hear the noise, you don't hear your tinnitus anymore. Partial masking is when you play a noise at a lower level, you would then hear the noise and the tinnitus, but maybe the loudness would be reduced. So partial masking is really good if higher level noises might be more disruptive. They could also make your tinnitus worse, or they could also interfere with speech perception. So using low level partial masking can be really good. Jastreboff in 1995 suggested the mixing point where the noise is just below the perception of the tinnitus, and this was in tinnitus retraining therapy. So this is the noise intensity, and on the y-axis, the effectiveness of, in his opinion, that as the increase to the mixing point just below where the person could hear both, that was the best level, most effective level. And then as you increase the noise, and if you covered it up, the effectiveness for habituation for the tinnitus was eliminated. And we showed that that was not correct. This is wrong. Mixing point is too loud for most patients. It should not be the goal. We argue you should use the lowest level possible for each individual patient. Some patients prefer total masking, but for a lot of patients, just having some low-level background sound can make their tinnitus less noticeable and doesn't interfere with their speech perception abilities. Lots of different sound therapy options these days. I'm sure you'll hear that from the people at the back. Broadband noise, the spectrum can be modulated, modulated tones, some processed music, notch music, notch noise, lots of different exceptions these days to move on. And also, patients use non-wearable sounds, including in their office or the bedroom to help them sleep. Sometimes there are different ways to play ocean waves and rain, music players, household appliances can be used for some patients, lots of different options. Okay, so that gives a background of our tinnitus activities treatment. And so now we're going to talk about some other areas, including things like measuring tinnitus and the reactions. So we refer to this as our psychological model of tinnitus. So this is really important. You have your tinnitus and you have your reactions to your tinnitus. And those are two separate things, your tinnitus and your reactions to the tinnitus. So the tinnitus has a certain pitch and a certain loudness and certain quality to it. And your reactions to that sound is influenced by you and what your life is like. And you know, if you're having fun and relaxed and enjoying life, and then all of a sudden you get that sound, that's going to change things. But if you're already stressed out, if you've just lost your job or you're having trouble at home, and then you've got this sound to deal with as well, that's going to affect the annoyance of your tinnitus. So you have your tinnitus and you have your reactions to the tinnitus, and your reactions are influenced not just by the tinnitus itself, but they're influenced by you, by what your brain is like, what your life is like. That's going to have an impact on how you react to tinnitus. And not enough people, in my opinion, have paid close enough attention to this psychological model for trying to measure tinnitus and trying to treat it. So it's not just the tinnitus. We have to connect to the patient, find out where they're at, and find out how we can help them as an individual. So we're going to measure it sometimes for the patient, for the clinician, research strategies. I also do legal cases on this. So a lot of the patients are sort of worried they're making this up. This is, you know, what's going on here? You can measure my tinnitus? You can actually measure this? That's amazing. And so this is quite reassuring for some of the patients. Just like demonstrating they have a hearing loss by their audiograms or by playing sounds they can't hear that their partner can hear. You know, talked about normal hearing already. So measuring tinnitus can include the pitch and the loudness and masking. We can also think about the reactions to the tinnitus. And the reactions to the tinnitus, as I said, include emotions. The tinnitus can affect your hearing in addition to their hearing loss. The tinnitus can affect sleep, and the tinnitus can affect their concentration. So we're going to talk about these different strategies here. Pitch matching, using a pure tone usually to match the most prominent pitch of their tinnitus. So the tinnitus doesn't always sound like a pure tone. Even if it sounds like a noise, you can sometimes, almost always, come up with the most prominent pitch. We usually do that by presenting two tones and have them choose which one is closer. The loudness, we can ask the patient, is your tinnitus louder or softer than my tone? Okay, I'm going to turn my tone up a little bit. Now, is your tinnitus louder or softer than my tone? We can find the loudness level. The minimum masking level is the amount of background noise that masks the tinnitus, so that can be done. And residual inhibition, or post-masking effects, finds out if we can actually mask the tinnitus and then turn our masker off and sees what happens to the tinnitus. And I mentioned already how that can have a major impact. So we don't do all these measurements for every single patient we see. These are just things I want to make sure everybody is aware of, and maybe you do some of these already. It's not essential, but it might be important in some of the sound therapies, for example, that are promoted now by some of the manufacturers. So you can measure pitch. Does it relate to the audiogram? If the tinnitus pitch decreases, does that mean the spontaneous activity on the nerve has decreased? There are some sound therapy devices based on the pitch match. Then you can adjust the noise spectrum according to the pitch match. And so there's some options where that can be very important. So even if it sounds like a cricket, you try and go for the most prominent pitch. There are several methods available, important to keep it simple. Even if they hear binaurally, we would almost always use a monaural stimulus. If necessary, we could test in the ipsilateral or contralateral ear in some of the research studies we've done. Pitch matching can be very difficult. It's difficult to do a pitch match in a normal listener to a pure tone. And if they're hearing a cricket sound, it's also reasonable that it would be very difficult to do a pitch match for the tinnitus. So that's true, and we've seen that. We also looked at, is it related to the audiogram at all? Is it related to the hearing loss at the low frequency edge? And our results found that there were no relationship. And here's a later result we did. And these are different audiograms for different patients. And this is the patients who reported a low frequency pitch and a high frequency pitch and intermediate pitch. And these are their individual audiograms. So these are the pitch matches down here. This is the average audiogram. So there might very well be a relationship between the pitch match and the audiogram in some patients. But in general, there's no relationship between the pitch match frequency and the audiogram shape. There can be in some, but certainly not in everybody. How loud is your tinnitus? I'd like you to rate the loudness of your tinnitus on a scale from 0 to 100, where 0 is the very faintest sound you could imagine. You could just barely hear it. And 100 is the loudest sound you could imagine. Please rate to me the loudness of your tinnitus on a scale from 0 to 100. We can also do loudness matching. I'm going to present a pulse tone, and I'm going to start off at threshold. I'm going to increase it slowly in level, and you tell me when my tone is the same loudness of your tinnitus. Okay, so you go slowly. When we do that, and this is some work from Jack Vernon and Mary Meikle, they found that most patients had tinnitus loudness matches only a few dB above threshold, even for patients who said their tinnitus was loud and the sensation level was only 5 dB or so above threshold. Well, it turns out, of course, sensation level is not a measure of loudness. It's a measure of the intensity of a sound above threshold. And if you remember loudness recruitment, and we published this to show that the sensation level was not clear. So this is the audiogram in sound pressure level. So it's upside down. So this is normal hearing down here at the bottom. And this is this individual's audiogram in these open circles. So they have a high frequency hearing loss. We did a pitch match on this patient, and their pitch match is here in this arrow. So they have a high frequency tinnitus. We then did a loudness matching. I want you to adjust my pulse tone so it equals the loudness of your pulse tone. And it was only a few dB above threshold here. However, if we did a loudness match at a low frequency where their hearing was normal, was 30 or 40 dB above threshold. And that's reasonable given that they had loudness recruitment where they had this severe hearing loss. So that's understandable and reasonable. We also, this was the first time, by the way, that hyperacusis had been linked to tinnitus in our study. We also measure loudness discomfort levels. And you'll see this person's loudness discomfort level was much lower than the normal range at this high frequency loss where their tinnitus was. And we'll talk more about that later. I was also interested in looking at frequency dependent masking. My advisor, when I was a student, Arnold Small, did the first studies like this in humans called psychoacoustical tuning curves. And so if you look at this form down here, if you're, if you play a 2000 hertz tone, then you play a pulse tone and you try and mask that with lower or higher tones, then you can actually mask that with low levels when it's a similar frequency. But if it's further away, you need greater intensity to mask that tone. And that's because of the traveling wave in the cochlea. So it turns out we had patients, and this is sort of a summary picture. We had some patients who had a pitch match of 2000 hertz. This is their audiogram like this. And we increased the level of a pure tone, 1000 hertz pure tone to mask their tinnitus, a 500 hertz pure tone to mask their tinnitus, 4000 and 8000. And they also had a tuning curve. So for these kinds of patients, it may very well be their tinnitus actually is starting in the basilar membrane. They might have some mechanism that is causing some extra excitation on the basilar membrane. That's where the tuning goes for enable us to hear different frequencies and different pitches. However, that was somewhat rare. For most of the patients, they had something like this, where their tinnitus pitch here is 2000 hertz. We're going to increase a 250 hertz tone to mask that 2000 hertz pitch tinnitus, and we can mask it when it's only a few dB above threshold. In fact, we can put in an 8000 hertz tone, and we can mask their tinnitus with an 8000 hertz tone when it's only a few dB above threshold. So this is not how normal listeners perceive the frequencies of different sounds. We also found for other subjects, we could put in levels of pure tones, and it took high levels, very high levels of intensity of pure tones to mask their tinnitus. And for some other groups of patients, we could not mask their tinnitus no matter what. So this is, again, an important documentation that we talk about this as it's one thing, tinnitus, but it's not. It's different in different people. So if we're going to try and find a pill or something to cure tinnitus, it's going to have to be a different pill for a different subgroup. We also looked at post-masking residual inhibition effects. And so some of what we found here in our article we published is that this is the patient's loudness of their tinnitus. We turn on a masker for 10 seconds and turn the masker off. When the masker was turned off, their tinnitus was present right away at the same loudness. For other patients, the masker was turned off and the tinnitus loudness was reduced and then gradually came back to normal. For some patients, the tinnitus was gone for a few seconds or a few minutes, gradually came back. For some patients, it was gone completely. And that's the story that I told you about the guy coming out of the lab and crying because his tinnitus was gone for the first time in 5 years. And then for some patients, not many, but for some patients, the tinnitus is worse when you mask it. And it gradually comes back to a normal level. So that's important to keep in mind in fitting these devices as well. Okay, so that's the tinnitus. And now we're going to measure the reactions to the tinnitus. So the first thing we did was an open-ended questionnaire. Please list the difficulties you have as your tinnitus and list them in order of importance. And this can be done before the patient comes into the clinic. It can be done in the waiting room. Just make a list. We want to know what's important for you. We want to be able to help you. So tell us how your tinnitus has affected your life. We published the first tinnitus handicap questionnaire for clinical trials that has been used worldwide. And these are available on our, again, university website in different languages, including Spanish and French and several versions in Chinese. Another version is the tinnitus functional index. I don't like this questionnaire because it includes some questions on the quality of life, which makes things a little more confusing. For example, has your tinnitus affected your social activities? Well, that could be influenced by the people that you're socializing with, including your family and friends. So I do not recommend this one. So you have your tinnitus. It's affected by thoughts and emotions, hearing, sleep, and concentration. And that is going to have an impact on your socialization, your work skills, lots of different things to keep in mind based on those different functions. So we developed the primary functions questionnaire, focusing on those 4 different areas. I have difficulty focusing my attention on some important tasks because of my tinnitus. My emotional peace is the worst thing on my tinnitus. In addition to my hearing loss, this is difficult sometimes, in addition to my hearing loss, my tinnitus interferes with speech. I lay awake at night because of my tinnitus. So this is the primary function questionnaire, pre and post measurements in a group we did our tinnitus activities treatment. Well, future treatments. So I mentioned the importance of looking at individual data. So this is a lipoflavonoid, and we've done 2 studies, published 2 studies with lipoflavonoid, and on average, it didn't work. We looked for individual results to see if we can find some benefit in some subjects. And you know, so there's something special about these subjects down here. This is pre and post. So these subjects actually got better. So is there something special about them? So I'm trying to work with the lipoflavonoid people again. Again, our results showed on average, there's no benefit of lipoflavonoid, no benefit. For zinc, we did a study on that as well. But I'm hoping, we're planning on getting together with them again. And, you know, every now and again, you see a patient who says, well, yeah, I did it for a month and it seemed to help a little bit. And I don't really, you know, I have mixed feelings about this. I'm not sure if it's a placebo effect or how to proceed, but paying attention to individual differences are very important. This is our study with zinc, and we had a placebo group. So they did their, for example, in this, this is the tinnitus handicap questionnaire score before and after the zinc. And this is their tinnitus handicap score before and after they were giving a placebo pill. So instead of just showing averages, we showed individual results. So here, sorry, this is, for example, here, the zinc takes no effect, but the placebo had an effect. But down here, the zinc takes an effect, and on the same individual, the placebo had no effect. So maybe there's something special about some of these subjects, but we don't know yet. It's very complicated. Future treatments need to focus on individual results, not subgroups. There may very well be medications, and of course, there's lots of stuff online. Most of it's junk, but there's so many patients with this that there's lots of interest by different companies in moving forward. So we did a study with vagal nerve stimulation with microtransponder contacted me a few years ago. And this is interesting because this has been used and approved for epilepsy for a long time. And so there's a nerve that goes up through your neck that can interact with the different parts of our brain and our sensory systems. And so this has been used for years for that process. And so we tried it with these for tinnitus. There was an implanted device, vagal nerve stimulation, and then a surgery that went on around the vagus nerve in their neck. They listened to sound every single evening, paired with the stimulation of the vagal nerve. We looked at individual results. So these are the patients that were in a control group that were not matched. One patient got better for no reason at all. But for some of the patients, it looked like there was some benefit, but on average, there was no benefit. And the company went over and did something in Europe. There might be a follow-up study. We're still working with them, but it's a challenge. I also want to mention, before I finish, somatosensory tinnitus. A colleague of mine, Claudia Colio from Brazil, has been focusing on this for quite a while now. And this is a system that coordinates perception from all different sensory systems, and including things going up in the neck. And this vagal nerve stimulation had to do with that. So maybe, not clear. But in any event, there's all this information going on in different areas, and from the vision and hearing and touch, and it all gets coordinated. Your brain needs to know where you're looking and where you're hearing and what's happening in your sensory systems. And that's what this does in part. And it's also interesting that some of these patients, when they move their head around, it can change their tinnitus. If they put pressure on their neck or they clench their teeth, it can change their tinnitus. And so Bob Levine early on took attention to this and talked about how this is the somatosensory system has influenced your hearing in the dorsal cochlear nucleus. So anyways, that's an interesting area for the future that Claudia is working on some new strategies, but you will see patients who can change their tinnitus. So I want to finish off here by talking about the meaning of life. Okay, the meaning of life. So how happy are you? Is your life better than your neighbors? Is it worse than better than last year? Are you happier than the person sitting on your right? This is quite a complicated situation. And one of the problems that I've noticed, I've done research for many, many years, it turns out that a lot of the quality of life scales that have been published don't even pay attention to hearing. This is terrible. And this is used for healthcare funding and all kinds of different things. And so I got fed up with this. And doesn't your meaning of life depend on your past experiences? We're all different, our age, our expectations, maybe gender, employment, personal issues. So I worked with a few other people. We developed a new questionnaire, 24 questions. I used the 0 to 100 scale, which I think is more sensitive. And one of the questions is, I have no difficulty hearing in any situation. So here it is. We did about 200 cochlear implant patients and over 100 tinnitus patients. These are the individual questions, 1 through I think 24 or something. And these are the results of the cochlear implant patients in the dark and the tinnitus patients in the light. And so they were both very bad on question 1. And sorry, I can't see underneath here, but there were also differences on this one here, I think number 10, between the two groups. Sorry, it was number 5. So they're both impaired in their hearing ability. And the tinnitus patients also said they had difficulty sleeping. So that's important for a quality of life. We also looked at differences between males and females. And there was a difference, I think on 1 here and on 12. And so I think that's it. I have to be careful about talking more about that. So we'll come back to that a bit later. Age greater than 60 and less than 60. And it turns out that older people have trouble remembering things sometimes, but older people are also more satisfied with their financial situation than younger people. So we did a factor analysis, and these are the factors. I should point out that one of the differences between the genders was I'm satisfied with my sex life. We quantified that as well. So these are the different groups that came out. So here it is after all these years, the meaning of life. Friendship, quality of having an outlook that you're looking forward to the future, your physical health, and your mental health. These are how we grouped the questions after we did this factor analysis on these different questions. And hearing is really important. It's not about hearing, it's about communicating and socializing and interacting with people. So this is a new approach, I think, that should be used for better appreciating the factors involved in the meaning of life and how important hearing is and how important tinnitus can affect some of those factors. So this one in the American Academy of Audiology, and Gary Jacobson, the editor, called it this month's gem. So friendship and positive outlook, physical health, hearing and mental health, and satisfaction with life. Okay, so we have an annual tinnitus conference. It was complicated last year, but we were able to pull some things off. We always have a 2-day conference with patients and researchers and clinicians and exhibitors. And the bad thing about this conference is I go and we always have a barbecue and a square dance in the round barn that I'm restoring. And whenever I give a talk in Germany or someplace, they don't ask me about my research. They ask me, how's the round barn? Which I guess is okay. So there's the round barn. I hope you can make it out next time round. Oh, and to finish off, so why is he screaming again? No. So no, that's not it either. So I like working in coffee shops. And so I go into this coffee shop in Northern Iowa, and on this window, somebody has painted in colors the scream. I thought, well, this is, watercolors on this paint. So I was really impressed. They have dropped their cup of coffee. That's why the scream. Now we know the answer. Okay. So that's the end. Are there questions for the tinnitus presentation?
The different results after masking, is there one that's more prevalent than the others? Masking 2 seconds, they keep it.
Right. So when you put on a masking noise, I can say that well, I won't go through this. When you put on a masking noise, just cancel that. When you put on a masking noise, the least effect is it gets worse after the noise is going on. For most patients, it actually, I'm going to say 50-50, either it doesn't have much of an effect or it goes off for a little while. But for some patients, it can actually go away for several minutes. And for some patients, I've seen patients in the clinic who say they listen to a loud sound on their own every morning when they wake up for an hour. And then when they turn that loud sound off, the tinnitus is gone for 5 or 6 hours during the day. Now, I've been somewhat reluctant to explore that in terms of a clinical procedure, but again, it shows you the different mechanisms involved and how for some patients, they can benefit from their maskers even after they take the masker off. Yep. Yeah. So I'm going to say that I don't really know the answer to that, but I'm saying that everybody who comes into a clinic where you're providing hearing aids is going to, many of them are going to have tinnitus. And if you feel it's in your scope of practice, or if you feel comfortable, then you're going to have to talk to them about it anyways. If you don't feel comfortable, if it's not in your scope of practice in your state or whatever, then at least you'll understand where the patient is at, because a lot of them are going to have tinnitus, and you'll be able to interact with that person and refer them if necessary. Well, again, I'm going to say that, you know, I'm not sure that I'm qualified to say, okay, you're legally able to do this or not. I think it is important that when you're helping people with hearing loss, that you know about tinnitus, because a lot of them are going to have tinnitus, and you can help them even just with hearing aids. And almost all the hearing aids these days have sound therapy built in to them. And so they're going to have, when they get a hearing aid, it's going to be an option. And so, you know, it's going to be there. They're going to ask you about it, whether you feel like you're qualified or not, or you're licensed or not. I can't say that I'm not in a position to say, well, your licensing board in your state is wrong or right. You know, I'm happy to help with those things, but that's not my role here, is to make sure that we can do our best job of helping all these patients. And many of your patients with hearing loss are going to have tinnitus, and many patients are going to come in to see you because they know that the hearing aids have tinnitus sound therapy built in. And many of them are going to come in for their tinnitus, not because they have hearing loss. They're going to come in to see you because they have ringing in their ears. And you're going to be able to help them, not just with their tinnitus, but also helping them with their hearing loss. So it's pretty complicated. And I'm pretty good at getting myself in trouble in a lot of different ways. But I'm glad that you're here and interested in this. And I guess that's probably about all I can say. Yes. Okay, yes. So that question was, okay, sorry.
Or just a comment about what you're just discussing. If companies can sell drugs to people or herbal remedies which are unproven, I think that we're all pretty safe, comfortable doing this.
Okay.
Doing what we do. And if someone wanted to try to tell us that treating, helping people with tinnitus is out of our scope of practice. All the things that happen outside of the industry, selling drugs on the radio, on TV, whatever.
Question. Yes, so we have built into our tinnitus activities treatment, we have mindfulness built in and progressive muscle relaxation and meditation. You know, again, this is another issue. I'm not certified as a meditation expert or levitation expert, but I have taken a class as a subject just in our hospital, and I have given a course specifically on mindfulness for tinnitus. And I guess all I can say is that a lot of these things, frankly, are marketing strategies. And I think that the main thing is to appreciate the overall challenges that the individual has with their individual tinnitus, and to use whatever techniques can be helpful for them. And in all of the areas I talked about, thoughts and emotions, hearing, sleep, and concentration, things like meditation and mindfulness and progressive muscle relaxation, all those things are interweaved with each other, in my opinion, and can be used depending upon the individual patient's mindset and what they're comfortable with and what you're comfortable with in helping them. So the question is, if I understood it correctly, are there studies on different patients that already have different psychological challenges in their life and things like that? So as I said, one of in our psychological model, the main emphasis here is that you have your tinnitus. It's a sound. It's not a good sound or a bad sound. It's a sound. And then you have your psychological makeup. And so we have tried, and hopefully more people are doing this now, to monitor what their psychological makeup is, and that their psychological makeup is going to have an impact on the impact of their tinnitus. So if you're having a great time, if you've got support at home, if you've got a nice job, if you've got people that care about you, and you've got this sound, then, okay, well, I can deal with this. It's a sound and I've got support and I'm having a good time at home and at work. If your life is terrible, you don't like your job, you're just had troubles at home and with your partner and everything else, and then all of a sudden you wake up and you got this sound in the morning you have no control over. This is one more thing. Now what am I going to do? I can't deal with this. This is awful. And in the extreme, people commit suicide from tinnitus. Yes. That have what, sorry? Suicide. I don't know that there's been a large scale survey done on this. It's very rare, but I have a small talk on this that I didn't include given time constraints. But one of the things you want to watch for in terms of suicide is if the patient says, well, I just can't live with this, or this is just, or, I started taking drugs and I'm not sure this is going to last for me. Or, I just happened to buy a gun. I just don't know. So, just be a good listener sometimes. It's very rare. I have had, I think, a couple of patients, frankly, I've been doing this for a long time, that have committed suicide. I have been contacted by people from different states and sometimes in different countries because they're so desperate and they're really, really bothered by this. And I think the main thing is to be a good listener. And if somebody says something that is a warning sign, like they talk about harming themselves, they talk about violence, they say it's just not worth it anymore, things like that. And I have taken patients in our hospital and walked them directly to our psychiatry department in our hospital as well. Doesn't happen very often at all. And you're going to be able to help most of these patients, believe me. But at least be aware that every now and again, not very often, but every now and again, somebody like that might come up and talk about some warning sign, and don't be afraid to ask them very clearly and recommend, have you seen maybe you should see a psychiatrist, maybe you should see a psychologist. It's okay to do that. So I think we're going to have to quit.
Early on, you had referenced university website. Did you already share that?
I'll see if I can find it. I'm not sure. So if you just search the University of Iowa otolaryngology tinnitus clinic, you'll come to our tinnitus clinic website. There's a section for patients and a section for clinicians and researchers. And I think we need a break because there's another talk to do after this. Okay. Okay, 5-minute break.
Stop sharing. And I think if you go to share, that's his. This is his, right?
This is the one I.
You
is up
need,
next,
right?
Yeah.
So we'll just open this, maximize, and that's it.
How do you?
Advan this slideshow. Just break down. Short tab, short. Right there. So let's try F. Man, I forget now. F5. F5. Okay.
Okay, and then the thing comes up down here again.
So,
Perfect.
so this go and sleep, I think. But when you see, so when you move, it
Yeah,
should
it
show up.
show up. Okay,
Right.
perfect. Yeah, thanks.
But
Finally.
see, this one is moving.
What?
Look at this.
Oh,
Some
wow.
advanced. So, question is, do you see this?
Uh,
Do you see that there?
By the way, it was actually working here at the end. I figured out those was,
No, this one. I open new one and works.
okay, good, thank you.
Thank you very much. No, it's okay.
Thank you. Oh, is that the beginning?
Yeah, I think that.
Yeah, thanks, Chris.
Yeah, I don't really have any strong. One of the most important things is to connect with the patient and appreciate them, share with them that they're all different, reasonable, that you're upset. I don't think you can say this one strategy is that best for everybody. Right. Yeah.
Really looking forward to being able to get some help.
Yeah.
Experience. So, I mean, I couldn't throw a money. It's not that journal, it's not for me.
Right. Well, there's none of these that have been shown to be better than anything else. It's just pretty complicated. And we're all different. We all have different perspectives on life. Different challenges. So you sort of have to work with them.
I must have that. It's always good to have. Healing enforcement, it doesn't make any sense. There's something else I say, yeah, I know about that. I have
Yeah, there's no, the psychiatrists don't have. Yeah. How do we show? Out of that, because ENT is not a psychiatrist. Right. No, I've actually written an article saying cognitive behavior therapy for tinnitus overemphasized. Okay. And the reasons for that, and that's true for these mindfulness and all this stuff, it can be very helpful, but every patient is different. And the most important thing is connecting with patients. Understanding what's there. And that's, you can use different things in different people, but it depends on your connection. Try. Everybody's different. All right. Okay.
It's a great paper. I had a lot of fun doing it. What the hell is that?
Okay, if you can take your seats again, please.
Verification, state word, you know, they do it and
You can take your seats, please.
Arrows now work.
Oh, yeah. Okay, perfect. Thank you. That makes it a bit easier. Well, I can get, yeah, I can probably get them right too. I'll just get some numbers. There's a lot of repetition in here, so it's okay. Okay, all right. All right, so we're going to talk about hyperacusis now. And I sometimes say it's hyperacusis and my mesophobia, which I'll go into. Part of this has to do with the definition. So the reactions to moderately loud sounds are way too loud, are annoying or fearful or even painful. And this is scary when you see patients like this. Oh, can we? Okay. So part of the problem is that, and again, I always say this has to do with marketing, is people keep coming up with different names. Select sound sensitivity, hypersensitivity, misophonia, exaggerated sound response, decreased sound tolerance, phonophobia. And I find this is confusing, not just to the patients, but to healthcare professionals, to the public at large. We've been using the term hyperacusis for about 100 years now. So I suggest we use the term hyperacusis. So now the back and forth are not using. It escaped. And that comes back up. So the arrows are not working anymore.
Okay. Press anywhere. And then there.
Yeah. Can we
It
make
must-
this go away again?
Yeah. And just go down to this area.
Yep.
Yeah, and then they'll come up.
Okay. So let's just stick with the term hyperacusis, please. We've did a review article several years ago on the different reactions people have: loudness, annoyance, fear, and pain. And maybe even better, just loudness and pain in the extreme situations. These are the different reactions that people have. So loudness are when some of these sounds are too loud. So for example, dogs barking and lawnmowers and radios and things like that. So this is the, you look down here at the bottom, as you increase the level of a sound, in a normal hearing individual, the loudness increases in some linear fashion. If you have recruitment, which we've known about for decades, that you have a hearing loss, and then as you increase the intensity of a sound above threshold, the loudness increases rapidly, but your loudness discomfort levels, when things are uncomfortably loud, are at the same level as they would be if you have normal hearing. When you have hyperacusis, when you increase the level above threshold, the loudness increases quite rapidly. And sometimes only a few dB above threshold. Wow, that's way, way too loud for me. So this is an example of different audiograms with normal hearing and normal loudness growth, somebody with a high frequency hearing loss, and their loudness discomfort levels are around 90 and 100 dBHL. Somebody with hyperacusis can have normal thresholds even, but their loudness discomfort levels are around 50 or 60 dB sound hearing level. So some overlap here. And these are the kinds of, this is a survey we did a few years ago. So these are some of the sounds that people complain about with their hyperacusis. Crying, babies crying, lawnmower sounds, dogs, restaurants, dishes in the kitchen is a very, very common one in my clinical experience. Annoyance, or some sounds are really, really annoying. They're not that loud, but I really find those sounds annoying. Fear hyperacusis is when people don't go to restaurants. They don't go to football games. And of course, maybe nobody should have went to the Iowa football game last week, but that's another issue, I guess. And the worst situation is pain hyperacusis. So there are people who lock themselves in their homes and don't leave their houses. And it's pretty scary when you see somebody like this that can't function in real life because moderately loud sounds create pain for them. So these are some, it doesn't happen that often, but these are some comments. My ear is always burning. It feels like it's sizzling. Walking on gravel feels as if I'm pressing gravel into my wounded ears. High frequency noises feel like needles stabbing in my eardrum. So this is pretty awful when you see people like this. So I prefer to use the terms loudness, annoyance, fear, and pain. Those are the symptoms that people come forward with in my experience. So I prefer to use the term hyperacusis and not all these other terms that come through. Well, what are the possible mechanisms? Well, Jonathan Hazel again started off when he was seeing these tinnitus patients. Not clear what's causing this. The brain is searching for activity, magnifies it because they've got a hearing loss. For some people, maybe there's more nerve fibers with the same best frequency, differences in the reallocation of nerve fibers, and so there's more intensity on some nerve fibers being coated. Interesting that there are some patients that have other kinds of disorders. So this is not one thing. Hyperacusis isn't one thing. It's related to all these different health issues that come across things, and not clear how to separate it all and how to make sense of it. So the estimates are very in different situations, but it does occur with tinnitus on a regular basis. Most of the causes are unknown. There are a few diseases that have hyperacusis as a syndrome, Williams syndrome, fibromyalgia, and some patients go along with other things as well. So there are the onset of this impulsive noise. I always make the distinction between impulsive noise, like when a fireworks goes off or a gun, or people working in factories with a banging and clanging. That's often occurs with tinnitus and hyperacusis and hearing loss. And so when we asked patients what they thought caused their hyperacusis, it was noise exposure. But a lot of them don't know. Just like tinnitus, medications is up there as well, and lots of different explanations. It's just interesting what the different perspectives they have. We also asked these patients if anybody in their family had hyperacusis, and some of them do. For some of them, there's some genetic link. And I'm working with Ishan Bhatt in our university now to look for genetic links that might make people more susceptible to getting hyperacusis and more susceptible to getting tinnitus, in addition to some of these syndromes that we know about, like Williams syndrome. It also surprised me that some patients only had hyperacusis in one ear. Now, that doesn't happen very often, but you just sort of think it's some brain thing going on, and that's not always the case. It also makes it a little more complicated in terms of treating it. And we've also found that sometimes you can actually put a sound in the other ear, and that can have an influence on their hyperacusis in the other ear. Again, as I mentioned this with tinnitus, most of the people with hyperacusis don't think they have a hearing loss, but they do. And so if you're helping these patients, they're going to need hearing aids as well. And we're talking about fitting those. Most of them do not think, or half of them do not think they have a hearing loss, although most of them do. We found in one of our first studies with tinnitus, a lot of patients also complained about loud sounds, although it was possible to have obviously either one in either directions. The prevalence of this varies in the survey, but a lot of patients with hyperacusis have tinnitus, a lot of them. Some patients with tinnitus, less of them, but many of these patients with tinnitus also have hyperacusis. So it's important to understand the issues involved if you're going to be helping tinnitus patients. So there's the survey about if they have ringing in their ears or not. So also interesting that it's not just about hearing. There's other sensory systems involved. We asked them about other smells. And so some of them had very strong reactions to cleaning solvents and smoke, perfumes, pesticides, paint smells, and tastes, spicy foods, sour foods. So a lot of hyperacusis is more closely linked with other diseases, including, for example, endocrine disorders, and maybe more genetic than tinnitus as well. Also make the distinction between children. So some of these children are also having hyperacusis as well. So, there are some, when the eustachian tube is not functioning correctly, that can cause these sounds from when you're eating to cause problems. For some people, their stapedius reflex is not working, and therefore loud sounds are not attenuated. So again, like tinnitus, there's lots of different mechanisms and different links for hearing loss and tinnitus, sometimes linked to smell and taste. So this is much more complicated in some ways than tinnitus is. So when we see our patients, like for tinnitus, understand where the patient is at, using this open-ended questionnaire. What difficulties do you have as a function, as a result of your hyperacusis? I want to know where you're at. I want to understand your problems. One of the most common problems the patient, so I'm sure you see that, is they avoid listening to sound. Some of them don't want to listen to music. They don't want to go places where they have no control over the sound, like restaurants and like sports activities, and sometimes plays and things, and walking in the streets. And this is an issue for hearing aids. A lot of them, not all of them, but a lot of them have hearing loss and need hearing aids. And so interestingly, how hearing aids can actually help these patients. And I'll talk more about that. If they have tinnitus, what do you do when you're providing background noise? Well, it can help hyperacusis patients as well, but it has to be fit properly in that. So different symptoms, different sounds. For some patients, it's all loud sounds. For some patients, it's unexpected sounds. And it depends on the circumstances. So it's really very interesting to see these hyperacusis patients, how they're different in different patients. So this is in contrast to tinnitus patients. For tinnitus patients, usually the first 6 months, 4 months, year is the worst, and then it starts to get better. But for these hyperacusis patients, it doesn't go away. They don't get used to it in the same way. So they need more of our help. So this is a survey of the patients over time. These patients have had their hyperacusis for 20 or 30 years, and it's still terrible. And this is exactly the opposite of the trend that we've seen in tinnitus patients. So as I said, the decreases over time for tinnitus can increase in some patients over time. Have you undergone any treatment? So when they come into the hyperacusis patients, hyperacusis, what have they tried? Well, some of them have tried, this is a treatment. So a lot of them, of course, have done nothing. These days, of course, everybody goes online first for the most part. Counseling, medications, and supplements, and some of them have tried sound therapy. Some of them actually come into the clinic and live their life all day long using earplugs. This is not helping them. It's reasonable. And I have earplugs in my back pocket. If I'm listening to loud music, or if I go to a bar at night, or I cut the grass, I got vacuuming, I've always got earplugs with me, no matter where I am. And I show that to the patients. But putting hearing protection on all the time might actually be making their hyperacusis worse. So it's okay to use hearing protection for loud sounds, and they might need hearing protection for a while because they have hyperacusis. That's reasonable, understand that, but it's not letting their ears and their brain have exposure to sounds at high intensities. And that's not helping and may actually be making things worse. So what makes it worse? Sharp noises, whistles. What makes it better? We try to see if there's anything positive we can talk about. They remove themselves from the noise. If they're relaxed, they have a good night's sleep, they're better frame of reference, they're taking care of themselves, then okay. But for most of the patients, it's a problem. So what problems do they have? They avoid going outside, crowds, affected their quality of life. Because of their tinnitus, they feel anxious, they're upset, but they're because of their hyperacusis, they actually socialize a lot less and they don't go out in places. And that's a big difference between the tinnitus patients and the hyperacusis patients. So these are some of the sounds that they are reporting too loud. Music, as I said, being in crowds, babies crying, and children, they have grandchildren, dishes in the kitchen, sporting events, lawnmowers, vacuum cleaners. If there are noisy sounds with rapid rise fall times that they have no control over, that they cannot expect and control what's going to happen, that's going to be a problem for them. So it creates this annoyance and fear that they avoid things on a regular basis. So, okay. Again, we tried to find things easier as well. So we want to connect with them just like we want to do with our tinnitus patients. Be a good listener. It's reasonable that you're bothered by these loud sounds with your hyperacusis. Are there any situations where you don't notice your hyperacusis? What have you done that's positive? Has anything been helpful? I understand you have hyperacusis and this is going to cause problems for you. I'm here to help you, so we're going to see what we can do. There are some things that we can do and that you can do to improve this. So many questionnaires, again, important to understand where the patient is at. I've said the tinnitus patients, their problems increase over time. The hyperacusis patients, they don't adapt. So it's a problem. We want to document what sounds that for this individual, we want to know what individual sounds bother them, because that's going to have an impact on our treatment, we'll talk about in a few minutes, and their lifestyle and how they can change or cannot change. We asked them if they tried different treatments. So some of them have tried wearable sound generators, medications, and counseling. Those are the three things people have done. No medications, just like tinnitus, have been shown to help them. But a lot of patients are very desperate, and a lot of patients will try until they want it to go away. Some of them have tried hearing protection. I said that's not always the best thing. We know that the hearing protection can help with tinnitus if they and using sleep, but if they're in quiet places, it's going to make their tinnitus worse and their hyperacusis worse. So for hyperacusis, again, sharp noises, whistles, things they have no control over, and they avoid these things. So try to be positive as well. Okay, so now we're going to measure hyperacusis. Wow, this is scary. How are we going to do this? So we can start off with a very low sound and tell the patient we're going to increase the sound in small steps, 5 dB steps, and we want to tell you when it's loud. And in the early days, this was done in the normal fashion, just to measure loudness discomfort levels. What we recommended is we have patients assign a number. So you tell me how loud this sound is on a scale from 0 to 100. And we're going to start off very low, so it'll be 5 or 10% of loudness. But we're not going to go to 100%. We know that you're bothered by loud sounds. When we get to 60% or 70%, we're going to stop. And for some of these patients, you'll have to stop. You know, you start at 20 dBHL, 25 dBHL, go up in 5 dB steps, not 10. And they're at 50 dBHL and they say, oh, that's 80% loudness. I don't want any more. That's okay. You've got a measure that you can document and see if you can change that over time. So we have some forms. These are available online, keeping track at usually two levels for 80%. Again, this is the level of a sound definition of hyperacusis. So this is as we increase different stimulus level, the loudness from 0 to 100. A is normal. B is when you have loudness recruitment, you have a 40 dB hearing loss. In this example, you increase the loudness of a sound and the loudness increases rapidly, but the loudness discomfort levels, 0, 100% loudness, is at the same level as somebody with normal hearing. With hyperacusis here in C, when you increase that level, the level increases quite rapidly, and their maximum loudness in this example is at 60 dB above threshold. Lots of different questionnaires. The questionnaires we've used focus on different specific sounds. So which of these sounds are too loud for you? Because this is going to have an impact on how we counsel them and how we want to change their environment. So lawnmowers, baby crying, power tools, don't like being around their grandchildren, don't like going to restaurants, vacuum cleaners, music. Okay. We also talk about annoyance. We can measure their annoyance, having these scares, what they're afraid of. And we've done these questionnaires, and I'll show you the results in a minute. There's lots of different questionnaires have been explored over the time. I don't really have any preference for any one particular questionnaire, but we do use a scale again from 0 to 100 and have them rate these different sounds. And these are the ones that we published in the Cat's Handbook. Standing next to a dog barking, stacking dishes, and these are based on responses that I've heard patients say in the clinic: hearing music, telephones, television, standing next to a lawnmower. So those are all questions, and the answers to that are shown here. So this is loudness, annoyance, and fear for crying, lawnmowers, dog, restaurants, dishes, and those are the main things that these patients are aware of, concerned with. These questionnaires are available online. Again, there's the website, Medicine U Iowa EDU Oto Research Tinnitus Questionnaires. And again, you can just, frankly, you can just search these online, and I can share this with the group here. Okay, so our hyperacusis activities treatment, modeled similar to the tinnitus activities treatment that you just were exposed to. You want to start off connecting to the individual patient. It's going to affect a lot of different people in different ways, different terminology. The way we categorize it, again, loudness, annoyance, fear, and pain. So how has it affected you? Tell me what problems do you do? How has it changed your life? You want to connect to the patients. What sounds are too loud? How often does this happen? Are there situations? Do you notice when you're at work that you're really bothered, but if you're at home, you're not so bothered by these sounds? It's really, everybody's different. They have very different perceptions. Like with our tinnitus activities treatment, we're going to talk to them about how the ear works and the activity on nerve fibers, the flashlight going on and off, show them about spontaneous activity. We're going to talk to them and give them some realistic activity that for them, for some reason, there's more activity on your nerve fibers for moderately loud sounds. There's a lot of activity on your nerve fibers. You don't have a psychiatric problem. There's something wrong with your hearing system that's creating more nervous activity on these nerve fibers. So again, connecting with them, their responses are real. There's something wrong with their auditory system. What do you think caused your hyperacusis? Just like we would go through. So the different reactions, again, like tinnitus, emotional well-being, hearing and communication, sleep, and concentration. So our counseling is based on those different areas. We can talk about earplugs and sound therapy and some relaxation, meditations, different things. So earplugs are good for all of us. We have, as I said, we give them out to the patients and they can help. And however, they're not exposing you to everyday sounds. Sound therapy can help for a lot of patients, having some background sound that you have control over. And for a lot of patients, being exposed to these loud sounds, moderately loud sounds, and increasing that over time can actually help with their hyperacusis. So different sound therapy options. There are non-wearable options. So you can have sounds going on your smartphone just in the background, and low-level sounds that you have control over their level. And then gradually, over several weeks, over several months, gradually turning that sound up, gradually, over several weeks and several months. And that's sort of getting your brain adjusted and accommodating to loud sounds, both with non-wearable devices and with wearable sound devices. And there is data showing now that this can actually works. So here is the frequency of a sound. We're increasing that gradually over several days, over several weeks. Talked about this already. You don't like dogs, you've got the fan noise, you keep yourself busy, and gradually we're going to turn up this background sound so the barns. The same things with muscle relaxation, go through different steps, and deep breathing exercises, meditation type things, visual imagery, we talked about already. There are no medications. I'm very clear with the patients. There are no medications that are going to help you with your hyperacusis. There are medications that help you with sleep. There are medications that help with anxiety and depression, and that's okay. But there are no medications that have been shown to help with hyperacusis at this point. Sound therapies can actually help very much, and we talked about the nerve fiber activity. So as you increase the sound of a tone or a noise, then on the nerve fibers we've already talked about, the nervous impulses, those like flashlight going on and off, increases and increases. And for some reason, you can see as we increase the level of the sound, for some reason, your nerves are showing more activity than they're supposed to. So again, this is a way of connecting with the patient. You're not making this up. You don't have a psychiatric illness. There's actually some abnormality with your nervous system that's creating more nervous activity, and it's not your fault. You have hyperacusis, and there's something real going on. So this helps patients. Jonathan Hazel talked about abnormal gain control, where the brain is searching for activity. There may also be more nerve fibers with the same best frequency. There's lots and lots of neural models for these things, but nobody really knows in general. So hearing aids are a problem with these hyperacusis patients. So what are you going to do with this patient who is bothered by loud sounds? Well, you can certainly turn down the maximum output of the hearing aid so they don't hear loud sounds, but that's going to have an impact on their speech perception. So gradually, if it works for this individual patients, there's no magic wand, you can gradually over several months turn that maximum output up on the hearing aid and see if that can help them. So sound therapy options for hyperacusis. So Jonathan Hazel talked about noise generators. So he was the first one to use this noise generators for hyperacusis patients. And again, there's some data showing that just having this low level noise you're listening to all the time can actually change your brains, making your brain accommodate to these things. Jack Vernon, in one of his books, published a strategy about in the evening, put your feet up, relax, listen to noise when you're in control of the noise, and listen to it for half an hour, twice a week in the evening. Take it easy. And then over time, next week, turn it up a little bit or listen to it for 45 minutes. And then next week, turn it up a little bit, listen to it for an hour. And over time, increase the duration you're listening to the noise and increase the duration. And that can help with hyperacusis. Well, when we got involved in this, it was pretty clear to me that patients all described individual sounds. So what we suggested is that, okay, if you don't like dishes in the kitchen, then you sit down, you have a recording of dishes, or we make recordings for the patient. Sit down in the living room, relax, put your feet up, listen to these dishes at a very, very low intensity when you're in control of this. And then next week, next month, turn the level up, move it forward a little bit. And I sometimes give the example to the patients that if you're afraid of spiders, then look at a picture of a spider and then have a spider in an aquarium with a lid on, and then have a spider in a terrarium and take the lid off. For hyperacusis, If dishes are a real problem for you, you take the dishes and you have a dish and a fork that you hit together. You're in control at a low level. And then move it to the kitchen, walk yourself into the kitchen and do it in the place where it happens. And then have somebody that you trust do it for you in the kitchen. So the successive approximations with these patients with the actual bothersome sounds that are used. So those are the sound therapy treatments that have been used, that have been shown to help some patients. It can take several months for some patients. Carol Samuth and colleagues had a very clever idea that I would like to talk about. So we talked about these things and data supporting them. So here's the Carol Samuth one. So she suggested fitting hearing aids on these patients with closed ear canal, ear molds. So this is now acting like an earplug. So now these patients are wearing earplugs, hearing aids with closed ear canals. And then the hearing aid now controls the maximum output of the hearing aid, of that hearing aid. So the hearing aid is now controlling the sound that they are listening to. And then over time, again, it can be several weeks or several months, we're going to now increase the level of the maximum output of the hearing aid. So you would be controlling the gain of the hearing aid. Patients would likely have to come in on a regular basis and deal with that. But I thought this was very clever. And now there's some groups that are actually going to produce this, I think, with one of the hearing aid companies and make it easier to do. But what a straightforward, clever idea. So Craig Formby and Edens are working on this now to try and work with this. So the works like an earplug. You use the hearing aid to fit amplification to the individual's hearing loss, but then you're using the compression circuit to control the maximum output. And then you can use sound therapy built into it, of course, as well at the same time. So clever strategy. So summary for sound therapies: low-level continuous sounds, sounds gradually increased. You can copy the individual sounds that they're bothered by for their individual experiences, like dishes in the kitchen I exposed to, doors slamming, their grandchildren. You can also use hearing aids and close the ear canals and move on. So in summary, loudness, annoyance, fear, and pain, several different mechanisms, not clearly related to hearing loss, not clearly obviously related to tinnitus, a wide variety of causes, and lots of different questionnaires available. Some of these are online on our website. Lots of sound therapies that I went through, adjusting the hearing aids. And there's some good data that I'll just supporting some of the sound therapies I won't necessarily go into, but it's pretty impressive now that there are some things that we can do with these patients, because some of these patients are very, very desperate. And some of them are now being helped with the sound therapies that go on. Our hyperactivity counseling is available online, and we'll stop there and ask for questions. Hyperacusis is a real challenge, but you will see some of these hyperacusis patients. And with your skills at fitting the hearing aids, you're going to have to adjust the hearing aids appropriately for these hyperacusis patients, because they're not going to want hearing aids, but they're going to benefit from hearing aids because they almost always have a hearing loss also. But it's going to take careful fitting of the hearing aids and gradual exposure to sounds and gradually increasing the maximum output of that hearing aid so they can accommodate to them. And some of the patients are very desperate, and these patients need your help. Comments or questions? Okay.
Thanks.
All right. All right.
All right, so we're going to take a break till about 10:15. Is that right, Carla? And at well, then we'll start with our manufacturer presentations. We'll have Signia, Oticon, and Widex to begin with. And so take some time now. Make sure that on these break times, you do visit the tables, because everybody back there is the whole reason that we can have you guys here and our virtual attendees. So make sure you get some time to connect with the manufacturer sponsors that we have. So we'll see you in about 10 minutes.
Which I call that.
Yes.
Yes.
Okay. Okay, great. Let me just,
Obviously, and that's part of the reason why one of the first things you have to do, and I'm not blaming you for this, one of the first things you have to do is connect them. Understand your problem. It's real. This is terrible.
let's say delete. Let's see.
I think everybody's got their USBs.
Let's see if we can. I think we can do it over here. And it looks like, got it. Copy. Hi, how are you? All right. Okay. Yay. All right. Okay, I think I have it. Let me just, and I am just need to,
well, this won't really reach.
okay, hold on one second.
Does all of them have to be plugged in at the same time?
No, I'm gonna take it out right now.
Okay. Yeah, if I could just.
And, check. Okay,
It won't just pop on the,
here we go.
Thank you so much.
Yep, and,
did mine pop on? Yeah, it did. It's in the middle.
okay,
Awesome.
perfect.
And I can pull this right out, right?
Yep. Okay. All right, so let's bring this up first.
Cool.
Okay,
Cool.
and then let me just go over here and share it. And this is it.
Awesome.
Share. Okay, and then you
Good.
could play around with
I
that.
just need to put it in presentation mode.
Okay, how do you hide this?
And that's okay, it goes away.
Does it?
Yeah.
Okay, okay.
We just need it in
And
presentation mode.
you are screen sharing. How come I don't see it? Here. Oh, yeah, we do. Okay. All right, so you're good.
All right. So I'm just gonna just put this over, put it that, and then let's get this in presentation mode. And then let's, okay, this has got a here. We're gonna stop sharing that for a second. And I'm just gonna minimize that for a second. And then we're gonna do this. and then swap presenter view, duplicate slideshow. There we go. And then escape out of there. All right. Put that in presentation mode. No, we want this to be duplicate slideshow. All right. And then there we go. And then share screen. Screen one, share. And then there we go. So we should be, there we go.
Okay, and then you can help maybe.
So we should be, well, and then they should be able to see that, right?
Yep, yep.
All right. Oop, I lost my hearing aids. I'm hoping Melanie took them. I hope so, because they're gone. And then to make this go away, and then hide floating meeting controls. There we go. There we go. There we go. All right. Are we using the lavalier mic? You know me, I don't need a mic.
If you speak anywhere here, if you want to walk around, you could.
Do you, for the home viewers, is it rather I stand still? It's fabulous.
It doesn't matter because we have videos. It's not just that, it's not this. We're going off of video.
Oh, so I can walk around?
Yeah.
Oh, I thought I had to stand still.
You'll need the lavalier, I think, for sound. I think.
For the home people?
Yeah.
Okay,
Unless you want to test it.
all right. Because you know I'm loud.
Okay, so why don't,
It's up to you.
then you're not shackled at all, I'm thinking.
You know I'm loud, so you know I don't need a mic. But it's for the home people. I want to make sure that they can hear me.
Yeah, because it comes in through that or this.
Okay.
But do you know how to?
Yeah. I'm good. I just don't want to overpower and be too loud.
Right.
So we'll get it on and we'll see if this is okay. Is this too loud? So I'm going to talk like this, and if this is okay. So even if I'm over around, is this okay? You got the.
I can.
All right. Is this too loud? So if I talk like this, if I'm over here, is this too loud? I don't know. I mean, I am loud. You know I'm loud. I don't want to be too loud. All right. I'm going to keep on talking, and I'm okay. I'm all right. All right. All right. And then for the home viewers, they're not able to see the screen though if we go too far out.
No, they can see it. They can see that.
Yeah, but they can't really see the PowerPoint.
Oh, no, they can see the PowerPoint. I'll show you.
Oh, they can see the PowerPoint. Yes, 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 yes. Ah, yes, 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 yes. I know. It's, oh, you are so much better than me. Are you kidding me? All right. Am I too loud though? You think it's okay? Okay. No. Yeah. All right, guys, we're going in. Yeah, we're going in. All right. There we go. We're getting personal.
We're trying to find the bio that I sent.
Oh, you can make it up. Yeah, you can make it up. You all know me. She likes puppies and kittens. I know. Yeah. Hey, guys, sure. Who's at home? Let's see who's at home.
My God, you're so much better at IT than I am. Are you kidding? You're amazing. All right. Oh, awesome. I figured that because I looked and then they were gone. Cool. Cool, cool. I like how you coordinated your mug. It was very good. I know. I gotta plug in my clicker. So my clicker works. I'm good to go. Yeah. All right. Oh,
Okay,
Hey,
we have a
guys.
2-minute countdown, guys.
2-minute countdown. Hey guys, I recognize a lot of names. Hey. I feel like, remember, what was it? Romper Room. Romper Room, when they looked in the mirror and they recognized the names. Remember Romper Room? I know, I'm looking at all the names. I'm recognizing everybody. Hey guys. It's so good to see you. Ah, Lorraine, I miss you too. It's good to see you all. Oh, no, that's fine. No, it's fine. I know we're going to start soon. It's okay. I'll see you guys hopefully in person soon. Hey, Patty. Hi, Lisa. You remember Romper Room? I know. I'm so dating myself. You say that to the kids, they're like, what? Which one? What is that? I know. Awesome to see you. This is so nice that you guys were able to join in person and virtual. This is such a nice event. I always liked coming. I know. And I'm not going last, which means it's not snowing this year. They were joking when I came. Exactly, Craig. We're not that old. Thank you. I agree. Oh, Lisa, how are you? Of course you remember Romper Room. These were the good days. Remember?
Okay, everybody start moving towards your seats. We're going to get started with the rest of the morning presentations.
That's right. We're not that old. We just get better with age, right? Of course. Like a fine wine. Where we're talking about Romper Room and the good old days. Exactly. Yes, the 80s was great years. I know, 80s birthday, but we're talking about 80s birthday parties. Are you kidding? We did an 80s day. We had a Signia University over the summer with the school age kids, which are like they're in their 20s. So of course we did an 80s day. So I did my hair really big and I had the big bow and the shirt off the shoulder and the fluorescent pink. And everyone's like, you did that way too easy. I said, it's because this is what I used to do like every day. It was very good. It was very reminiscent. I'm like, I like this very much. This was a good look for me. It was fun. Yes, big hair. That was a good time. Aquanet, yes, extra super hold. 80s.
We're talking 80s.
Absolutely. Oh, you use that now. Oh, very good.
Okay, everybody, we're going to get started with our afternoon presentation.
I'm gonna bring you guys back. We're gonna start now. I gotta put you back over on the side. So I gotta go
Our
back to the
first
podium.
presenter of our manufacturers this morning is Dr. Lisa Perex. She is from Signia. She has been with Signia for quite a while, now WSA. And if anybody knows Lisa, she's one of the most dynamic speakers I know. So I'm going to turn the mic over to her.
Thank you. All right, it is so good to be here and it's not snowing. Yay, it's not snowing. This is true. This is true. Did I jinx it? So we are going to talk about AX technology today, and the proof is in the processing. So I put mine and Melanie's name up here. If you don't know us, Melanie's in the back. She's waving. Melanie Holman is your account manager for New Jersey, for Delaware, and those are our cell phone numbers. So absolutely, you can reach out to us. You can reach out to me if you have a difficult fit, because those are always the most fun. And or to Melanie, because we both are audiologists. We can help you with that. And Melanie also is the person to help you with your business planning, placing orders. She's the gal that comes into your office. I could come into your office too as well. We could do virtual visits or in person, kind of like this convention, which makes it a lot of fun. So today we're going to talk about our AX technology. How many of you all are familiar with AX? Okay, a few. Good, fun. Let's talk about it. Why are we talking about it? Because it's what's important for the patients. Look at what's most important to the patients. This is a survey that was done with over 15,000 hearing aid wearers. It's funny. If you ask us what's important to the patient, we say small and tiny. It's got to have connectivity to everything. It's got to do everything. It's got to be remote mic availability. It's got to work with the smartwatch. It's got to have manual adjustments. It's got to have it all. Those are all bottom of the list is what's important to the patient. What the patient says, they got to hear better. That's what's most important. Hear better in noise. Hear better in quiet. And it's got to work. Better reliability. Those are the three most important things to the patient. Everything else comes secondary. So what's the best listening environment out of everything? Remember the movies? Yeah. What was the last time we went to the movies? I know, long time ago, right? In the movies, that is your ultimate best listening environment. You go to the movies, the main character is having this great conversation, and he's talking to someone on the corner of a really busy street, and the cars are zooming by and the trucks, and he's having this really in-depth conversation, and you are hanging on to every word, and you can hear everything, every bit of that conversation. And you feel like you're right there in the movies with him. And you could almost feel the wind as the cars zoom by because you feel like you're right there and you can hear everything. It's the best listening environment ever. If you were actually standing next to that guy on the corner, you wouldn't hear a darn thing. You know why? Because that traffic would drown out everything he was saying. The reason why the movies is so good is because they have a sound engineer. And the sound engineer records his speech separate than the background noise. And then they mix everything all together so you could hear perfectly while you're sitting in the movies and feel like you're in the middle of all the action and still hear everything. Hearing aids try to do that. They try to make that contrast. And they try really well by using directional mics and noise reduction. We've been doing it for years and they get better and better and better. They make the contrast by reducing the background sounds, focusing on the speech. But in doing so, what they do is they mute the background. So you lose kind of that awareness of what's going on around you. So that way you could focus. And that's what the directional mics do. The reason that you kind of lose that awareness is because we're working in one plane, one processor. And that's how hearing aids work. That's why we separate that one plane, that one processor into multiple channels. And that's why at Signia, we've been doing many, many channels. And we switched where our top of the line used to be 16 channels. And then we went to 48 channels. And everyone's like, why are you doing that? That's crazy. It's overkill. And it was, and it still is for frequency shaping. And that's why with frequency shaping, we still only give you maximum of 20 to make adjustments. But for noise reduction, for directionality, you want the multiple channels because what it does is lets you carve out the noise and enhance the speech. Smaller area you work, the better clarity you have. So that's how we could get around working in that one plane and try to get better speech understanding, better noise reduction. But there's still limitations. And that limitation is there's going to be times that in that one channel, you're going to have speech and noise occurring. And the hearing aid's going to have to make a decision. Do I enhance the speech or do I bring down the noise? What do I do in that one area? So it's going to have to compromise. And it's never going to be as good as the movies. So how do we get the hearing aids to be like that movie experience where we can reduce that background noise, enhance the speech, and really make things clear, but still have you immersed in the background, just like those movies? That's where AX technology comes in. AX is augmented experience. Our experience chip is using all your acoustic information. It's also using motion sensors, and it's adapting based on who you're talking to, what's going on. The augmented experience is doing all that, but it's like the movies, because now instead of just using one plane, one processor, this hearing aid has two processors. So for the first time ever, you've got two processors in one ear and two processors in two. So now it's like having two hearing aids in the right ear and two hearing aids in the left ear. And you've got a processor that's going to focus just on speech and make speech clear and use all the channels for that. And then you've got a processor just for noise, just like the movies. So let's tell you how it does this. But these two processors, and the one for speech is using all channels. So if you've got a premium hearing aid, a 7-level technology, that's 48 channels. So it's using all 48 channels just for speech. And it's more linear compression, brings the speech clear, bring it close to you. And then the second processor in the same hearing aid is using all 48 channels, different compression, a lot more compression for background sounds. And then the AX chip is going to mix those two different processors together to give you an optimized sound, better clarity, better sound for speech, more natural, and the background sounds still sound clear. The difference is it doesn't overpower the speech. So the background sounds aren't muted, they're not dulled. You hear them clear and vibrant, just like the movies, like you're experiencing them like real life, but they don't overpower the speech. So it's like real experience, just like you're watching the movies. And it's using all of those acoustic motion sensors. So it's using the information on motion. When you're standing still, it's more focused. When you're moving around, relaxes directionality. It's looking at your signal to noise ratio on who you're talking to, whether it's noisy in the environment, what's going on. So all that you love in the experience chip, it's doing in the AX2. The difference is it's doing it in two processors. So that's a clearer, more natural sound. This is a whole new way of processing. If you haven't heard it, we have a sound sample we can play for you in the back. It is completely different than what you've heard before. And the best part, in the software, it doesn't involve you having to program each processor separately. Thank God. The AX chip does it all together. So all you do in your universal program is what you're doing in the software is you're setting that universal program on where you want it to start, how much directionality versus how much omni. So you're setting it at balance. That's your starting point. Equal amount of directional and omni, and you can make it more focused or more open from the starting point. And it will adapt automatically based on the environment the patient's in. So it's all automatic. What this does is it makes your universal program handle everything, whether it's a 7 or a 5 or a 3. And in the spring, we're also going to have 2s and 1s coming out. So it doesn't matter what level of technology, it's going to be all automatic in your universal program. So that's what makes it comfortable, natural, the best sound that you can have for your patients. And it works, not just in a testing environment, but also at home, because we're really big at Signia at putting the research behind what we claim. We want to make sure it works for you. We don't just want to put these blanket statements out there without backing it up. So we see that this contrast between the focus area and the surrounding actually has the patients understand better for speech in their own home environments, not just in the test environments, that they prefer it to their own hearing aids. And these are hearing aids that are new. Not that they had hearing aids for 10 years. We tested it with people that had new hearing aids, new technology, and that they understood better with the technology. And this is exciting. This I am proud to present to you. This shows you what Signia puts into research and development. Did you know that we actually have 40% more in research and development and patents than any other company? Look at this chart. This is just showing 2021 of patents that we applied for versus any other company. The long dark line, that's WS Audiology. The line below it, that's Sonova. The line below that, that's William Demont. What does that mean? Well, the more patents you apply for, that's the more innovation. That's the more technology that you're able to introduce to the world. That's better sound quality. That's better options for your patients. That's new and groundbreaking technology that's available for you to offer. That's how we came out with own voice processing. That's how we came out with the first contactless rechargeable custom product. That's how we came out with the first Flimric, the first earbud design custom product that looks like an earbud, but it's a true hearing aid, or the first CIC cross and the long battery life we have with our crosses. Did you know that 1 out of 3 hearing aids in the world comes from us because of our innovation, because of what we are able to offer? So you know that when you are fitting an instrument from our company, you're offering your patients the best innovation, because we believe strongly in research and development. Look at the amount of patents that we've applied for. Again, 40% more than any other company. So I'll just leave that up there so you can take a look. Because what that means is that you see more innovation that'll come out in the next year and the next year and the next year. So that's exciting to see as well. So there's more from the AX technology, not just the two processors. We have a new way of interchanging the sound between the ears. We're still using the near field magnetic induction. That's how we can have the very low battery drain. Have you noticed that our crosses last a lot longer than any other manufacturer? Because they're using radio frequency. Radio frequency is a higher frequency. Radio frequency is Bluetooth. It's a higher frequency. It has a lot more battery drain. Near field magnetic induction is a lower frequency, a lot lower battery drain, less interference. So that's why we're able to do the crosses. We're able to do narrow directionality. We're able to do twin phone. We're able to do own voice processing, all without causing great amount of battery drain. So this E2E wireless 4.0 actually has sped up the process, much lower latency, better integration of sound between the ears. So better crosses, better sound quality, actually enhance the feedback cancellation, better dynamic range. The dynamic range now can go to 117 dB. So better sound quality with that. And with AX, you can stream now from Android and Apple. So you have that capability as well. So with the Android, it's the ASHA capability. So that is a great improvement too as well. So for those people that are Androids, like myself, we no longer have to have an accessory. So that's a really nice option too with our AX technology. So not only we have two core processors, better integration rate between the ears, so better sound quality, lower latency, more circuits, better battery life, better sound quality. All of that adds up to a win-win with the technology for you and your patients. So now you know what's inside with the AX technology. Let me show you what they come in as far as the instruments. This is exciting. Do you guys think you could use a rechargeable custom? It's nice to have another option, right? Very sleek design. And no, it's not just in black. Also comes in skin tones. What do you notice about the faceplate? No charging contacts. This is using magnetic resonance. No other hearing aid is using magnetic resonance for its charging capabilities. So there's no contacts, not on the shell, not on the faceplate, nothing to get corroded, nothing to get gunked up, nothing to get clogged. Uses your Bluetooth connectivity. And it's got a great push button on it. So the push button is right in the middle. And actually, I'll continue to show on here because mine are real tiny. So the push button's right in the middle. So you're not going to touch it by accident when you're putting it in and out of your ear. And you can use that push button to shut them on and off. 5 seconds, hold it down, shut off. 5 seconds, put it back on again. Although the case will shut them on and off as well. Put them in the case, it shuts off, take them out of the case, it turns on. You can have a removable string on it as well if you need. I like where the push button is located in the middle, and then it's programmable as well. So the way I have mine set, because I'm an Android, and because I can stream to both, I have both my Android, my personal phone paired to my hearing aids, and I have normal hearing, but I wear them all the time when I'm walking the dog, when I'm on the elliptical machine, I wear them for streaming all the time. So I have my Android paired to them, and I have my work phone paired to it, which is an Apple. And they're both paired at the same time. So no matter which one rings, it goes directly to my ears. Makes it very easy and very simple. Right ear, quick press, volume up, longer press, volume down. Left ear, I have as a program change. So that's how I have mine programmed. But I realize patients may not be able to do the quick press, longer press for volume up and down. So most people program that push button, right volume up, left volume down. Raise, right raise, left lower. Make it a little simple for them. You can put a removal string on there. First custom ever that was IP rated. We found a way to seal those microphone ports. There's no battery door. There's no contacts, nothing to corrode. So this IP68. What was the second thing most important to the patients? Reliability. So you've got it. You've got it with a custom. So you're not going to have moisture problems. They can wear it while running a marathon. Not me. You guys know, only run when chased. No one's chasing me. I'm not running. So I have better chance of wearing this, in the pool. That's, yeah, with a nice little drink, right? There you go. You can fit a lot of people with this one. You've got 3 different matrices. So it's size-wise, it's a half shell or a canal or an ITE. It's not tiny. It's not invisible, but no one gets accustomed to be invisible. They know that. Matrices, you got a 50 peak gain, you got a 55 peak gain, and you got a 65 peak gain. So you're going to fit a lot of losses with this one. So if you've got someone with a severe loss, you can cover it, which is awesome. Very easy to use. As we said, contactless charging, 24 hours on a single charge. That's without streaming. Okay, so more like 20, 21 hours with 5 hours of streaming. Here are your different colors. You can get black if you want it to look like an earbud, but you have more of the skin tones too as well. You can get the shells to be red and blue. The serial numbers will be in red or blue. Okay, so they'll be able to tell which one's right and left, or you can get the shells in clear. So you have different options too as well. For charging, again, the case will automatically shut it off. And here's your battery life, 24 hours we said without streaming. And you're going to use your NOAA Link wireless. Now, this is the easiest charger that I've ever used. And I've been around for a long time, as you guys know. No comment. When you look at the charger, it's not a portable charger, okay? It's got to be plugged in, right? You're going to have the lights on the bottom showing that it's charging. The charger is not custom. So it's one size fits all. And it's got the little wells where the hearing aids fit into. So the way the hearing aids fit in might be different depending on the size of the hearing aids, okay? And I have to hold them in because they're going to fall out. It doesn't hold them into place. It's not, even though it's magnetic resonance, it doesn't mean it's like holding them in. So when they're in there, you'll see it'll start lighting up and recognize that they're in, and they'll start charging, okay? The reason why this is my favorite charger in the entire world, it's a 6-second delay before they turn on. So I'm going to let them shut off and turn on. Wait for the lights to be off. Let's say the person puts them in wrong. They've got poor dexterity. Maybe they got Parkinson's. Maybe they just really don't get it on how to put it in the charger. So this is my right one. Maybe I'm going to put the right one in the left ear and the left one in the right ear. Still charging, right? Well, let's wait. Here we go. Still charging. Take them out. Waiting for them to turn on. All right, so maybe this person's really confused and you told them the canal's got to go in the well. And that's what the manual says. The manual says the canal's got to go in the well and the faceplate's got to be flat. And that's the only way it's supposed to work. And if you put it in wrong, you'll get yellow lights, or if you really have it wrong, the lights will be red. but maybe this person's confused. So they put it, the faceplate, right on top where the canal's now sticking up in the air. Do you see it? The canals are sticking up in the air. They're not in the well at all. You guys see? What's it doing? It's still charging. This is why this is my favorite charger in the world. I can't get it to go red. So even if your patient does it wrong, it still works. I love this charger. I love this charger. The only time I had problems with this charger is when they wasn't plugged in the right way. And I'm amazed it's still working so securely. I have it plugged into my computer. You want to use the brick and the cable that it comes with because it regulates the voltage on the charger, and make sure it's plugged into the wall or it's securely plugged in. If they're having weird charging issues, lots of times they're not using the plug and the cable that it came with. So I like to label it. Like, you know, those little stickers that you label charts with that you have in the office, just like a little colored sticker. I'll put a little colored sticker or flag on the wire and on the brick before I dispense it out, just so they know what cable and brick came with their hearing aids and they don't get it confused. Because the wire, the white wire and brick look the same for everybody, just so they know which one and they don't confuse it. But you can't get it wrong. It's the easiest charger ever. And it's perfect for the patients because they can't mess it up. So I love this one. It fits in the ear. It's going to be recessed in the ear. We're going to make it as small as we can. It depends on the ear though. I mean, if they've got no canal, it's going to all be in the concha bowl. So we'll make it as small as we can, but it's not going to be a CIC. Canal, half shell, or ITE. Those are your sizes. AX also comes in the pure. So you can get the RICs as well. And they're available in 7, 5s, and 3s. The RICs are available either in the AX or the TAX. I'm going to make your life simple. Go with the TAX. This is the good tax. T for telecoil. Remember TAX, tax, the good tax. Why do you want the good tax? Look at that battery life. Same price. You can either have 28 hours or 39 hours. The difference is the width of a dime. Go with the TAX. You get a telecoil and you get 10 more hours of battery life. Go with the TAX. And with the TAX, it fits better in the charger. You also have a cross option with the AX as well. Here's the cross. We do skewed directionality with our cross. This is what makes all the difference in the world. So when you're in noise, they feel like the cross doesn't shut off because on that transmitter side, it's skewed rather than frontal focus. So they always feel like they have input on that cross side. Here's your chargers. You can even have a charger that disinfects on the AX line. It'll disinfect, it'll dry it out, and it'll charge it up. You can have a portable charger or you can have a standard charger. They're all in the back. Come visit me and Mel. We'll show you them. Our app is a one app, does it all. So Signia app, it's for every instrument, whether it has Bluetooth or not. If it has Bluetooth, you have face mask mode. We have Signia Assistant, make changes when they're not even with you, so they can make adjustments to their hearing aids. The app can do directionality, change volume. New thing on the app, they can now change the volume to be separate volume controls, right and left, or a single volume control that the patient could do themselves now. And we have our experience technology as well that have BTEs, a superpower, 80 peak gain. Oh, I'm sorry, 82 peak gain for 61 hours of battery life. And here's our earbud design. looks like an earbud, but it's a real hearing aid. So if you want something to compete with over the counter, this is it. It's called an Active. Come back and see me and Melanie. We'll show you it. And we got the stiletto. So we've got a lot of options, including your Instant Fit CIC. So come see us. We got a lot to offer you. That's it. Thank you. I'll take my hearing aids and go home now. Thank you. Oh, I can unmic that. I know.
Okay. Which one? Well, actually, we'll just put it on the desktop.
It's my favorite
because,
charger.
copy.
How did you show and tell?
Testing 1, 2. Testing 1, 2. Up. This is good. So,
All right, so this is yours right here.
yes.
Do you want to be here or the lava? Oh, you got that.
Lovely. Yes, thank you. I move a lot.
You're
I'm mobile.
You're fine all the way around here. You see that?
Okay.
Okay. You good?
Yep. Thank you very much. Thank you.
Our next speaker today from Oticon is Dr. Carla Quinones. She is the Mid-Atlantic Training Manager for Oticon, responsible for continuing education and new education of the hearing care professionals down through her territory.
All right, thank you, Sharon. Hi, everybody. Good morning. My name is Carla Quinones. I am the new education and training specialist with Oticon for the Mid-Atlantic region. However, I am not new to Oticon. I'm just new to the East Coast. I previously worked with Oticon and our pediatric team in the Midwest region. So I was Chicago-based, and then life brought us to good old Philadelphia. So it's great to be with all of you here today. I am joined today, Doug Beck also works with Oticon in our organization, and Donna Grant. Her information is also located up here. Donna is the account manager serving New Jersey and also parts of Pennsylvania. So certainly, when you have some time, please come back, get to know us. I'd love to get to know you. As again, I am, newer to the East Coast. So today, I'm really excited to talk about what's new with Oticon More. We want to give your patients even more options on this amazing platform that we released in early January. Since the launch of Oticon More, this has really taken the industry by storm. And having been at Oticon previously, Open was really what I thought the pinnacle of hearing technology, but oh man, we did it again. And with Oticon More, what we have found is that not only are new users kind of experiencing more sounds around in their environment and seeing those benefits in real time, but also those experienced users that are even upgrading from our previous technology are noticing how much more information they're able to get. But it's not bothersome. Something that was shared with me recently that was so impactful was a patient sharing, "I'm aware of a lot more, but it's not bothersome." And that was huge to hear, not bothersome. He was able to go into environments that he had been in previously with his Open S's and was doing well,
But then when he upgraded to Oticon More, he goes, wow, there's so many more sounds in the environment. What we have found is that an amazing 8 out of 10 people prefer the sound quality of Oticon More. And we'll get into a little bit of the research that we've conducted. With Oticon More, we're utilizing a new and novel approach to tackle speech and noise. Oticon has been really steadfast in regards to developing technology that helps our patients with the most common problem. And as we just learned, hearing and noise is always the #1 kind of patient complaint. With Open, we introduced Open Sound Navigator. And the way that we've built upon that with More is that we're utilizing a deep learning kind of network that allows us to be really precise about when we're reducing noise in complex environments. With More Sound Intelligence, we utilize an onboard deep neural network that was trained with 12 million real-world sound scenes. And it learns the way that our brain learns through repeated exposure. And what this deep learning allows our system to do is sift through huge data packets and look at those patterns within patterns to make determinations of when it's going to be reducing that noise in complex environments. And what this gives patients is a very precise and balanced and contrasted sound scene. So now I understand why that patient was saying, it's not bothersome. I'm hearing a lot more, but it's not irritating. It's not this wall of sound that I used to experience before I wore hearing aids. So this deep onboard neural network, and the reason I say it's on board, it's because it's not a cloud-based system where it goes up into the sky and gets analyzed and then comes back to the hearing aid. It's something that's on each hearing aid that goes out our door. So every patient can take advantage of this deep neural network, regardless of what performance level you're in a More product. The magic behind this is the Polaris platform. Oticon develops our platforms from the ground up, meaning that we don't source our platforms and then try to include all the features that we want. And what this gives us is creative agency to be able to really add the features that we know are going to help our patients the most. And the goal, of course, is giving them not only good hearing in simple situations, but also those complex situations. As I mentioned before, Oticon More is preferred by 8 out of 10 people. And why do you think I'm harping on that? Wouldn't you be glad if 8 out of 10 of your patients didn't bring back their hearing aids? That they were really satisfied with the sound quality? When we looked at competitive studies specifically, we wanted to compare how Oticon More compared to two top competitors in the market. And we wanted to look at sound quality because we know that that's such an important facet of keeping the hearing aids and not being sent back or not being kept in the drawer. So this is a summary, if you will, of the 3 competitive studies that we performed. We wanted to look at sound quality, how much speech information was Oticon More able to provide compared to those 2 other competitors, and how quickly was those features that are intended to help our patients in noise able to respond in complex and dynamic environments. And what we found is that, again, 8 out of 10 people preferred that sound quality of Oticon More in complex environments and also under face mask condition, which is still very relevant to today's situation. In addition, we found that Oticon More was able to provide 20% more speech information based on the Speech Intelligibility Index, not only for target speakers to the front, but target speakers from the side. We moved from directionality a long time ago with Open. And what we've built upon that with More is, again, utilizing that deep neural network. And the emphasis really here is that we are wanting to provide a whole holistic view of what that environment is. And if we're able to provide more speech awareness to our patients, that's more that they could do with that information. And last but not least, Oticon More was able to adapt 2 to 3 times faster in complex environments. And that's what makes the difference between listening effort and then our patients engaging or not engaging. More sound intelligence reacted and stabilized within an order of 7 seconds once it entered a complex environment, whereas competitor A and competitor B took respectively 15 and 22 seconds to stabilize in a complex environment utilizing traditional directionality and noise reduction. If you ask me, 15 and 22 seconds respectively is a very long time when we consider running speech in these environments. This did skip a slide. However, I do want to say that if you come over and visit us, I will show you some of the research that we did with the sound quality study, in that not only was Oticon More chosen in a cafe and in a restaurant environment, but also under a face mask condition when fit with everyday first fit. So it wasn't a special face mask program. In fact, we don't even have one, because we are confident that the technology in Oticon More is able to still provide your patient the benefit even when the speaker is utilizing a face mask. So come over and visit me if you're interested in that. So what's new? What can you offer your patients now that we've expanded our Oticon More line? We are introducing a new mini right T. This new mini right T gives you the versatility of utilizing disposable batteries. So there are certain patients for which rechargeability maybe wasn't an attractive option. Honestly, I don't know why, but we need options, right? And so with this new mini right T style, we bring to you all the great technology that was available in the mini right R. However, they can utilize those 312 disposable batteries. In addition, we now have our portable smart charger solution. This smart charger solution works with Oticon More rechargeable devices. And the amazing thing about it is that it does have a built-in power bank. So it stores up to 3 complete charges based on 4 hours of charging the smart charger. And with the smart charger, our engineers were super clever and realized, oh, our induction charging produces heat. And when you utilize a smart charger with the lid closed, what it allows us to do is remove moisture from the hearing aids as well. There's no brick or desiccant that you have to change. It's automatic. In addition, we have expanded our cross portfolio, and we now bring to you a cross rechargeable device. So this is the new Cross PX that's going to be utilizing that more sound intelligence to clean up the signal prior to being sent to the receiver or the hearing aid on the better side. Not only do we have new hardware, we also have new software enhancements to really drive that efficiency in clinic, with the goal being that we want you to spend more time in front of your patient and less time behind your screen. I don't know about you, I'm pretty burnt out on virtual. So if I could spend more time in front of people like yourselves, I'm all the happier. Oh, well, they're located here. So apologies for that. So this is that sound quality study that I had mentioned previously. So as you can see here, Oticon More was the chosen manufacturer in regards to sound quality in a cafe and restaurant environment, keeping in mind that these participants were blinded. So they did not have awareness of which device they were listening to. But what you can see is overwhelmingly, Oticon More was chosen as the preferred device. And this is our face mask condition. So this was a male speaker who was utilizing a typical surgical mask. And what we wanted to look at was what was the preferred sound quality for Oticon More in this condition. And again, keep in mind, this is not a special face mask program. This is everyday first fit with premium devices compared amongst 2 other top competitors. Overwhelmingly, Oticon More was chosen as the device of preferred sound quality. So why is this important to you? Your patients are going to be interacting, even though I know New Jersey doesn't have a mask mandate, but they, coming back. But what we'll find is that you're able to have patients really just go out in their environment and not have to manipulate anything on their hearing aids to give them that benefit when interacting with individuals with face masks. So the key takeaway is that there's a significant preference for Oticon More sound quality, and this was seen across different listening environments. So looking at some of the practicalities of our new Mini Rate T, it comes in all the performance levels. So it comes in the More 1, More 2, and More 3. It does have a telecoil, just like the Mini Rate R, as we know that some patients are still looking for that solution. It utilizes 312 disposable batteries, and it has that proven Oticon More technology inside, namely More Sound Intelligence. It will fit a wide variety of hearing losses. You could fit it anywhere from more mild to up to a severe hearing loss, of course, utilizing our power custom mold. But you have a ton of flexibility with either the Mini Rate R or the Mini Rate T, no matter who walks into your door. Something that is new that we've not had previously is a new microshell. So the new microshell is a completely embedded receiver option for non-power users. So previously, we only had a completely embedded receiver option for power users, but this new microshell option is available with an 85 receiver and then a 60 receiver coming soon. It is acoustically equal to other custom molds. However, it is a completely embedded option. So when you're recommending this option, a few key things to keep in mind is that you're not able to change out that speaker wire in the office. So that's absolutely something that you want to counsel your patients on. But the convenience of it is that it fits really nicely into the ear canal. So if someone's very concerned about cosmetics, this is a great solution for them as it does fit nice and deep into the ear canal. So I'm really excited to talk about our Cross PX. So in 2018, we introduced our Cross technology, and I was so excited because Oticon never had a Cross before. It was kind of a new world for us. And then the very first question I got is it rechargeable? Well, it wasn't. However, I'm excited to share that now it is rechargeable. So you really have two Cross options now from Oticon. With our new rechargeable Cross PX, this gives your patients a full day of power. What does that mean? We are saying 18 hours of use based on one single charge. So to charge the Cross PX, it takes approximately 3 hours, and that will give your patient that 18 hours of daily use. So that's pretty remarkable for a Cross device, wouldn't you say? It's going to give your patients that exceptional sound quality, and it has unparalleled compatibility as it is both forwards and backwards compatible. So it's not just simply can only connect with More. If you had a patient in an Open S rechargeable and they've been waiting out for this Cross rechargeable option, hallelujah, we got an option for you. So to keep it simple, you have your Cross PX, which is your rechargeable device, and then your Cross, which is a disposable battery device. So that one utilizes a 312 disposable battery. One of the key things about our Cross solution is that it does utilize our two-way radio system that we term Twin Link. And what this allows us to do is cross that signal over via near field magnetic induction. As we just learned, near field magnetic induction is excellent for ear-to-ear communication, as it does allow us to be conservative with the battery life. So that is going to give your patients that full day use. And the benefit to having that dual system is that they're able to receive a streaming signal simultaneous to their Cross being active. Some solutions out there, you have to have the Cross deactivated to be able to stream, but this ability gives your patients kind of that flexibility of both. We do have a study that we looked at the benefit of having the transmitter on versus off when someone was utilizing a Connect clip. And what we found is that we were able to provide 50% more speech awareness when that transmitter was on, simultaneous with running speech from the Connect clip. If you happen to work with any pediatric patients and are brave enough to recommend a cross solution, this is a huge advantage as they're still able to get their EduMic signal or Connect Clip signal in the classroom and still hear their peers around them. But even for your adults, perhaps in a meeting situation such as this, they're able to still get that that Bluetooth signal to their better ear and still able to hear their colleagues around them via that cross transmitter being active. As I mentioned previously, it is both forwards and backwards compatible, either of the models. And so what you'll see here, these are all the product families that work with either of our cross solutions. Now, keep in mind, this does require a firmware update. I know that's not everyone's favorite thing to do. However, I'm excited to share that with more, you can do wireless firmware updates via the NOAA Link Wireless. So it should only take about 2 minutes of your time, which is a big deal. And then for any of the existing products, you might want to dust off a few of those cables, but thankfully we've now entered the wireless era of audiology in that regard. So with the Cross PX, you can fit it with any of the product families with the exception of the Open S3 or the Open Play 2. So those are the only 2 devices that won't work with our cross solution, but otherwise you have lots of options available for you. And our new smart charger. So the smart charger, as you can see here, you can come back and take a look at it. It's a clever little device. It does have the kind of convenience that your patients are looking for. So maybe they don't want to be tethered, or maybe now they're getting back on an airplane and starting to travel and kind of want that convenience of on the go. Or if they're, in the field like us or a rep and drive around all the time, then this is a really nice, convenient option for them. You can charge it either via USB or through a wall adapter. So you do have that flexibility in there as well. And we brought you a lid. We have heard you loud and clear that you would like a lid on your chargers. So with this new lid, not only does it give your patients that kind of safety net for their devices to stay in there, but also it does allow us to remove that moisture from the devices when that lid is closed, again, because we utilize that heat that's dissipated from that induction charging. So again, clever little device. The desktop charger is still going to be the primary charger that goes out with the hearing aids. So it's not to say that the smart charger replaces that desktop charger. So it's really meant to be as an added on accessory. And now you're able to order it for anybody that is in a More device that is interested in a smart charger option. So looking at a few of the highlights here about our smart charger, it's going to be 3 hours to fully charge those hearing aids or that cross in the smart charger. It does give you that capability of that power bank, so you can do 3 charges on the go. There are 3 LED lights that are located on the back of the smart charger to indicate to your patient how many charges are left. As they go through their charge cycles, those lights will successively go down to 2 and then 1, and then blink orange when they need to plug it in again. So it's a clever little device. I so wish I had this on my AirPods. It would take a lot of the guesswork out. But it is a really kind of easy accessory to utilize. Of course, when you open up the lid and you remove the hearing aids, it's an auto start on. So it's simple for your patients to just take them out and move on with their day. With Oticon More, we bring you some enhanced connectivity. So we do now have direct streaming capability with Android devices that do have that ASHA protocol. We do have a wonderful website, oticon.com/support/compatibility. I highly recommend that you save it as one of your bookmarks in your web browser. It is a living, breathing list. We update it frequently with new phones, or if we identify an issue with a particular phone, we indicate that information as well. So I don't recommend printing it out and giving it to your patient because it may very well change in the next hour or even in the next day. So something good to have handy on your internet browser. It is also compatible with all the following accessories that you see here. And then, of course, it is made for iPhones. So you could utilize it with your iDevices. So we have just a few fitting tools that we've added into Genie to, again, really drive that efficiency in clinic. The goal being that we want to make things efficient for you and easy to work with. So one of those new additions, and I can't really say new because we used to have it previously, is Fitting Assistant. So in the original version of Genie, we had Fitting Assistant. When we came out with Genie 2, it seemingly vanished overnight. And then people said, why'd you get away with that? And I don't know. But we've brought it back, and it's a really nice tool to be able to have after you've taken all of your typical troubleshooting steps and are still not able to resolve the patient's complaints. So where that's going to be located is going to be under Fitting, More Tools, Fitting Assistant. And then here you could see that there's 5 topics to choose from. And those 5 topics do get pretty specific, as you can see here. So you can see that the selected topic here was loudness, and then this was environmental sound. So you can get really, really detailed into what you're trying to chase after. So here it's the crinkling of paper or clinking of silverware is too loud. I have absolutely heard that before. And what Genie will recommend is a solution depending upon, again, what that specific complaint is. So here it's recommending to decrease the gain for moderate and loud inputs, and then it has an additional solution if this solution was not able to completely resolve the patient's complaints. But let's say you apply the solution and the patient says, I don't know what you did, but I hate it. That's okay. You have an undo button. So you can just undo the recommended solution that you just applied. It's not going to undo your programming, of course. However, it's just going to undo that recent action that you did with the Fitting Assistant. So it's something to try. And now you do have that available under More Tools. If any of you are utilizing our remote care, which is a great advantage if you're doing, any telehealth, we do have 2 new updates. One being that you can do cross and bi-cross fittings with our new remote care option. So if your patient, for example, were to lose their cross device, what you can have them do is stop by the clinic, pick one up at the front office. With the cross, it is a close proximity pairing. So as long as the hearing aid and the cross are within 7 inches of each other, they will recognize each other. And what you're able to do is start a remote care session that your patient is sitting at home, and then you're able to essentially program them both from afar. So this is a really nice advantage. In addition, you now have in situ audiometry available via remote care. This, of course, does not replace your diagnostic hearing test. However, can be a great tool to have for remote care, particularly if the patient is concerned that perhaps their hearing thresholds have decreased, or review ruled out that the hearing aid is not what's causing the patient's issue. This is also excellent for your patients with existing fluctuating hearing losses. You're many years patients. You know that their hearing thresholds are going to change likely over time. And if they are established patients and are aware of that, you could start a remote care session with them, assess their audiometry via in situ audiometry, and then you're able to really kind of make adjustments on the go. Last but not least, we introduced a new way to manage bone conduction thresholds. And a lot of people have been very excited about this change because it's going to make it a lot easier to manage those bone conduction ear bone gap compensations that the Genie software prescribes. What you're able to do now is that you're actually able to choose to include or exclude those bone conduction ear bone gap compensations off one single button. So you no longer have to remove the bone conduction thresholds from your audiogram, especially if you have a system that's like integrated. So for example, NOAA or Cycle or any of those. What you're able to do now is go under your selection, audiogram, and then choose to include or exclude those bone conduction values to again make it a lot easier for you to be able to manage those depending on the individual patient. So today we learned about how there's a strong preference for Oticon More in regards to sound quality against those 2 top competitors. We explored more fitting options. So now we have that Cross PX. We also have that Mini Right T to give you that flexibility. So that really gives you more freedom for you and your patients. So thank you so much for inviting Oticon to be part of your day today. It is lovely to get to meet all of you in person. And please stop by the booth so you can get to know us a little bit more. Thanks so much. I think I grabbed all my stuff. Okay.
Thanks.
Thank you. Oh, hang on.
Okay. This is Signia. Oh, here it is. Okay, Widex, and then let's share it.
Move it up a little bit. There we go.
Okay. Good.
I think so.
Okay, and to round out our morning before lunch, we have Dr. Cassie Fuller from Widex. Cassie has been training for Widex for quite a long time, and she has a lot of experience in multiple clinical settings and training hearing care professionals and combining technology with patient needs. So here we go.
Okay, thank you very much. Hey, everybody. How's everybody doing? I promise, going last right before lunch is very challenging, so I will not go over, I promise you this. But my name is Cassie Fuller. I'm an audiologist and clinical product specialist with Widex. I'm here in the back with Michael Steinman. So we're very happy to be here. If you all don't know Michael, you will get to know him today, I'm sure. But a little bit about me, because I don't know that I know everybody here, and I know there's a lot of people zooming in. But I am a New York transplant, so I live in upstate New York. But I actually also come from the Midwest, so I'm from the Chicago area. I'm actually going back home tomorrow. I haven't seen my family in a very long time, so I get to spend the next week there with them. But very happy to be serving the East Coast here. I've got all of New York State, all of New Jersey, and then Western Connecticut and Western Massachusetts. So I'm just traveling all over the East Coast. I am, a little bit about me, a little bit of personal things. I am a coffee enthusiast, which is a nice way of saying I am a coffee snob. So drink it all day. It's my favorite thing. I go to bed every night excited to wake up every morning to have a cup of coffee. I am a dog mom to my rescue Piper. So Piper is my pride and joy. She'll be turning 10 soon. So I've had her for 9 years. I got her while I was in graduate school. And when I'm not an audiologist, I'm a runner. So currently training for like my 15th marathon. So I'll be doing Big Sur in the spring. So that's a little bit about me. Before we kind of get into product and what makes Widex and what makes us a little bit different, I kind of want to talk about our patients a little bit rather than focusing so much on product and what we have to offer. And if you take a look at what our patients are afraid of, what health things our patients are afraid of, 5 things typically come up. Diabetes, heart disease, stroke, cancer, all things that impact just about everybody, it's something definitely to fear. It's something life-threatening. But more than any other life-threatening disease, our patients fear Alzheimer's and cognitive decline. They fear this more than any life-threatening disease that's out there. And there's some things that we can do to protect against Alzheimer's and cognitive decline. One of which is exercise. So keeping a healthy body can help us maintain a healthy brain over time. Diet is going to make a big impact. That old saying, garbage in, garbage out, making sure we're eating the right things, eating the good things, limiting the bad things. Sleep is really important. This is one of the most important things you can do for your body, is making sure we get good, adequate sleep. It helps the body repair and restore itself. Mental stimulation is also really important to maintaining a healthy brain, making sure that we're reading, we're doing puzzles, but really social contacts is a really important piece of this as well. There's actually evidence out there that shows that mental stimulation and social interaction are two of the biggest factors in preventing cognitive decline. And that's because having that social interaction is engaging a lot of the parts of the brain. It's, we're having to use working memory, we're having to use, executive functioning. Our brain is really having to engage a lot. So these two are tied very well, very strongly together. And we know as hearing care providers that hearing loss of any kind tends to limit that social interaction. Now, there's a big correlation between filling in the gaps and having hearing loss. Our patients out there are having to do a lot more work when it comes to socializing. They spend a lot of time listening a lot harder, putting a lot of listening effort. They're focusing much more intensely. A lot of my patients, a lot of our patients, I should say, when we see them, they say, when someone starts talking to me, I miss the first thing they said. And then by the time I figure out the first thing they said, I miss the second thing they said. So they're having to focus a lot harder on conversation. They're having to rely on a lot of visual cues. And a lot of times when this just gets too cumbersome, they just avoid adverse listening situations completely, which we know is a very negative thing. That's taking away from that social interaction. That's preventing that thing that they fear the most, that cognitive decline. And we know that there's a very strong correlation between hearing loss and cognitive decline. Even with a mild hearing loss, you are 2 times more likely to develop dementia. As that hearing loss increases, we see that chance of developing dementia increases exponentially. Now, I want to talk about this really cool study that was done. So this study was done by Dr. Anu Sharma out of the University of Colorado Boulder. And what she did is she took a group of participants with a mild hearing loss. And what's interesting is if you take a look at the study, actually most of the people she recruited didn't even know that they had hearing loss. And what she did is she took a measurement of their brain's response to sound. Now, she took that measurement by way of EEG. And that's what you see up here. This is the results that she got. And there's a couple of remarkable things about these results. Number one is the shape of this plot. So we know that hearing happens in the auditory cortex, right, in the temporal lobe. Patients with a mild hearing loss, their brain is changing because of that mild hearing loss. Their brain is having to reach more into the frontal lobe to help them hear, even just with a mild hearing loss. Now, what she did after she took these EEG results is she ran through a battery of tests. She ran them through speech and noise testing, global cognitive functioning, executive functioning, looking at visual processing, really global cognitive tests to see how this could be impacting other areas of the brain. And what she found is that the more that the brain is reaching into that frontal lobe to compensate for that mild hearing loss, the poorer patients do on all these tests. The poorer they perform in speech and noise, but the poorer they perform in visual working memory, executive functioning, all these different cognitive processes. So after she took those measurements, she didn't just stop right there. She said, what do we do if we put hearing aids on these patients? So she put hearing aids on these patients. Each patient was fit with hearing aids and they were told to wear them full time every day for 6 months. And after 6 months, she had them come back into her office and she reran all those tests. And when she ran that EEG, this is what she got. After 6 months of consistent hearing aid use, those patients had reversed their brain back to what a normal brain would look like. It made a huge difference in the way that their brain behaved. Now, if you're comparing these two pictures, the before and after, there's a couple of things that you recognize. Not only the shape is different, now we're not having to compensate with that frontal lobe. It's also the color. So you see in the before, there's mostly reds, blacks, oranges, those darker colors. That indicates that there's a very low correlation of neural stimulation. You can see in the after using hearing aids for 6 months consistently, we've got a very high correlation. You're seeing a lot of whites and yellows. That means that brain is really responding well to that sound. This is also correlated with better cognitive functioning. So she reran all those cognitive tests on those patients. And they did better at unaided speech and noise. They also did better at global cognitive functioning, executive functioning, visual working memory, processing speed. It really made a global change to their entire brain. So now we can really see that if we treat that hearing loss, we could potentially offset that cognitive decline that could happen in the future. Now, knowing this information, that the number one thing our patients are afraid of is called cognitive decline. We know that with a hearing loss, you are more likely to experience some cognitive decline. We know that if we wear hearing aids, that could potentially reverse that experience. Should be easy to get everybody to walk out the door with a set of hearing aids, right? Of course, we know that's not how it is. That's not how it goes ever. There's some challenges of hearing aids. And when I think about it, there's primarily 3 challenges. Number 1 is sound quality. We have to provide a sound quality that people like to listen to. If a patient doesn't like the sound quality of their hearing aid, it's going to be sitting in their nightstand drawer. They're going to be back at your office returning those hearing aids. So we have to give them something pleasant to listen to. We also have to have a good cortical response. The brain has to be able to understand the signal very well. If we want to reduce listening effort, we really have to give the brain something that it can actually understand. And we also have to encourage participation. This is a really important part of our job. Success with a hearing aid isn't necessarily measured by getting a patient with binaural hearing aids, fitting them to target, putting them in the booth and running speech and noise testing and sending them out the door. We have to get our patients to participate in their lives again. We have to try our best to allow our patients to live the life they had before they had hearing loss. And that's going to be a big impact on their life in the future, because we know that participation, that social interaction is really important for their brain's health in the long run. So that brings us to the Moment platform. When we've developed this platform, we've had this idea in mind of not only providing a sound quality that is great, but also making sure that it's something that the brain can understand, and to get our patients to participate in their lives again. So this is a schematic of the average hearing aid you can get on the market. You can see this is the pathway that sound takes. So sound is picked up at the microphones. It goes to the A to D converter where it's translated into a digital signal. It goes to that digital signal processor where that signal is processed and amplified. Goes to the digital to analog converter, and then out the receiver down the ear canal to the TM. This process is a lot of work. And this work is going to take time. And the time it takes a hearing aid to do all this work is what we call delay. Now, there's been tons of research in delay, but all of this research has really been based off of how much delay is acceptable, because delay is an inevitable thing. No matter what, that hearing aid is going to take some time to process sound. And what we know from this research is that every hearing aid in the industry has to process at 10 milliseconds or less, because once we hit this 10 millisecond threshold, it's going to be unbearable to listen to. It's very robotic, it's very artificial sounding, it's annoying, and it's going to start interfering with speech understanding. But even if we half that processing speed, even if we have a processing speed of 5 milliseconds, you can actually hear an audible echo. So what we've done on this platform is we've actually created 2 digital signal processors in one single device. So what we've done is we've built our WideX Classic engine. So this is our engine that's been built upon our legacy that we've built over the last 60 years in bringing the best sound quality, the widest sound window, making sure that our patients have access to soft sounds, but also access to loud sounds without distorting them. So we have our classic engine there for our WideX loyalists. But what we've also done is we've created the first hearing aid with a second digital signal processor with our zero delay engine. And what's significant about this zero delay engine is that it's significantly faster in processing speed. And we've done this because we've recognized that processing speed is a very important piece to making sound quality natural. So not only have we made our WideX Classic engine the fastest engine in the industry, we've taken that one step further and making the zero delay engine even faster. Because we know that some patients can really benefit from faster processing. And it's good to have 2 separate digital signal processors because every patient that comes into our office, we can't necessarily treat them the same. Up until now, we had this one pathway for sound to travel, regardless of hearing loss. If you had a patient with a mild hearing loss versus a patient with a severe hearing loss, you're using the same digital signal processing, but that's not necessarily going to benefit those patients the same. So now you have some options. We've created a hearing aid that's specific for each of these patients. So that brings me to Pure Sound, which is powered by that zero delay engine. Now, when it comes to processing speed, if you kind of look at the industry standards, the gold standard for processing speed is right in this 5 to 8 millisecond range. That's what all other manufacturers are performing at. But that's right in that echo threshold. That's right where you're still getting an audible echo. With our classic pathway, we've sped that processing up to 2.5 milliseconds. So we're twice as fast as everybody else when it comes to the time it takes our hearing aid to process speed or process sound. Our zero delay engine, however, is taking that one step further, and it's processing sound at 0.5 milliseconds. So it's virtually taking no time at all to process that sound. Now, why are we able to do this? It's because we fundamentally treat sound different than every other manufacturer. We treat sound different right from the very beginning at the level of our microphones and A to D converters. Every hearing aid in the industry processes sound in 2 domains, frequency and intensity. But at WideX, we've always considered the time domain as well. We're also considering time. And it's because we're considering that time domain that we're able to make a faster hearing aid. What's interesting is that we're not the only ones interested in time delay. If you look at the cochlear implant industry, they're really considering that very much as well, because they found that it's really beneficial for bimodal patients to match the cochlear implant speed or the cochlear implant delay to the hearing aid delay. So what they've done is they've done the research, they did their homework, they understood the assignment, and they looked at every manufacturer's processing speed and published it to their website. So if you're ever interested in looking at what the average processing speed of the hearing aids that you're choosing, it's their public information. Now, you may be asking yourself, why does this matter? Why does processing speed really make a big difference? If we've been performing at this level or at this processing speed for so long, why is this an important thing to consider? Well, it's all because of the comb filter effect. So for example, if you think about the development of a RIC hearing aid, the RIC hearing aid was able to check a lot of boxes, right? We're able to give the patient a hearing aid that's cosmetically appealing. It's very discreet, small. It's packed with a lot of features, so we don't have to sacrifice very much. And we can open up the ear canal a little bit more to make a patient a lot more comfortable. But in opening up that ear canal, we really introduced a whole new problem with the comb filter effect. And essentially what this is where we've got sound, natural sound coming into the ear, going past the dome or through the vent and traveling down the canal to the TM. At the same time, we've got that sound hitting the microphones, being processed by the hearing aid, coming out the receiver and traveling down the canal a few milliseconds after that natural sound. Now, because that natural sound and amplified sound are mismatched, when those sound waves crash together, it's going to create a really jagged sound wave like what you see right here. It kind of looks like a hair comb. That's where it gets the name comb filter effect. When we get a sound wave that looks like this, that's really jagged, that's noise. It's going to cause a lot of problems. It's not going to give a natural sound to the TM. And if the TM can't pick up a natural sound, do you think the brain's going to be able to make up for that? Yeah. So the comb filter effect is kind of the problem that we didn't know we had because we never had a solution to it. But now we do have a solution to it because if we can process sound at 0.5 milliseconds, there's virtually no timing difference at all, and it eliminates this comb filter effect. So that is how we've introduced Pure Sound. So Pure Sound is going to be the best program for patients that are really fitting in a more mild to moderate region, because those are the patients that we're fitting much more open. Those are the patients that are getting that natural sound. Those are the patients that are experiencing that comb filter effect most frequently. It is preferred not only in our clinical trials, but from what we've seen in the field overwhelmingly. It's been very successful. And it's really been a huge game changer for patients, even if they're experienced hearing aid users, even if they're used to that slower time delay. We've seen an overall preference for that Pure Sound, for that faster processing. Now, I've mentioned that Pure Sound is really the best program for mild to moderate patients. And here's what we've recommended as a fitting range. Pure Sound is available in every single level of technology. So whether you're fitting our highest level of technology at the 440 or our most basic level of technology at the 110, everybody gets access to this ultra fast delay. The good news is that if the patient fits within this recommended fitting range and they've got a RIC or a BTE hearing aid, the software is automatically going to put that Pure Sound program in as a program, so you don't even have to think about that. Of course, you can add Pure Sound in as a program if a patient's falling just outside of the shaded region, and I really do recommend that. Actually, if you look back at all the studies that we've done on Pure Sound, what's interesting is usually about 50% of the ears that we use in our studies fall outside of this fitting range. So there is really good evidence to show that Pure Sound is a good program for really anyone with a more mild to moderate loss. And here's some of the words that patients have used to describe the Pure Sound experience. So I always like to note that you'll see that they say it's much calmer and softer, but we're actually not impacting gain. We're not impacting audibility for speech. It's just calmer and softer because we don't have that comb filter effect to worry about. You know, we don't have that hearing aid sound quality with Pure Sound. It's just calmer because there's less noise. Actually, the first time I wore Pure Sound, when I was first being trained on it, day one, they put the hearing aids on my ears and said, tell me what you think. They didn't tell me a thing about what was going on. They were just, tell me what you think. And at first I thought they were off because I didn't hear that rushing, that hearing aid sound quality, that shh noise that I typically hear when I listen to a hearing aid. I just noticed that it was much calmer. It sounded much more natural. And it wasn't until one of my colleagues started talking to me that I realized, oh, her voice is amplified. I can hear her nice and clear. So it's almost a bizarre experience. It's not what you expect to hear with a hearing aid. You'll also notice that they say, I have a better own voice quality. Own voice is something that we almost always have to cancel out on, right? We have to say, oh, give it some time, read out loud to yourself for 20 minutes a day. It's something you'll get used to. But that's something that we're not really experiencing with Pure Sound. Patients are just really easily adapting to that faster processing. It makes those patients that are new to amplification It makes that adaptation period very seamless. And it's not because we're doing any own voice processing. We're actually just pushing that sound through much faster. And that is just a great byproduct of a faster processing speed. Now, we've said that it's really important to make sure that patients are, they have a sound quality that they like. You have to be able to listen to that sound all day to really like it and be successful. And overall, I know we've only got about 13 minutes left, so I'm going to fly through a little bit of this because I want to make sure everybody gets to lunch on time. But we've done a lot of survey studies because survey studies are really important to consider. We want to make sure that our patients are doing well with our hearing aids because that means that your patients will do well with their hearing aids. And that is going to be a strong indicator that those patients are going to keep those hearing aids. Like I said earlier, we can put a patient in the booth and test them and prove to them that they are performing better in background noise, but that doesn't mean anything if they don't like it. It's not necessarily a real world experience. We need to send the patients out into the real world and get their actual reactions. And so what we've done is we've done a global study. We've done a number of global studies looking at pure sound and at moment in general, using that universal program. And we compared their own hearing aids, so whether that be a Widex hearing aid or any other major manufacturer, to the moment platform. And overwhelmingly, everyone really prefers the natural sound quality of moment, particularly with pure sound. Over 4 times as many wearers strongly agree that the sound is much more natural. They also noted that their own voice sounds more natural, which, like I said, is a great byproduct of that faster processing. But more importantly, 10 times as many were very satisfied with their performance in background noise. And as we've said, as every manufacturer has said today, background noise is still the #1 complaint of our patients. That's where we need to perform our best. And the preference for the moment platform is unmatched. Now, if you think a couple slides back, when I identified the 3 big challenges with hearing aids, sound quality, we need to make sure we're encouraging participation, but a good cortical response is really important as well. And so this is a study that we did looking at the brain's response to sound listening through a hearing aid. Now, the way we measured this is we took a group of participants with a mild loss. So we're not working with normal ears here, we're working with patients with hearing loss. And we took an EEG of their brain's response to sound listening through different hearing aids. And there's a portion of an EEG called an envelope following response, or an EFR. And that EFR looks exactly like the stimulus that's coming into the ear. So this black line here at the top, this is the sound da, over and over again, da, 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 da. And we took the brain's response to that sound, took a measurement of it. And the response to pure sound is here in the blue. Now, there's a couple of things that are remarkable about this response. #1 is the amplitude. So you can see we've got a nice and robust amplitude across the board. It's really looking a lot like the stimulus. And that amplitude means that we've got a good, strong neural coordination. That brain is really syncing together to get that sound to the auditory cortex. The second thing that you really notice about the response from pure sound is the timing. So you can see that the peaks and the troughs of that EFR listening through pure sound is really identical to the peaks and troughs of the signal. What this really suggests is that providing a sound that can get to the ear faster, making sure that we have a much faster processing speed, gives the brain something natural that it can understand. It can more easily interpret because we have less distortion at the level of the eardrum. And that can make a big difference on listening effort. Listening effort is something all of our patients experience. It takes a lot more effort when you have hearing loss, and it can be quite exhausting. But one way we can lift that effort is by providing a much more natural sound. Now, you'll see the pink and the green. Those are 2 of our competitors' hearing aids with a much slower processing speed. And you can see at the beginning Looks pretty great. Looks just like pure sound, right? But over time, you can see that EFR response really flattens out quite a bit. The amplitude is not as robust, and the timing kind of gets off track, which really suggests that a slower hearing aid processing is going to take more listening effort over time. Kind of going back to this survey study. So this is looking at the Moment platform as a whole, not just looking at pure sound, but also looking at that universal program. And you can see that patients are more satisfied with the Moment compared to their own hearing aids. What's interesting about this study is we do this over a long period of time, over a period of about 2 months. And that first, we have the patient kind of rate their own satisfaction with their hearing aids over a 2-week period. Then we put them in Moment for 2 weeks and rate their experience. Then we have them go back to their own hearing aids for a couple of weeks. And then we go back to Moment for a couple of weeks. And what's interesting about this study is you can see at the beginning when they're rating their own hearing aid, they're pretty satisfied with their performance with their own hearing aid. But after experiencing Moment, they're more satisfied with the Moment platform. But what's interesting to me is that when we have them go back to their own hearing aids, they're actually less satisfied with their own hearing aids after they've had the Moment for a couple of weeks. So I think that really kind of shows us that we don't always know what we've got until we experience it. But more important than this is this graphic here on the right, participation in daily life. I'll say it over and over and over again. The one thing that we really need to give our patients is that social connection. That's what we should be measuring our success on. How our patients feel they can participate in their lives. How our patients feel that they're not missing a beat. And you can see here that patients feel like they can participate in their life much more when they're wearing a Moment hearing aid. Now, I just kind of want to wrap up with a couple of the updates. I know I've kind of gone very research heavy, but we do have some very exciting updates that we've introduced this fall and coming into this winter. So it really further makes Moment a great choice. One of which is our Android. So we did release a firmware update a couple of months ago now. That firmware update actually goes directly through the Moment app. So patients don't have to come into your office. That app can be uploaded at home. It'll automatically push that firmware update. So there's no wires involved. The patient doesn't have to come into the office. You don't have to waste a slot or an appointment slot to upgrade firmware. Of course, you can update it through the software if you choose to, but I actually find it's easier to update it through the app. If you update it through the software, it takes about 3, 4, maybe 5 minutes. But if you're on the app, I time myself every time we have a firmware update because I'm a total nerd. And it takes about 2.5 minutes to update the firmware through the app itself. So it's what I recommend doing. But we do now have Android streaming available. So we've always been able to stream from iPhone, but now we have the flexibility of streaming through that NJAHHP protocol. So we've got all the compatible phones on our website. Currently, it's more of your Samsungs and Google Pixels and OnePlus phones, but it is a living document. It is growing day by day as we're testing phones and making sure that they're stable and the sound quality is great. Actually, I was very lucky. I'm an iPhone person myself, but I was very lucky to be able to get an Android phone from Widex. And like I said, I'm a runner. I'm a long distance runner. I spend a lot of time out in nature, just kind of running for hours and hours and hours. And I'm a streamer. I outrun my AirPods. So I don't really use my AirPods when I'm running because the battery's going to die and then I'm going to be bored for a couple of hours. So I usually put my hearing aids in my ears and stream that way while I'm running. So I've done a lot of practice streaming from Android, and I've got to say the streaming sound quality is amazing. It's actually got me cheating on my iPhone so that now I'm grabbing my Android as I'm going out for my runs over my own personal iPhone. Funny enough, just as a side note, Spotify does at the end of the year kind of like your summary. and how frequently you're listening to music and podcasts. I don't know if I should be proud or embarrassed, but I listen to more Spotify than 96% of the US. So I'm in their top 4% of users. That's a lot of streaming with hearing aids. We do also have, that's what you get when you're a long distance runner and you travel for work. So lots of streaming. If anybody wants podcast recommendations, let me know. I've listened to all of them. We do also have an update for Compass GPS. So make sure that when you go into the office on Monday, you are updated to version 4.3. Some of the highlights here, we've got some upgrades with NOAA Link Wireless. So we have been compatible with NOAA Link Wireless on the Moment platform for quite a while. But we've got some upgrades behind the scenes to just help with that stability, and it's much easier to detect. We have some upgrades with Auto REM. So if you're using the Natus Oracle FreeFit, we do have Auto REM available for that. You can match targets in about 1.5 minutes. And then we do have some improvements to sensogram as well. So if you're doing those in situ measurements, just know that the research that we've taken, the data that we've taken has made this process much more accurate so that we get the best fit possible right out of the box. We have also expanded our portfolio. So we do now have a rechargeable BTE available. This is a super cool device. Not only is it a BTE that has a standard hook or options of a slim tube, it's got everything. I mean, this is kind of like the Swiss Army knife of hearing aids. We've got T-coil, Bluetooth, rechargeable. That rechargeable battery is going to work upwards of 37 hours. If you're streaming for 8 hours, you'll still get 24 hours of use. We've got the push button, the rocker switch, and an LED light on this. We've also introduced some improved embedded molds for the version 2 receivers. So these are the receivers for our lithium ion option. So that is all available in this fall, everything you can order right now. So with 1 minute to spare, I just want to thank everybody for having us here. We appreciate all of your support that you give us. And we'll be hanging out at the back in case there's anything you need. Thank you.
Okay, so just for 1 second before lunch, lunches, box lunches across the hall. Looks like there's a lot to choose from 12 to 12:45. At 12:45, Jordan, who is our new IHS governor for the area, is going to give us a little bit of an update, and Doug Beck will be on promptly at 1 and working straight through. We won't have time for a break while Doug is speaking because he has to leave exactly at 3 for a flight. So take your time, decompress, see our manufacturers, and enjoy your lunch.
Should be pretty straightforward. That's great. Then I can put all my junk away now. I'll be right back.
Uh, um, For some reason, this is still running. This,
Click on it, right click it. Go back to that right click.
uh-huh.
And then click close. You can just get rid of it, he's done.
Yeah, I know. That's why I was trying to put it in recycle.
Well,
Yeah.
it says it's open, that's why I'm gonna let you do it.
Yeah, I'm just trying to figure out how to,
Yeah, it should be
okay,
closed.
I'll open it and see what happens. Okay, now let's close it. Yep. Okay, so yours. Beck NJ.
Yep.
Okay, and so these other two. Let's see. Don't need that. Chapter.
Yeah, as long as it opens, yeah.
Yep. 21. Okay, so what we decided to do is go off of this entirely, but,
That's it.
so. Major Linux. Okay, so, the only thing is when I was carrying that around, it cut off the, PowerPoint to, let's just open yours up and see if it. Okay. Got it?
2021 chapter.
Oh, yeah, that's IHS. Okay, so there's only two on here now. The one at 12:45. Okay, so this is you, right?
So which one is without the presentation? Yeah, that's good.
Okay,
And have you got a clicker?
I can if you want to walk around you as well.
Yeah, 'cause I'm-
on it,
okay,
that's good.
okay. So, how did you do this slideshow?
Well, I'm gonna do it manually.
Right, right.
But I hit F5 to bring it.
Oh,
full screen.
F5, okay,
From there, I should.
Yeah, you can.
yeah, and I get
I
a
mean,
picture.
best use
Yeah.
same laptop. That's
Yeah, that's fine.
easier.
Yeah, okay, great.
I'm gonna control it manually. Some of them I'll have up for 5 seconds.
Yeah,
Also, if you want to put everything on mute until And
If I want to
which
what?
is first presentation? Who's next?
This one.
Yeah, put him up.
Okay. All right,
And you can
so,
leave, also just minimize it.
okay, so 12:45. Yep. Mhm.
Or they can go after me.
He's right over there, so you can just talk to Jordan. We can, yeah. It's gotta be, he's gotta be done. Right, right. Yep.
Carl, I don't have control on the microphone. You have this one, right? And also I don't see this camera.
Okay, so that's what it got knocked out. Can you help me fix that?
Yeah, let's see.
Hey, Carol, are you there or are you taking a break?
That's right. And then did you hear about the child who died on Easton, just 2 blocks away from me this morning, in a house fire? Yes. Yes, right between Reimer and Union, there's 4 houses there by the, yes. 2 o'clock this morning, the mother is still at Robert Wood. The older daughter, who's 9, is at St. Barnabas Burn Unit. The boyfriend, I don't know what happened.
There. So I just pause it.
The darn laptop. I clicked something and I don't know.
Oh my God. Oh my God. True, this one, up, down. Good. I cannot make this full screen. How can I do that?
How one of these?
Like if I click down, see?
That's minimum.
Right. Even smaller, and this one is that.
What if you right click on it?
So this what I have. So Rachel.
Well, that's just the camera. Kat.
Okay.
You won't see that full screen. That's just the camera. That's just the camera.
Are telling I'm out?
people at home can't see I mean, the presentation.
Anything. Okay, so that means I'm out, right?
You don't. No, you must be in.
In Zoom, but I don't see it.
Yeah, I don't either.
So we have signed in. Enter your email. Carl, I need your help here. Your information.
It's not, it wasn't my account.
No, you can't put her. You got to put that number in. Join the meeting.
I forget which email address we used. Did you use yours?
Use mine,
Use yours.
but I don't have a password though
Or your Zoom account?
for the sign in. But you
I can't remember what we signed in, how we signed in.
849.
But that's the email.
No,
Hold on
no.
a second.
This is the meeting ID.
Wait a second. Hold on a second. Before we do join meeting.
You cannot join me.
Okay, because why? Wait a second. You're in the meeting. Oh, you're just attendee? Who are you? Is this a different laptop?
No, the same one. Check if she gave me right. Anyway.
She's got a great job.
Yes. But I don't have controls too. Oh, I have here. Okay.
Yeah, you're good.
Okay, I have there. So I think this is it, right?
Mhm.
How can I move this in bottom instead of top?
What? I have no idea.
Let's see. Do we want?
You have a weird screen here. Change this back. Get out of presenter mode. Wherever that is in the PowerPoint.
Should be on top, but
Go to the triple dots.
and
Hide
show.
presenter view.
I present. Okay.
Okay. Now let's see what you
No, no, but look, this thing here is. Oh, there, it's back.
I leave and I come back, you two have taken something else apart and you've broken something else. No problem.
No, we mean it.
Test. But you can hear me now, so. So this presentation for now.
Yeah.
and we check. Okay. Very
And
good.
on mine,
It's fine, you know what, I'll just. That's probably what it is.
I used to start talking to
I hope everybody enjoyed their lunch. We're looking at the clock and it's time to start getting going. So, take a minute, get settled, and we'll have Jordan give us some updates on IHS, who has been very busy lately with a lot of governmental affairs in the Medicare bill. And we'll welcome him to New Jersey as our new governor. Give them a minute, so,
Yeah,
I mean,
will.
obviously.
Okay, I'll talk about the least important part of which is about myself first. While everybody comes into the room. This is my first time to New Jersey. I just moved. Someone in the crowd said something like, it's not as bad as everybody says, right? No, it's nice. I'm originally from St. Louis, and I don't know if anybody of you see me around. Oh yeah, boo. Go Cardinals. I just moved. I grew up in St. Louis, though. I've been in the industry for over 15 years. Go Cubs. And I just bought a business for myself out here in the Mid-Atlantic region. So I was the IHS governor there in the central region. And then when I moved over here, it just so happened Patrick Kochanowski became president-elect. So the seat became available. So worked out. So I'm here now as the governor for the central East Coast. So anyway, thank you for having me. I have like 13 minutes to go through a bunch of stuff. So there's no way I'm going to possibly go through all of what's happening with IHS. But I just want you all to know that IHS they do so many different things for us and for all hearing healthcare providers. But especially for hearing instrument specialists, it's the only organization that protects our profession, the only one. And we're going to talk mostly about legislative issues, which right now it's probably at a fever pitch. It's the most I've ever heard about all at once, beginning with Medicare. Can you guys see that? Good way to hide that. Anyway. I could just do that. Okay. So Medicare, I was just talking with Doug. He's going to be on next here. I mean, in a simple sense, they're talking about adding hearing aids to Medicare, and this has always been up, as more of a discussion, or people propose the bill, but it never really gets very far. But right now, with Democrats in the House, and of course, it's very political. It's as close as it's ever been to actually having hearing aid coverage added to Medicare. Some of us thought this would never happen. It still hasn't happened, but it actually is seeming quite likely. So it's something you guys really need to pay attention to. It would dramatically change our industry and profession. I was just talking with Doug too about that. It could be really great or really bad, but I lean towards my personal opinion is probably it's going to be good, but we just need to learn how to approach it. It just needs to pass a simple vote, majority vote in the Senate, and it's added to I think the reconciliation bill. Yeah, the budget reconciliation bill. Let me go to the next slide here. Okay, another thing to know about this is it's one device per ear every 5 years. Okay, so that's another thing to keep in mind. Yeah, of course, it all comes down to money, and even if this gets added, think about how many millions of people are on Medicare, and we already know what the market penetration rate is for people with hearing loss. Most people don't do anything about this. This would just be a giant advertisement, I think, for hearing aids and going in to get a hearing test. So again, we were talking about this. I mean, this changes almost by the minute, all of this information. So this is probably the most current that you can look at, but I'm going to show you guys later some different, go to ihsinfo.org, and there's some other resources. That's really what I'm here just to tell you is to go to ihsinfo.org and keep up with the information. There's also the Hearing Hub where you can find other people speaking about their own opinions as well. Okay. Again, this is all the details. I would be doing Alyssa a disservice if I tried to do this. But here you go. There's action alerts, the bills, all the relevant news. I want to tell you guys, all the staff up at IHS does a wonderful job. They're all top notch. Alyssa Parody, if you guys ever seen her, she's just amazing in what she does. And they really stay on top of all of this. So, look at those email updates that come through, and somewhere in there, there's talking points, or I think maybe it's another slide here, is they will give us talking points whenever it comes up, especially for OTC. We're in the comment period right now, and us as professionals, we need to go to our local officials and they basically have it wrapped up nicely with the bow and tell you what to say and all the details that we need. So we have a unified message going through, because there's a 6-month period, I believe, that now that the rules have been proposed, whoops, don't ahead of myself here. And they're due January 18th. So the board, IHS board, we've been going through this, we've been, throughout the weeknights and everything. And by the way, think I mentioned this is a volunteer position. I'm a business owner during the day for Beltone, but I've been a fitter for over 15 years as well. But we've been talking about it throughout the week, and by this next Wednesday, we're submitting our own comments. And basically, we're going to release that to everybody else so that you can use that too. Okay, we've talked about over the counter quite a bit. It's finally here. So, it's been 4 or 5 years in the making, and it's here. I really don't know where it's going to go. Again, I couldn't tell you about all the specific details. A lot of it has to do with the amplification, the labeling on the products. I know one big thing I can say is the wording of mild to moderate hearing loss and perceived is a big deal. So keep that in mind. That always stuck out for me is labeling it as perceived hearing loss. I think that's pretty important, that should not be on the label. Okay, again, here we go. You have some more information you can find through advocacy. Does anybody have any questions about OTC or Medicare? Yeah, go ahead.
The last meeting I was on, they were talking about Medicare, and I'll try to be really quick. The language, the criteria was for severe to profound hearing losses. Do you know if that language has been adjusted?
I believe it's moderate to.
It went to moderate. Yeah, because they were.
Do you know, Doug?
Do you know?
Okay. Right. Yeah. Thank you. What he said right there. Yeah. It is. It with the. Yeah. Right. So what it's going to look like. You have a question?
Like me, how the states are addressing the potential exemption for pre-action. Yeah, this is a huge issue. The HIA attorneys.
Might as well put it.
All the patients' protection
All those protections the patients have come from you. They're not coming from, Walmart. They're not coming from CVS. They're not coming from Walgreens. So exactly how that's going to be handled, to be determined. This is a very, very important issue. It's referred to as exemption, and every state has its own laws. It has its own rules and regs, and how they're going to work with the federal government, yet to be determined. Not one state has weighed in, to my knowledge, on how they're going to handle any of these issues.
The normal preemption for the states would be if the states actually have their own rules and regulations that are in excess of what the federal is.
It should be, you would think intuitively that's correct. But then you had the waiver. Remember the federal waiver? Well, that went away within 30 days, right? But every state, to the best of my knowledge, still has a waiver. So these are very important issues. All of them have been asked. None of them have been finalized.
Historically, I wonder about the industry when these kind of things are being advertised to the public. In years gone by, when a president got a hearing aid, it brought the industry up. When a president talked about getting free hearing aids, it brought the industry down to the point until somebody realized that we're not going to get free hearing aids. People were not buying hearing aids, were not pursuing it because they thought that in a short period of time, the government's going to provide it. And that didn't happen. And as a result, the providers had to put up with that for, 1 to 2 to 3 or 4 years.
Well, 2021 has been the busiest year for hearing aids in the history of the world. We've sold more hearing aids in the USA in 2021 than we have previously. So there are certainly niches where what you're saying is true, but across the nation, it's gone the other way. And most of the sales have been really doing amazingly well. So again, nobody's got any of these things solved. And you have to understand that IHS, as well as AAA, ASHA, ADA, HLAA, all, everybody is looking for answers. And, when we wrote that consensus document in 2018, we being all the audiology and hearing aid professionals, we got no response from that. We also got no response when HIA wrote the original documents saying that OTC might not be such a good idea. We wrote that in 2016. And there was no response to that either. So my thought, as somebody who's been involved in the legislation of this for all these years now, I'm not so enthusiastic that they're going to actually define these things or clarify these things. I think that what they may do is drop their best guess at how to do this, which will become law, and then the states have to deal with it. That could happen. Again, I don't know any more than anybody else does about it. There's nothing final.
So on the New Jersey Licensing Board, which has been general information to us from our DAG, is that their interpretation at the moment that was last given, evolving, quicksand, is that we are to stand down on over the counter. We do not have regulatory authority over unlicensed practice. And as such, it's the wild, wild west again. And I've been practicing, I've been around since the 70s, practicing with Cy Libby. So like Pete, we go back to Never, Never Land. And this is, watch what you pray for.
Yeah.
This is not.
It does seem like it's going backwards.
It's totally going backwards.
Yeah.
But the only thing I would encourage us to look at, if it's an encouragement at all, is if they put through a benefit that you can take to licensed practices, that would be the federal moderate to severe hearing loss. As long as we have inclusion in that, and furthermore, that we look at the two-tiered system that exists with over-the-counter, and or if they do provide a low benefit, so it'll be essentially an over-the-counter type model that they'll pay for. There's a lot of healthcare systems that do that, but people opt out to go buy something good.
Yep.
This is kind of a universal truth. Mike Valente and Amina Milani wrote this article December 2017 in the Otolaryngology Head and Neck Surgery, the flagship journal for the American Academy of Otolaryngology Head and Neck Surgery. And they pointed out the uptake of hearing aids where they are free. The UK, the entire Western EU, New Zealand, Australia, where hearing aids are free, only 42% of people bother. 58% of all people say, no, that's okay, I'm good. So it's not like everybody wants them or needs them. I think, you know, Chip's point is well taken. And where this is going to go, we don't know. In the US, by the way, the uptake, we are the most expensive place in the world to get hearing aids, is 32%. And when Dr. Amlani wrote that article with Dr. Valente, he said, you know, even if they were free in the USA, it wouldn't impact the sales very much, because we're almost at the same penetration rate as countries where it's free. And by the way, our satisfaction with hearing care professionals involved hovers, you know, 88 to 92, 93%. Patients really, really like us. You know what the satisfaction rate is where you have OTC like Japan? Like 20, 25%. But we made all these arguments in 2016, 17, 18, 19, 20, and 21. So you know, we can only say it so many times. We can only provide the peer-reviewed literature on this so many times. They don't seem, see, I don't want to put my personal bias in. I don't want to say they're not interested in our thoughts, but they haven't reacted to them. How's that?
Yeah. But I guess I'm stating the obvious here, and I'm speaking to the crowd. You all care. You're all here, so you're those who truly care about the profession industry. But if you know anybody, you know, just make sure everybody is aware that IHS is here to support you. And, you know, IHS works with all the other industry groups that Doug's involved with. So donations, become a member. You know, I'm here to advocate for that. It really does matter. Your dollars go to a really just cause, and it couldn't go to a better team there. And just real quick, I'm going to touch on a few other things. I'm going to let Doug talk here. There's the new apprenticeship program. I don't know that much about it, but it's been in the works for a while. I think Minnesota is where they had the first program that they're going to start working on, but it's Department of Labor. So you can go to ihsinfo.org and this link down here. ILE, so, you know, IHS is involved with providing the international licensing exam, the written. They are in the works of doing one for the practical as well, but it's not ready right now. But there's a test prep course. It's really nice. It's worth taking. So if you have anybody who's getting licensed and they need to practice for the exam, this is a really great tool. There's a third edition of the trainer manual. This is a really nice thing that goes along with the distance learning course. So again, if anybody's getting licensed and needs to be trained, this is a step-by-step process, week by week, to make sure you're hitting all the points, checking all the boxes, make sure that they have a complete knowledge of the profession and should be able to pass the written and the practical. And then IHS helps manage NBCHIS, and it's confusing. We have all these acronyms. They used to be one organization, then they split up, and now they're back kind of together. But anyway, it's kind of having a resurgence. If you aren't board certified, you should get it. It is. We have some great tools for you. You can have this new digital embedded. I don't know what you call it, a little emblem or whatever you can put on your email or any kind of digital marketing, and people click on it and it ensures the accreditation, just things like that. But it's the only other thing that we can have for a hearing instrument specialist within, you know, other than audiologist here. So if you have any questions, you can go to nbc-his.com. And then this is new, the American Cochlear Implant Alliance. You can have one free year membership along with IHS. There's more. She gave me 18 slides for 15 minutes. So this is another nice thing. If you're a member, you get access to this right here. It's for insurance and compliance, and it's very technical. I was in on some of these meetings. Samantha Sikorsky really helped out tremendously with this. She knows everything about how to bill for insurance and HBMs and managed care and all of that. So it's a really nice guide. If you have anybody yourself or anybody working in your organization might need that. All right, that's it. Thank you.
Now this is going to take about the next half hour. Doug gave me his bio. Dr. Beck began his career in Los Angeles at the House Ear Institute in cochlear implant research and intraoperative cranial nerve monitoring. By 1988, he was the director of audiology at St. Louis University. In 1996, he co-founded a multi-office dispensing practice in St. Louis. In 1999, he became president and editor-in-chief of audiologyonline.com, speechpathology.com, and healthyhearing.com. Dr. Beck joined Oticon in 2005. From 2008 through 15, he was served as web content editor for the American Academy of Audiology. In 2016, he also became senior editor for clinical research at the Hearing Review and also adjunct clinical professor of communication disorders and sciences at NJAHHP. In 2019, he was appointed vice president of academic sciences at Oticon. Dr. Beck is among the most prolific authors in audiology with more than 208 publications. Please welcome Dr. Douglas Beck.
Thank you very much. Should be there and there. Okay. So you know what? I'm going to improve the signal to noise ratio by turning on my microphone. Okay, can you guys hear me? Am I on? All right. So first of all, thank you, Ed. What a joy to be here. The last time I was here, we had this hellacious snowstorm, and I had a flight about an hour and a half away. And I think when I went out at lunch, it was a sunny day. Everything was good. I went out after my lecture. There was like 5 inches of ice. So I went south to Philly instead of going up to Newark. And I'm on the phone with United, and they said, okay, well, there's a flight in about 40 minutes out of Philly. And I said, oh yeah, I'm only like 2 miles away. I didn't make the flight, you know. Anyway, so I am vice president of academic sciences at Oticon, been there 17 years. I am an adjunct professor at State University of New York at Buffalo. I've been with the Hearing Review for 817 years. All of those things that I do are free except Oticon. I'm a salaried employee, right? So I get a salary from Oticon. All these other things that I do in audiology are freebies, including all those commissions for the FTC, the FDA, and what I would refer to. See, I don't want to be belligerent or nasty, but boy, oh boy, those guys really have screwed stuff up. None of us were opposed to OTC. None of us, not ASHA, not AAA, not IHS. We all said, you know, if you do this reasonably and rationally, it could be a good thing. Reasonably and rationally. Okay, so what we're going to talk about is 3 subjects today: cognition and audition. We're going to talk about deep neural networks, and we're going to talk about speech and noise tests. How many of you do speech and noise testing? Just, okay, well, about 3 or 4 people. Okay, so we're going to talk about that. I want to start with cognition because we heard a little bit this morning about some aspects of cognition and how that interacts with auditory phenomena. So I'm going to tell you, this is a paper I published about a year and a half ago through the British Society of Audiology. I was on a committee there. It's called a SIG, Special Interest Group on Cognition and Audition. And we worked together for 3 or 4 years, 5 years. Then we started publishing papers. This is peer reviewed. This is the Journal of Otolaryngology, ENT Research. Any of these papers that I'm mentioning, by the way, you can get them from my colleague Donna in the back. Just sign up and she will put you on the list and send you these. Or you can go to douglaslbeck.com. They're all available there, okay? They're all free. And you can use them for whatever you want. You have my permission as the author, as the senior author on any of these papers. You can give them to patients, you can give them to your colleagues, to professionals, give them to whoever you don't like and has a sleeping disorder. Maybe they'll fall asleep. So hearing loss and cognition, a discussion for audiologists and hearing care professionals. And we covered a couple of things in this paper. Number one, let's be real clear on cognitive decline. Cognitive decline is a normal process associated with aging. You will slow down. Not me, but everybody else will. And I will continue to talk this fast into my 70s, 80s, and 90s. I was raised in New York City. That's how we do it. So, you know, and telling somebody slow down, that's like saying, oh yeah, well, why don't you talk without an accent? Your accent bothers me. I know. I have all kinds of degrees in hearing and processing. I know, but this is the way I talk. So, you know, so if you're having trouble, let me tell you what you should be telling your patients. Please sit closer. It makes it much easier for you to visualize. And when you have the visual redundancy with the auditory cues, it makes it really easy. And further, when you speak rapidly, think about Martin Short, think about Robin Williams, think about Jonathan Winters. Remember those guys? They all talk really, really. So why do they do that? Why do you think? Because you have to pay attention. You can't get the joke if you're not paying attention. You can't follow the conversation. You know, so they force you by speaking really rapidly to pay attention. Now you could zone out. You zone out on people who speak slowly too. But I've studied a lot of courses on how to present, and one of the things is you have to grab their attention. One of the ways to grab the attention is, you know, to start speaking with an accent makes it a little bit more tricky, but then they have to really pay attention. Yeah, see. So what we're going to do, talk about these things. So cognitive decline, the National Institutes of Health will tell you normal aging process. So when we talk about cognitive decline, that in and of itself is not very unusual. It's normal. Okay, you got to know that. But dementia describes things like memory, which is not functioning as it might be, or recognition, or things like that. So it's various symptoms. Forgetfulness, dementia is not a single disease. You could have a gazillion types of dementia. In fact, the medical books in the USA describe over 200 types. The one you're most familiar with is Alzheimer's. It's good you're sitting down because I'm going to tell you your chance of having Alzheimer's. Does anybody know by the time you're 80 to 85, what's your chance of having Alzheimer's? 10%, and we're talking about in the USA. 40%. Yeah, it's between 35 and 40. So this is really important because that means, you know, about 3 out of 10 of us, maybe 4 out of 10 of us in this room, by the time you're 80 to 85, Alzheimer's. How many dementias did I say there are? 200. You have stuff like frontotemporal dementia, you have, you know, Alzheimer's, you have a bunch, most of which you've never heard of. And the reason is because they're really small. They don't happen a lot. But Alzheimer's is the biggest. And Alzheimer's doesn't happen quickly. It takes 20 or 30 years from the time amyloid plaques and tau proteins start to build up in your brain and really cause dysfunctional brain processing and anatomic changes in the brain. But your brain, because it's plastic, you have 100 billion neurons. But you have 100 trillion synapses. So once that information is stored in your brain, there's a gazillion ways to get to it. So after 20 or 30 years of having Alzheimer's disease, you start to manifest those signs and symptoms. You can't hide them anymore. You can't access all the information in your brain because those 100 trillion neurons have decreased substantially. And they've slowed down through cognitive decline. And so taking a pill or putting on a hearing aid to change the course of cognitive decline, not so likely. What is very likely is that when you put on a hearing aid, you improve somebody's ability to communicate. So this is, you know, in 1999, the National Council of Aging published 2,000 people who had hearing loss and got hearing aids. And they had 2,000 people who had hearing loss and didn't get hearing aids. The people who wore hearing aids, less stress, less anxiety, less depression, better socialization, and they were more content. That's not because we changed them cognitively. It's because they could communicate. So they didn't socially isolate. Because they could communicate, they weren't so depressed. Because they could communicate, they weren't so anxious. So cognitive decline happens. But can you change that with a hearing aid? And the answer is maybe. We don't really know. The big study that's really looking at this using science, a control group versus an experimental group, is the ACHIEVE study coming out of Johns Hopkins. That'll come out in 2023. We were hoping 22, but I spoke to the epidemiologist, Jennifer Deal, who's running that study. And she said because of COVID, they weren't able to get everything they needed, but they do have 900 people in the study. So when it's published in 2023, it will be fairly conclusive that hearing aids did change or did not change the trajectory of the patient's cognitive and social and healthful life. Right now, we just have snippets here and there. We have some good anecdotal reports. I'll share some of those with you, but that's not the answer because most of them don't involve a control group. Excuse me, the importance of a control group is, I used to use this one with my students all the time. I would say, I could prove to you that milk causes cancer. Yeah, well, everybody who has cancer drank milk. You see, there's no control group. So that's totally bogus, right? But people will do this. They'll say, well, with tinnitus, you know, Rich was talking this morning, lipoflavonoids. Yeah, no, the lipoflavonoids, you know what that is? That's an orange peel. That's a lime peel. But, you know, it's placebo, but some people believe it. Some people believe milk causes cancer. Some people believe that if you eat enough grapefruits, you'll get taller, you'll get shorter, you'll get fatter, you'll get thin. But and everybody has, well, you know, I had 3 patients with tinnitus and they all started eating Raisin Bran cereal and all of their tinnitus went away. Seriously, that's the best you got. I mean, you know, this is not science. These are called anecdotal reports. That doesn't make it true. And it doesn't even make it true for the person who reported it. It means somebody noticed something, which is good. You should notice stuff, but it doesn't mean that it's science. And science, just to be clear, never ends. There is no solved science. Science evolves. You know, the planet is round. We have gravity. You know, yes, we do. And every year we learn more about gravity. We learn more about the trajectory of the universe. And you know, you can't even imagine the ignorance we had when we went to the moon in 1969. I actually met Buzz Aldrin a few years ago, and I had a conversation with him. And he was so startled at how things had evolved. I had one of those goofy digital watches where the numbers like, and he looked at my watch and he said, Doug, your wristwatch had more computing power than we had on the whole lunar landing module. I mean, think about that, right? So we had these genius analog systems that were absolutely brilliant, but there was nothing digital on it. And when the controls jammed on Apollo 13, Buzz Aldrin took a pen and he stuck it into the thing and moved it that way. And that was why they were able to propel themselves off the moon. I mean, so anyway, so that's pretty good science, but it evolves. You know, when you go and you see these billionaires that rocket themselves into space for 12 to know 25% in the USA over age 65 have mild cognitive impairment. So this is why I'm a big advocate for cognitive screening. Because you get a patient with mild to moderate sensory neural high frequency loss, 45 dB of hearing loss, 88% discrim, 84% in the other ear. You have no idea if they have any sort of dementia, mild cognitive impairment, early Alzheimer's. You have no idea. And these aren't silos. They could absolutely have mild to moderate sensory neural high frequency loss, and they could have traumatic brain injury, and they could have mild cognitive impairment. And if you don't think that that's possible, here's how you get supra-threshold listening disorders. You have to understand that in the USA, there's 325 million people. That's really important to know. Of those 325, 37 to 38 million have hearing loss on an audiogram. Not 45, not 60. When people tell you that they're smoking dope, they're doing, I don't know what they're doing. But those numbers aren't right. I'm giving you the numbers from the CDC, the NIH, AAA, ASHA, and IHS. It's 37 to 38 million people have hearing loss on an audiogram, but there's another 26 million people in the USA who have no hearing loss on an audiogram at all, but they have ADD, ADHD, dyslexia, neurocognitive disorders. They have auditory processing disorders, auditory neuropathy spectrum disorder. They have cochlear synaptopathy, hidden hearing loss, traumatic brain injury. They have Alzheimer's. They have cognitive decline. They have dementia. They have mild cognitive impairment. So there's 13 off the top of my head. And these are the people who often will come to see us, no hearing loss. And so what we do, right, is generally we say, oh, sit closer, better lighting, and pay more attention, which is totally bogus, because you know what IHS says you should be doing? And so does AAA, and so does ASHA. Every single patient, every single time. Right? We should be doing airborne speech impedance, all that typical clinical stuff. But you should also be doing, you know, a listening or communication assessment. That tells you whether the patient needs hearing aid, not their pure tones. Pure tones don't make the decision who needs hearing aids and who does not. It gives you a lot of information. I'm not dissing audiograms, but I'm saying that is not how IHS or AAA or ASHA makes a decision as to who needs hearing aids. That's on communication and listening assessments in combination with history, in combination with the diagnostic information. And then from there, we're supposed to do a speech and noise test. We are. It's not even ambiguous. It's very clearly written. And in the IHS guidelines, I think they mentioned 4 different, and they just do something like these or similar. And then we're supposed to do real ear when we fit hearing aids. Now, close your eyes. If your eyes are open, I'll call on you. Works every time. Raise your hand if you do real ear every patient every time, and hands down, eyes open. So 4 of you do it. The rest of you are actually guessing because you have no idea what the sound pressure level is in that ear canal. You just don't. You could say you do. You could say, oh, my patients love me. But it's really clear that your best practice statement says you should do it. And the reason it says you should do it is because you can't guess. Here's the thing. All hearing aids are built to a 2cc coupler. Right? So you get 30 dB of gain on your first fit. It looks great. Patient loves it. Everything's hunky-dory. Well, the thing is, your patient's ear canal might be 1.3. So instead of the 2.0 that the hearing aid was calibrated on, the 30 dB gain you thought, you're giving him 44. Noise-induced hearing loss, acoustic trauma, all kinds of problems that you open yourself up to lawsuits. Or conversely, patient returns the hearing aid and said, but you said, oh, but it's perfect. It's first fit. It's exactly where it's supposed to be. But the patient's ear canal was 2.7. So instead of the 30 dB gain you thought you were giving him or her, turns out you were only giving him 22, which wasn't enough, frustrating, so he returned the hearing aids. There's no way for you to know the amount of sound pressure that you're delivering to the ear without real ear, which is why IHS and AAA and national say to do it, but only 3 people in this room, 4 people in this room do it. So what that means is most of us are practicing differently. So, so we have an issue because the patients are paying us. I don't care if they pay $50 or $5,000. I don't care. Not my point. My point is we're being paid to be, board certified IHS members, to be board certified AAA members, to be doctors, to be dispensers, to be audiologists, to be hearing care providers. We're being paid to do that. Who said it's okay to take shortcuts? Would you go see, let me ask you a question. So would you go see a dentist if you knew that that dentist did not follow the American Dental Association guidelines? And particularly now, you need a root canal. Are you going to go see the dentist that's not? No, you're not. So if you need to go see an OBGYN, do you want to see the one that's following or not following the guidelines of the American Obstetrics Association? So you've got a migraine and you're going to go see a neurologist, but you're a neurologist. My patients love me. He tells everybody that. The only thing is he doesn't follow the guidelines of the American Neurological Association. You want to see him for your migraine? Which surgeon do you want to see? But yet, most of us do not follow best practices. It's not, you can't make up your own best practices. These are nationally derived from subject matter experts based on the peer-reviewed literature. We know how to fit hearing aids. And it is a bit of art and science. The art is all your humanity stuff. It's how you relate to people. Some people are really, really good at that. So maybe their technical knowledge isn't good, but they're very successful because they relate really well to people, and people like that. And there's certainly science. I mean, we know how to fit hearing aids acoustically. We've known that for 40 years. There's not much new in how to fit a hearing aid acoustically. But what we know now is that hearing is just perceiving or detecting sound. That is not the end. That's step one. Listening is the end. Listening is making sense of sound. Listening is comprehending sound. Listening is untangling the neural code. And the patients come to see you primarily because of speech and noise disorders, suprathreshold listening disorders. They don't really come to see you because they need the world louder. And in fact, think about this. When patients come to see you and you make the world louder, they go out to a restaurant with their significant other and they say, well, I was at the restaurant, I couldn't really understand what people were saying, so I did what? Took them out. Yeah, they took them out. And did they hear better or worse when they took them out? Better. They tell you this all the time. Do you think that they are all liars? No, I don't think so either. So why do they hear better when they take them out? Because they're concentrating more on looking for the visual cues. That could be, what do you think? Yeah, a lot of perceive. Okay, so here's what we do with hearing aid fittings. Think about this. We go directional, 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 beamforming, beamforming, beamforming. And then we go compress, compress, compress. So we took away all the dynamics. We took away the real world acoustics. In fact, if Ed is speaking from into my right ear from 1 meter away, and he's just reciting the alphabet, if you think of the spectral response at 5, 6, 7,000 hertz, my right ear and my left ear, what do you think the difference is between my right and left ear? 5, 6, 7,000 hertz. What do you think? Wild guess. 4 to 6 dB. At 5, 6, 7,000 hertz, it's actually 20 to 22 dB. Yeah, that's cue number one to understand speech and noise. You need 2 ears. You can't do this test hardly at all in a cocktail party, restaurant, something like that, with only 1 ear. That's why, sudden sensory neural loss, unilateral hearing loss, 1 dead ear, they're very, very difficult because no matter what you do, all the processing is going to be done in the better ear. And for you to make sense of sound, assuming you have 2 ears that work, your brain is constantly comparing and contrasting the loudness, not just the loudness. What I just demonstrated with Ed is interaural loudness differences. People think of the head transfer effect, the head shadow effect as 3, 4, 5, 6 dB. That may be true RMS, root mean squared, the total sound. But in the most important sounds, 5, 6, 7,000 hertz, it's 20 to 22 dB of difference. If your hearing aid's not maintaining interaural loudness differences, you're giving them the same signal to each ear, so your brain's got nothing to process. Those differences are huge. Now, you also have interaural timing differences. So when Ed is speaking in my right ear, it's also hitting my right ear a couple of milliseconds before my left. All these cues tell my brain where to pay attention. That's how I do with speech and noise. And then I can depend on a really good noise circuit, really good signal to noise ratio and stuff like that. But if all you've got is directional, 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 beamforming, beamforming, so you're shooting this little tiny beam of sound at the brain. which is kind of backwards because we know that the entire brain is involved in processing sound. We all learned, you have these air molecules out here. They tickle your tympanic membrane, malleus incus stapes, oval window, and then the basilar membrane, the fluids, the endolymph, paralymph, moving the outer hair cells, wiggling around to the inner hair cells, and then it goes to the synapse, to the 8th nerve, lateral lemniscus, medial geniculate, inferior colliculus, and when you think about like the inferior colliculus, right? That's auditory. Yeah, we know that. But the superior is visual. So all of this visual and audition and tactile and smell and taste, well, not smell actually, smell goes directly to the brain. It doesn't go through the thalamus, everything else does. So all of this interaction between all these sensory systems, that's how you understand speech and noise. It's pretty miraculous that it even works right on anybody because it's very intricate. And we don't even know half of it yet. We've been studying it for 100, 150 years, but it's very intense. And it gets even more intense when you look at it closely. So the point is that hearing is just perceiving sound, right? You can tell there's a click. Listening is much more important. I mean, you have to have hearing or there's no listening. Of course, hearing is the foundation upon which listening is built. But if there's no hearing, there can't be any listening, but just providing hearing, that ain't enough. That's not going to help. You have lots of people with good thresholds. How many did I say? 26 million in the USA who can't make sense out of sound, but they have no hearing loss. That's why IHS, AAA, ASHA all say you have to do a speech and noise test. That's the only way you're going to find them. Otherwise, you're going to counsel them to sit closer, better lighting, and you have no idea what their speech and noise ability is. They're telling you my speech and noise is terrible. So it takes 2 minutes to test it. That's why you should test it. So can we measure cognition? Because I said, it's really important for me to know if I've got a mild to moderate loss, 40, 45 dB, everything makes sense audiologically, and the patient is 68 years of age, I want to do a cognitive screening in 2021 because I want to know, are they performing within normal limits on a screening test? If they are, go ahead and do what you're going to do. If they're not, go ahead and do what you're going to do, but refer them back and say to the physician, hey, listen, as you know, I saw Mrs. Smith. She's 72 years of age, mild to moderate sensory neural loss. We fit her with hearing aids. Her speech and noise score improved dramatically. However, she did not pass the cognitive screening. Therefore, we're referring back to you for further guidance. That's called patient-centered care. Now, I know some of you are audiologists, most of you are dispensers. I don't know if you can do this. This gets back to Chip's point earlier about tinnitus and stuff. You got to follow your state regulations. I don't know. I'm not licensed in Jersey. I was when I lived here, but I don't live here anymore. So, these are, and we have to always push the borders, but you don't push them beyond your license. When I started intraoperative cranial nerve monitoring in 1983 or 84, audiologists didn't typically do that. I was in the operating room every day, and I did over 1,000 acoustic neuromas at the House Ear Institute over about a 4.5-year period of time. That's when I wrote the book, The Handbook of Intraoperative Monitoring. Most audiologists saying, whoa, what are you doing? In fact, Jim Jerger didn't like that I was in the operating room. So, but it turns out AAA and ASHA both said neurophysiologic, monitoring diagnosis. I mean, we do electroneuronography, we do ECOGs, we do auditory brainstem response. So I'm just doing those in the operating room, But so there's that. Jim Jerger was also opposed to us being involved with tinnitus. And he used to say, or vestibular studies. And he would say that's not really within, so it's changed. It's the same with dispensers, that some of you do cerumen management, but it has to be based on your state law. And what Chip's point earlier, well, it doesn't say you can or you can't. So you have to be very respectful of that because if it's a gray area, you have to be careful and you should not be blazing a trail that you can't cover yourself on. That's my advice. But I want to say one other thing. When we talk about my licensure doesn't mention it, I have news for you. My licensure doesn't say I can't do coronary artery bypass surgery, but we kind of all know I can't. Right? So if I go up and did I do your coronary artery bypass? Yeah. So if I go out and do that, my defense cannot be, well, it's not my license. That's not a very strong leg to stand on. Chip. Real loud, because we're trying to, right. Right. Void. Right. Absolutely. So you have to practice within your scope of practice. There's no other option. But that doesn't mean you shouldn't push the envelope forward professionally. In California, I testified about 4 months ago for their California Board of Hearing Arts, I think it's called, the ones up in Sacramento that run speech language pathology, hearing aid, and audiology licensure. And I was brought in for testimony on should audiologists be allowed to do cognitive screening. And they had 3 days of testimony from audiologists, from neurologists, from speech language pathologists, from psychologists, from educators and others. And at the end, the state of California said, we don't see a problem here. They didn't say, yes, you can do it. They didn't say, no, you can't do it. The question came to them because an audiologist said, hey, you know, I've read a lot of papers on this. Here they are. And 2 or 3 of my papers were listed. And they said, are we allowed to do this? Which is exactly the right way to handle it. And let the state decide. And they did. They said they don't see that it's a problem because they looked at the AAA scope of practice. They looked at the ASHA scope of practice. They looked at their own state laws and they resolved that it was okay. They didn't underscore, yes, you should do it. They didn't say, no, you can't do it. But, you know, you can't do tympanograms poorly. If you hurt somebody while doing a tympanogram, even though it's covered, you're going to get sued, right? So you practice within your scope of practice. I'm telling you things about cognition, just like if I were a physician here telling you about tympanoplasty. You don't get to do a tympanoplasty unless your license says you can. So I'm going to tell you about cognition so you're aware of where it is. And if you're interested, I would bring it to the authorities and I would say, this is really interesting. We'd like to be able to do this. How do we make sure it's okay? Is that fair? Okay. So number one about cognitive diagnostic tests is you can't thoroughly or accurately measure human cognition. Now, all of these quotes that I'm showing you came from this article. Okay, so this is one of the articles that we're happy to send you. If you want to take a picture of it, you can just Google it and find it. It'll come up. It's no charge. And then cognitive abilities cannot be directly observed. They must be inferred. So this is really important. Any cognitive test you take does not tell us what your cognitive ability is. It tells us kind of sort of where you are. The ability to predict overall cognitive ability based on a specific sub-skill, like a reflex test or a type A TIMP or something like that, no, that just tells you the result of that one test at that one moment in time. You heard about this study earlier today from the Journal of the American Medical Association by Frank Lin and at Johns Hopkins and his colleagues. So they took about 2,000 folks with no hearing impairment. They did the modified mini mental state exam, which is a cognitive screener. And they said 1,100 of these people had hearing loss greater than 25 dB, 822 were within normal limits. 6 years later, the people with hearing loss declined on the mini mental state exam. So this is kind of the point, is that we absolutely know, I feel very confident saying this, and I know I'm being recorded, hearing loss exacerbates cognitive decline. Hearing loss exacerbates cognitive decline. I feel very comfortable saying that. I've got at least 15 or 20 peer-reviewed articles that I'll be happy to share with you. What we don't know is what happens when you put a hearing aid on them. Do we impact their cognitive abilities? Now, I'll show you some pilot studies that indicate, yes, this is a very good thing, but you have to understand these are pilot studies. We do not have final, clear, peer-reviewed science. That will be 2023 when the ACHIEVE study comes out of Hopkins. So you saw this earlier today. The rate of cognitive decline and the risk of cognitive impairment were linearly associated with the severity of hearing loss. I just want to correct something that was said earlier today. You can't say that people with mild loss have twice the amount of dementia, or moderate is 3 times or severe is 4. Those are for big, giant groups. Those are studies of populations. Those are not studies of individuals. You each have people that you know in their 70s, 80s, 90s have no cognitive decline whatsoever, and they have absolutely terrible hearing. And so this is a very important point. When you're looking at these giant studies, these are studies looking at populations. They are not looking at individuals. And so you have to be aware of this, because I could say in general, men are taller than women, and nobody would argue the point. Everybody would say, yeah, that's generally true. But there's certainly women in this room who are taller than some men in this room. So that's the problem with group statistics versus individual facts. So everybody in this room knows men are generally taller than women, but there are many women in this room and many men in this room that violate that general hypothesis, which we know to be true. It's just not true for individuals. So hearing loss is independently associated with accelerated cognitive decline and cognitive impairment among community-dwelling adults. what effect does hearing loss have on cognitive performance? Even, so you know those categories we all use, 0 to 25 is normal, 26 to 40 mild, 41 to 70 moderate, et cetera. Those are not scientific categories, you know this. These are categories of convenience. So we talk to patients, we use those categories, but they're not scientific. In fact, there's no difference at all between somebody with a PTA of 24 and a PTA of 26. Although one is normal, one is mild. They're really the same because you're taking 5 and 10 dB steps, Houston-Westlake protocol, so your average error, the standard error is going to be 7 or 8 dB. So the person with 23 dB hearing loss could come in next week and have 27 and really nothing's changed. Maybe they're happier, maybe they had more caffeine, maybe they're not as tired, maybe they're not as bored, maybe, you know, but that doesn't mean there's been a change in their audiology. I mean, when we're looking for a shift in thresholds, we're generally looking for 15 dB or more at 2 or 3 consecutive frequencies, right? But these guys were studying, if you take patients with 0 dB thresholds and people with 24, 25 dB, even though we'd all consider them normal, their point is, as you went from 0 to 25, your score on your cognitive screening decreased. So these tests are fairly sensitive, and the hearing loss categories are fairly insensitive, is the point they're making. As hearing ability decreases within normal limits from excellent, like 0 or -5, to normal, which is perhaps 24 or 25, measurable aspects of cognition decrease. So cognition is a really big factor, as is speech and noise. And in fact, there are new studies that have come out in the last 24 months showing that when somebody has a particularly decreased speech and noise ability, it could be an indicator of cognitive decline or perhaps dementia. And these studies are very important because you're already supposed to be doing speech and noise. But we don't. I know only about 15% of us do it. So this is Dr. Gaeta's work, and this is in the Journal of the American Medical Association in 2019, saying that as hearing decreases from excellent to normal, you also get decreases in mini mental state exam. Dr. Amiva in 2015 looked at over 3,000 people, and she was looking at hearing aids. And she said, well, what's the impact of hearing aids? Now, there's a couple of problems with the study. Number one, she didn't do any hearing tests. So you got 3,670 people, and what they did to see which group you're in, hearing loss or normal, they asked you, do you have hearing loss? If you said yes, you're in the hearing loss group. She said, no, you're in the normal group. When she said, do you wear hearing aids? You don't know if it was 1 or 2. You don't know how it was fit. Was it FIG 6? Was it IHAF? Was it NALNL2? Was it Don't know. So, but she was looking for general trends. So that's what she reported. The study, you know, you can't assign to it more credibility than it's worth, but it's worth a lot because it's a good study and you can see some general trends. So those who said they have hearing loss and no hearing aid, that was the unaddressed hearing group. Those with hearing loss and hearing aids were group 2. Group 3 was those who said they had no hearing loss. So they're not really scientifically controlled very well. But could you find a trend here? And the trend was addressing one's hearing loss by the use of hearing aids may slow cognitive decline by alleviating communication difficulties and improving mood and social interaction. So this is very much what National Council of Aging reported in 1999. You know, when they had 2,000 people with hearing aids and 2,000 people without. They said the people who wore hearing aids, right, they had, you know, you alleviated their communication difficulties, so they interacted more and they seemed to be less depressed, less anxious, less everything. So that's a matter of reversal of auditory deprivation, because we know auditory deprivation is bad for your brain, right? There were rat studies in the 60s and 70s where you would section the 8th nerve of a rat or a guinea pig, and the contralateral side of the brain at the temporal lobe didn't develop with all the convolutions and all the neural connections that it was supposed to have. So we know that sacrificing hearing is very bad for the brain. And that's what the National Council of Aging said as well in 1999. So this study wasn't a shocker, but kind of reassured us that these general trends are true and that the people who wore hearing aids, who had more brain stimulation, did better over the long term. This is the study we talked about earlier. Jennifer Deal is the epidemiologist who does these giant studies. And again, there's a world of difference between an epidemiology study of social factors and outcomes than for specific patients. So in 2017, she looked at 40 adults in a random controlled trial. So there's 2 types of science that you could do in peer review. You know, experimental versus control group or random controlled trials. Random controlled trials, double-blinded studies are the strongest of all. That's what she did. So these people had untreated adult onset bilateral mild to moderate hearing loss. They didn't have dementia. So half of them said, I'll just take the workshop on better living. how to maximize the quality of their life. And then the other half, the other 20 said, I'll take that and I'm going to wear hearing aids. Because, you can't assign people to the no hearing aid group for 5 years. Because if their brain starts to peter out, you're going to get sued. And that's never going to make it through, the IRB, the Institutional Review Board. You can't, and that's why we can't study children very well. You can't say, here's a bunch of kids with mild to moderate loss that we treated, here's a bunch we didn't. And at age 10, we compared. You can never do that because you just really screwed up these kids and their mom and dad and the institution and the whole, they're going to come down on you like a ton of bricks, right? You can't do that. That would be totally unethical. So that's kind of the problem. But these people self-elected into one of the two groups. I want to go through rehab with hearing aids, and some said I'll go through rehab without. So then we could study them because it was their election. And they signed, they were fully informed, totally consented. So the people who got hearing aids, they improved the cognitive domain score for memory, and the people without hearing aids, no change or worse function. Peer reviewed. Very small n, 40 people, only 20 people per group. So we have no idea how to apply that to the, to the larger pool. Can we intervene on the relationship between hearing loss and cognition? Well, Dr. Amiva, the same one who had 3,600 people in her study, in 2020 publishes this paper with Dr. Uvrard, and this one I thought was genius level. They looked at a bunch of studies and they said, the available data globally supports the hypotheses, not a fact, not a truth, nothing you can bank on, but a hypothesis that hearing aids have a positive impact on long-term cognition in older adults who have hearing loss. The protective effects of hearing aid use may be hardly observable in clinical trials involving small samples. In other words, in small groups, you're not going to see it. You need to do hundreds and hundreds. And that's why the upcoming ACHIEVE study out of Johns Hopkins has 900 patients over 4 different sites. Follow him for 3 years. So the available data, again, globally supports the hypotheses that hearing aid use positively does impact long-term outcomes, but we don't know that it's attributable to the hearing aid because it could be as simple as this. The people who choose hearing aids, they're more concerned about their health. So because they're more concerned about their health, it could be a placebo effect that they're wearing hearing aids. These are people who are socially, financially viable. They have the means, they seek out help. They're trying to do the best they can. So maybe the hearing aid was a factor, maybe it wasn't. Maybe those same patients, if they had chosen, whatever, 1-a-day vitamins, maybe they would have had a better life expectancy. Because, there's no evidence that vitamins and minerals do anything for you. But I think 90% of us take them because we think they probably do. So this is a big area as we move forward, is to determine, what's real and what isn't. Although the people who self-elect and get hearing aids seem to do better over the long term, it could be because of their personalities, because they were the ones who chose hearing aids. So they're looking out for their health. So we have to put that into the large studies as a factor, as a variable, so we can determine whether or not it cuts mustard. So you heard about this study this morning. This is Dr. Anna Sharma. Anna is a friend of mine. She and Hannah Glick are the ones who actually wrote this study. And in 2020, the year came out in Trends in Neuroscience. In fact, the same month, we did an interview. I did an interview with her for hearing review. So you probably have this in your desk at home, but it was February 2020. And she was looking at something called cross-modal plasticity. And what that is that as you age and you develop more hearing loss, your temporal lobe, superior temporal lobe, which is also called Brodmann area 41 and 42, also called Heschel's gyrus, that gets less and less stimulation. So if your auditory centers are getting less stimulation, and that part of the brain is not being used, well, the visual center or the somatosensory might take it. And what she found is indeed these people, there was only about 24 folks in the study, but their visual evoked potential became huge as their hearing loss increased. So what that means is as the hearing loss got worse, the superior temporal lobe had less to do with audition because there was less sound getting up there. And the visual cortex started to use that real estate in the superior temporal lobe to process vision, which is why their VEP, the visual evoked potentials, became huge. And then she fit them with hearing aids for 6 months. And this is a study that is so important. Age-related hearing loss is associated with cognitive decline and functional and structural brain changes, exactly as I just described. They determined multiple deficits were improved by 6 months of daily hearing aid use. And look at this, you don't see this in science very much, providing striking evidence of compensatory cortical neuroplasticity. In other words, after stimulating them for 6 months, the brains of these people went back. The visual evoked potential shrunk, and the auditory center, as you saw on those fMRI scans this morning, got better, became more prominent as they were able to use audition again. So they noted a reversal in cross-modal reorganization, speech perception improvement, gains in cognitive performance, and auditory speech improved, improvements in global cognitive function, executive function, processing speed, all were improved after 6 months of wearing hearing aids. But there's no control group. So we don't know what to attribute these improvements to. Yes, sir. Shlomo Silman, City University of New York, 1986. It was Dr. Silman was looking at if you have symmetric ears, by pure tones and by speech discrim, if you only fit one ear, what happens? And the other ear that was not fit, the discrim went down and down and down. So that's the one you're referring to? Yeah, pretty much the same. So he was trying to argue that it's really important to do bilateral, binaural processes. And he was exactly right. But he was like 25 years ahead of the curve. Yeah. So I have bad news for you. You're going to die. Hopefully not anytime soon. But what I want you to notice is in 1700, the average age of death in the USA was 35 years. So now we have Parkinson's, we have Alzheimer's, we have dementia, we have cognitive decline. These are natural processes because we have very, very old people. Even in so remember when Medicare and Social Security came in, and I love those. I would never speak against either of them. I want more, but I'm old, right? So this is, I love those programs. I think they're brilliant. But think about this, look at this chart carefully and try to guess in 1965, how old were you when you died? About 65, right? So you work your whole life and then you're gonna get Social Security and Medicare. Oh, but sorry, you died. So the government then, right, was in great shape because they'd have to pay out these benefits. Now, this is part of why we're in such a financial difficult situation. People live to be 80. And it's not unusual to have, 15 people who are in their 80s and 90s, right? So we age terrifically now. We are basically healthy, but so you have Alzheimer's, you have dementia, you have Parkinson's, which are, diseases of aged people. You didn't have those in the 1800s and early 1900s because on average, people didn't live to be anywhere near as old as we get to be. So that's important, but that's why I put that up. This one is more important. 80% of adults over age 65 have at least one chronic condition. What is hearing loss? Hearing loss is number 3. That's what we all learned, right? That's the third most common chronic condition. But and 68% of adults over 65 have 2 or more chronic conditions. But look what the National Council of Aging did is they, oh, it's in the wrong spot. They left us off the list entirely in their 2021 publication. Yeah, so I, of course, wrote a letter to them. And I said, hey, we're number 3, but we try harder, right? And I never got a response. But I wrote a letter to the editor and I said, how dare you? What's wrong with you people? So, we are the third thing at hearing loss. But if you add in those other 26 million with super threshold listening disorders, we're actually number 2. So, most people fear cancer more than anything else, right? But it turns out hypertension, cardiac issues, high cholesterol, arthritis, those are pretty likely to get you. And that's the list. So when you look at these numbers, they should be familiar now because I told you these earlier a couple of times. People in the USA, 37 million people have hearing loss on an audiogram, 26 million have no hearing loss whatsoever, but they have supra-threshold listening disorders. What is the number one thing we do to help people with supra-threshold listening disorders? There's only one thing we really do. People have no hearing loss, but they can't make sense out of sound. Counseling. Well, counseling is important, but it's not the number one thing we do. Auditory training, and I'll put that in the same bucket with counseling. Yep. What do we do with kids with ADD or ADHD? What do we do with veterans who come back with noise trauma? You got to improve the signal to noise ratio, right? And you could do that with hearing aids. You could do that with FM. You could do that with a digital remote mic. You could do that with a pocket talker. But it's improving the signal to noise ratio because Meade Killian was really clear. 2001, he published in Seminars in Hearing, people with normal thresholds or near normal thresholds need a 2 dB signal to noise ratio. You got to memorize this right now. You absolutely have to know this. 2 dB signal to noise ratio to get 50% of the words correct. People with a mild to moderate loss need 8 dB. So their SNR 50, the signal to noise ratio to get 50% of the words correct, People with normal thresholds or near normal is 2 dB. People with mild to moderate loss is 8. Very, very important, because these people who we usually don't even recognize as having problems because we're not doing listening and communication assessments, we're not doing speech and noise, which is what IHS specifies is your best practice. Because we're not doing that, these people are invisible to you. You don't see them. I mean, they're coming into your office, but you're incorrectly telling them, oh, we'll follow up in a year. Oh, get used to it. Everybody has that. Oh, there's nothing wrong. Yes, there's something wrong. Do you think anybody would voluntarily come to see you 3 o'clock on a Wednesday because they had nothing else to do? They just really wanted a hearing test? If they're in your chair, there's a reason they're there. If you don't find it through the typical audiometric protocols, that's why you have the other protocols that are best practice, is to figure out who are these people and how bad is their problem. Once you know that, then the solution becomes apparent. Because you're looking at their SNR 50. If their SNR 50, what did I say people with normal or near normal thresholds should have? 2. People with mild to moderate loss should have what? 8. So your patient has normal thresholds, but their SNR 50, because you spent 2 minutes testing them in noise, their SNR 50 is 6. They're acting like somebody with a mild to moderate hearing loss in the real world, and they don't have it. So what's their diagnosis? Well, you don't know that yet, but it could be ADD, ADHD, dyslexia, auditory processing disorders, auditory neuropathy spectrum disorder. It could be dementia, it could be traumatic brain injury, it could be cochlear synaptopathy, it could be hidden hearing loss, it could be neurocognitive disorders, it could be Alzheimer's, it could be a bazillion others. I don't know how many I mentioned each time I go through that little rant, but I usually have about 15 or 20. And you know, these people are all around you, quite literally, but we don't diagnose them because we fail to provide our best practices. Even though the patient paid you, again, I don't care if it's $5, $50, or $5,000, I don't care. But when they, you know, in all of medicine, we do this. We say diagnosis first, treatment second. And when we're telling them they're normal, and then, oh, everybody goes, we haven't even done our best practices. How are you making that diagnosis without doing the work? And now that we're in the age of OTC, it becomes more important than ever. Because you're going to have a bunch of crazy people who are going to buy these products that they have no idea if they are candidates or not, because it's going to say on the label, self-perceived mild to moderate. That's pretty much done. We're still arguing that's nonsense. But do any of us on the committee think the FDA is going to change? No, we don't. And so that's going to be the thing. And they have no way of knowing if they have a mild to moderate, particularly somebody with auditory neuropathy spectrum disorder, their speech to scrim 0 at 45 dB, right? And so they're going to say, yeah, I have hearing loss. They're going to buy all these products. It's not going to help at all because we don't have a diagnosis, but we're treating, and we're treating poorly because we have no idea how much sound. So one of the guidelines, by the way, if you're not familiar, what the FDA proposed, they're not restricting gain at all. The consensus statement that we wrote, AAA, ASHA, IHS, the consensus statement, we said it should be limited to 25 dB of gain, 110 dB maximum output. The FDA said 115 dB output and 120 dB output if you use input compression. These are people who could have normal hearing walking around. And so we said, well, that doesn't make sense because they're going to cause noise-induced hearing loss. And the FDA said, oh, well, they could take it out if it's too loud. I guess, right? So we should all wear 3.0 glasses. All of us who wear cheaters for reading, just wear the 3.0s. You know, if it's too much, just take them off. I mean, is that a solution that's right? Well, and you know, the good news is there's going to be a lot more people with hearing loss the way the FDA is going. So, right? So, yeah, hearing aid induced. I like that. I'm going to steal that. So this is one of the early papers I wrote on this topic. This was 2018. Look at this carefully. 25 authors. You probably know at least half of them. These are all very, very smart people. And this is audiologic considerations for people with normal hearing sensitivity, yet hearing difficulty and/or speech and noise problems. Get a copy of this, because whenever you refer to a patient at 3 o'clock on Wednesday, normal, 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 you're not done. You haven't done what IHS says to do. You need to practice to best practices, do the other stuff, and you'll figure out why that person's there. I don't have the time to go into this. This is a 17,000 word paper. It's got 200 references. Every one of these authors contributed significantly. I did not write this by myself. I didn't give them a guideline, say, here, fill in your, nope. We talked about it a couple of times. We decided what we were going to write. People volunteered for different sections. Then I did the final, you know, putting it together. That was the most downloaded paper at the Hearing Review in 2018, 3 years ago. So as a result of that, Jeff Danhauer and I said, we need to get this information into the otolaryngology literature, because there's a lot of ENTs who are seeing patients with normal thresholds. They're having tremendous difficulty. How many people would that be? 26 million, yeah, who we're all dismissing until I come back in a year. So Jeff and I decided we would write a cheaters version. So we wrote this version of the same paper. It's the exact same paper as this. This is the long version for you. This is for hearing care professionals. This is the short version for ENTs, because they're not going to read 17,000 words. You'd be lucky if they read 4,500 words, which is not a cut on ENT. It's the same. You're not going to read a paper on radical mastoidectomy. You're probably not going to read a paper on fenestration in 1958, right? It's just totally irrelevant to who you are and what you do. So we wrote this cheaters version because we know the ENTs, if they're going to read any of this, it's got to be short and to the point. I strongly urge you to keep this in your computer. You can just simply Google this, talk to Donna, she'll get you a copy, talk to me, I'll get you a copy. Google it so you have it. And when you see that patient with normal hearing, say, I'd like to see this patient back for a 1-hour comprehensive audiometric evaluation in which we'll do a listening and communication assessment. We'll do unaided speech and noise. We'll do aided speech and noise. I don't know if it's covered by their insurance. We charge $125. But we really recommend it because there's 26 million people in the USA who we're not catching right now. Okay, so that's my advice. And I don't care if you charge $125. I don't care if you do it free. I don't charge whatever you want to charge. I'm not suggesting what you should charge. I have no idea. This all goes back to Dr. Michael Buss, 1949, Journal of Speech Language Hearing Research. Dr. Michael Buss pointed out there's no difference in psychology, language, and auditory processing. They are all the same. It's just a matter of which lens you're looking at it from. For instance, you take an 8-year-old little girl and she has ADD. That's what the pediatrician said. Well, then she saw a neurologist for her ADD and the neurologist said ADHD. Then she saw a speech language pathologist and they said specific language disorder. Then they saw the audiologist said auditory processing disorder. It's the same kid. It's just a matter of you interpret this information based on your training and your knowledge. So Michael Buss, this is 72 years ago. Clinical psych has an important contribution to make in audiology. In reality, you can't really separate cognition, language, and audition. They're the same. These processes are intimately interwoven and interdependent. It may manifest in the audiology world, but it could be a psychology problem and vice versa, and it could be a language problem and vice versa. The most difficult and challenging dilemma is to determine how much of a communicative disorder originates within hearing loss and how much is based on other causes, which is again why I really urge cognitive screenings. In the paper I wrote with Mike Harvey, he's a clinical psychologist up in Boston, and Barbara Weinstein, she's a professor of audiology at City University of New York. We suggested all patients over age 70 just do a cognitive screening. Takes you 3 minutes, 5 minutes, whatever it is, because it's good patient-centered care. Now, a lot of people pushed back on that and said, oh, I don't think so. That's not in our realm. Well, audiologists, about 98% of us have an undergraduate degree in communication disorders. So yeah, it does make sense. Again, I can't tell you guys what to do, and I don't know. But I think it's important for you to know this, because if you're not allowed to do it, you ought to be pushing that border and doing it legally and correctly, because it's a very, very important point to know who your patient is, what the actual diagnosis is rather than the symptom. The symptom could be the hearing loss. The symptom could be the inability to understand speech and noise. So this is a huge problem. And my first paper on this was in 2009, which I think I spoke at CHIP's meeting back then in 2009 on this paper. So this is published by AAA. The title is, so Jackie Clark was the president of AAA a year or two before this. She and I wrote this together. And I think in 2009, we won the award for the longest title. It was called Audition Matters More as Cognition Declines, and Cognition Matters More as Audition Declines. Okay, so that's what this paper was about. But look at the date. That's the important thing. This is not new for audiology. Then I wrote this in 2014 for AAA. And we start with listening is where hearing meets brain, right? Because Carol Flexer and I wrote that in 2011. But this whole idea that who's going to do the very best with a hearing aid is actually not based at all on their pure tones. The single most decisive factor as to who's going to do well with hearing aids happens to be who has the best working memory. Different discussion for a different day, but that's why I wrote this op-ed for AAA in 2014. You can find this at douglaslbeck.com, or you can just Google it, working memory, Beck, audiology, you'll pull it up. But it's really important to understand that the influence of your brain on, so that you have this top-down and bottom-up thing going on every minute of every day. You have an afferent nervous system, which is sensory going up, and you have efferent, which is cognitive going down. And these things work together at every level of your central nervous system. And it works with your hearing as well. That it's not just a matter of the sound that goes up, it's also what your brain does with it. So the most recent mega study was in August 2020. It came out from the Lancet, which is the world's foremost medical journal out of the UK. And in 2020, they put out their revised one. In 2017 was the original. I'm not going to tell you about the original because it's been revised. I'm just going to tell you the newer stuff. So they said 60% of your dementia risk is based on non-modifiable stuff. It's your deoxyribonucleic acids. It's your DNA. You can't do anything about it. But 40% of your risk for dementia is based on 12 modifiable factors. And those 12 modifiable factors are these. You can read them yourself. The thing about this is if you look at these one by one, the one that is the most significant in an epidemiologic study, not for your patient, you can't say 2 times greater for mild. That's epidemiology. That's not your patient. And also in epidemiology, we actually have better numbers now. So the numbers for hearing loss are 8.2% of your dementia risk, which does mean, you know, that about 97.8%, 92% of your risk is not due to hearing loss. Okay, so the scary big deal numbers about, you know, 2/3, twice the increase for dementia with mild, 3 times, 8.2%, 2020 Lancet. So not to say that Baltimore was wrong. Baltimore nailed it, but we're getting closer and closer because science evolves. That's what we had in 2011. This is what we have in the next decade. Now, this is based on 3 different studies. The problem with this study is that it's based on white people only in upper and middle socioeconomic groups. This is done 2 of these in the USA, 1 in the UK, and that's what was the basis of this study. So it's a big study. It's the biggest one we have. It's the most highly peer-reviewed. It's probably the most highly regarded, but it may not apply to the whole population. It applies only to the people that were studied because still we didn't have thousands and thousands. But anyway, you get the idea. So we're seeing trends, and the trend is that hearing loss is 1/5 of all of the modifiable risk. If you take that 40% that you can modify, 1/5 of all of that, 8%, is due to hearing loss. To put that in perspective, depression is 3.9, social isolation, traumatic brain injury, so you get the idea. And we already covered group data versus personal data. You have to be very careful when you're reading epidemiologic studies, like the stuff that comes out of Johns Hopkins. That is true for a population. That is not necessarily true for a person. The person in front of you is unique. I gave you this example already. Hearing loss is associated with depression and cognitive impairment. Age-related hearing loss is a potential risk factor for cognitive impairment, dementia, and late life depression. And age-related hearing loss is highly prevalent and is highly treatable. This is 2021. This is my buddy Boz Ben David. He's a psychologist in Tel Aviv. He just published this. Cognitive performance is intertwined with speech perception and hearing. Well, 1949, Michael Buss said the same thing. Cognitive ability has a large effect in speech perception. Hearing status impacts cognitive reserve. When assessing speech processing, we have to consider their cognitive ability. That would be the other 26 million that we're currently ignoring. And when assessing cognitive ability, we have to consider auditory and visual sensory input. In other words, to give somebody a spoken test, a cognitive screening, not such a good idea because there's tester bias and you're presuming that when you say the word went, that they're hearing went. But what if they heard bent or gent or tent? So the caution is before you do any psychological screening, whether it's depression index, whether it's cognitive ability, whether it's dementia, you should get a full audiologic workup first so that you know the patient is perceiving correctly before you're measuring where their brain is at. Never end a sentence with a preposition. Okay. The real challenge is beyond hearing. The real challenge is to improve the opportunity for listening. And that's most often done with an improved signal to noise ratio. Say again? Yeah, that's what it was, right? He said for the camera, sorry. For those of you online, he said this is the best lecture he's ever attended. So addressing, addressing the hearing needs of people with dementia. This is by Pierce Dawes. Pierce is a dear friend of mine. He's now in Australia. And I've worked with Pierce at the British Society of Audiology for 10 or 15 years. So he just published this in 2021. Untreated hearing loss exacerbates the impact of dementia. I gave you that exact sentence about an hour ago. Hearing care should be person-centered, tailored to the needs of the individual, should involve multidisciplinary professionals. Hearing professionals should receive training in dementia. That's what you're doing right now. And it's time for hearing professionals to address the global dementia challenge. Not that you're going to diagnose, you're not diagnosing anyone, but you're going to be aware that people with cognitive limitations and cognitive issues are often going to complain of the exact same problems that people with hearing loss and listening disorders complain about. So if you screen that, because by the way, if you don't do it, exactly who's going to do it? You think the GP is going to do that? The neurologist? I don't think so. But if you do it and they fail, then the GP is kind of obligated to push it further and see if there's something there. And they'll order a diagnostic test from a psychologist, a social worker, psychiatrist, neuropsychologist, whoever they're working with in their group. This is also 2021, Dr. Irais. If age-related hearing loss goes untreated, it may result in social isolation, loneliness, loss of productivity, loss of autonomy, depression, cognitive decline. A growing body of evidence linking hearing loss to the development of dementia has substantially increased interest in hearing aids. Excuse me. So this is a paper I wrote in 2011. Pardon me, I've just been speaking way too much. Listening is where hearing meets brain. If you get nothing else from this lecture, take away that quote. It's so important. Good ears by themselves mean nothing. A good brain by itself means nothing. You have to have both in order to understand speech and noise. In other words, to comprehend speech, you have to have a good brain and good hearing. So listening is where hearing meets brain. We can make anybody hear. You know, you have hearing aids, you have boomer hearing aids, you have cochlear implants. If they don't have an auditory nerve, they don't have a cochlea. We've been doing brainstem implants since 1987. You know when the first cochlear implant was done? History of the world? 1959. People go, oh my gosh, oh, that's right, we have cochlear implants now. Yes, we do. And for the last 59 is 62 years. Yeah, we've been doing them. They were only approved by the FDA for adults in 87 and then for children in 90. But I mean, even since 90, since they were approved for children, that's more than a generation ago, right? That's 3 decades ago. Anyway, so we can make anybody hear, but we can't make anybody listen. And in fact, when you think about it, we are the top of the food chain, not because of our hearing. Human hearing is kind of sucky in the animal kingdom. This is my cat. This is Fred. One blue eye, one amber eye. I know, isn't that? I put that up for the big aw. And this is my German Shepherd. That's Mia. But the point is that all of these animals hear better than you do, by far. I mean, humans hear 20 to 20,000 hertz, which is, your cochlear will respond there, but it's got to be 140 dB. You know, you're going to feel it percussively before you would hear, you know, a 20,000 hertz tone. And if I gave you a tone of 15K and a tone of 20K, you could not tell the difference because you have no sensitivity there at all. So, and you don't really hear stuff at 20 hertz, but you might feel them. There might be vibe. So your real hearing is maybe like 30 to 35 hertz to maybe like 12,000. Cats and dogs, 38 to 40,000. Dolphins, whales, porpoises, some of them go up to 140,000. Bats, yeah, they have radar. You don't. You can't even see ultraviolet. You can't see infrared. Human sensory perception, horrible in the animal kingdom. The reason we're the top of the food chain is our brains, is our listening ability, our ability to attribute meaning to sound. So speech and quiet, as by now I'm sure you get, does not predict speech and noise. This is Rich Wilson's study, 2011, based on 3,430 veterans. He did word recognition and quiet, you know, NU6s, CIDW22s, and then he did speech and noise, and he said, gee, the two are totally unrelated. You could have brilliant 100% in both ear, but your speech and noise is horrible. So you test, great, and you survive poorly because you have no idea what anybody's saying. This is Dr. Guyot's and colleagues, ear and hearing, I think, American Journal of Audiology in 2018. It says peer reviewed by ASHA. And they said, you know, an established goal of modern hearing aids is to improve speech understanding for the wearer. This goal is best achieved by improving the signal to noise ratio. That should be the goal. That's why you should be doing a speech and noise test. This ain't new. 1970, Ray Carhart and Dr. Tillman said the exact same thing. Every audiometric eval should include, 1970, 51 years ago, speech and noise testing. Yep. This one. That one. This one. If you take a picture of my cat, you got to pay me a royalty. This is the meanest cat in the history of the globe. She will take your head. No, he's really nasty. He will take your hand off. If you don't feed him on time, he is on you like white on rice. It gets ugly really fast. And his purr is like, you know, it's not like, no, it's nasty. He purrs to keep people away from him. So 50 years of speech and noise testing. Ray Carhart, and I think it was Robert Tillman, maybe it was Ed Tillman, advocated speech and noise test. And AAA adopted it, IHS adopted it, ASHA adopted it. It's just that only 3 or 4 people in this room adopted it. Sir. Of course. In those ENT offices, they schedule an ABR for 1 hour. They schedule ECOGs. They schedule electroneuronography. They schedule hearing aid evaluations. They're all special tests. You come back for an hour and you pay for them. That's how I would do it. I would say, doctor, you're leaving money on the table. As soon as you say that, oh, everything changes. An ENT leaving money on the table, they don't want to do that. So I would say, anytime somebody complains of speech and noise, whether it's apparent or not, whether it shows up on their word recognition, regardless, let's do a full eval. Let's get their baseline speech and noise score. Let them bring in their OTCs, let them bring in their previous hearing, test them again with that, and then test them with your premium product and see if there's a difference. If there's no difference, there's no reason to buy it. But that's how I would handle it, because we right now, we bill 92557. Most offices get somewhere between $30 and $42 for that. It's not, some offices don't even charge for testing because it's not worth it. Because you have to then give it to your accountant. It's in your accounts receivable for 180 days. You have to bill Medicare. You have to, all that nonsense, right? So that's why people sometimes don't even charge. But I would say that since we set up special appointments for all these other things, anytime somebody complains about speech and noise, here are 2 papers. Here's the one from the Journal of Otolaryngology ENT Research by Beck and Danhauer showing 26 million people in the USA have a problem we should be dealing with. And here's the one by 25 authors out of Hearing Review, all of them audiologists. Well, 21 of the 25 of us were audiologists. And because it's not a paper from Oticon, it's not AAA, it's all clinicians. And that makes a huge difference. So I would avail those 2 papers to that ENT practice and say, look, a lot of people are going to complain about speech and noise who have no hearing loss. And they're all patients who are candidates for FM, for digital remote mics, for hearing aids, for pocket talkers. It's the #1 thing. What do they do with the Veterans Administration? You have guys who come back from battle and they say they can't understand, they can't follow conversations. It's automatically normal. What do we do with them? We give them hearing aids, we give them FM systems, and we retrain the brain what to pay attention to. We know this from Australia, the pediatric studies from National Acoustics Labs. You take a kid with ADD, ADHD, auditory processing disorders, you fit them really, really well with an FM system. Often, most often, 3 or 4 years later, their brain has learned what to pay attention to, so they don't need that FM system anymore. Sometimes no, sometimes they don't learn, sometimes it takes longer. But in general, a well-fitted child with an FM system, 2, 3 years later, their brain has been trained on what to pay attention to, so they start to do better because they know they organize their brain differently. There's a bunch of hearing tests, speech and noise tests. These are all okay. The best out of the bunch is mine. Now, the reason that I say that is it's free. It costs you nothing. We didn't do it in a sound booth. All of these other tests, they're really good. They're fine. Most of you use the QuickSyn. Here's why I don't. The QuickSyn is developed by a very dear friend of mine, Mead Killian. I love Mead. He is one of the smartest people I've ever known. I learned more clinical audiology from Mead Killian than I have from any other human being. Mead has 26 patents. I have none. Mead is a genius. But I don't like that test because, remember we started this discussion, to do well with speech and noise, you have to realize it's a localization test. You're trying to figure out where the sound is coming from, right? Who's doing the QuickSyn? Okay, so you're doing the QuickSyn. What is the step size? 5. And where does the sound come from? A speaker, right? So speech and noise is typically coming from the exact same location. So your brain doesn't have a chance to separate speech from noise. The 5 dB step size, big problem, because people with an SNR50 of 1, 2, 3, 4 all look the same. But normal hearing should have 2 or 3 dB SNR50. Somebody with 4 falls in the normal category. People with 5, 6, 7, 8, 9, they all look the same. So, and there's a memory test involved, right? The boy went to the store to get milk and eggs. So if the patient says milk and eggs, boy milk and eggs, wrong. They got some of the key, but why don't we, if Houston Westlake is good enough for pure tones, which is the gold standard of hearing, what we did here in the 2-minute speech and noise test, did I mention it's free? You don't buy anything. You may need 4-talk or babble. You cannot use speech spectrum noise, white noise, or pink noise because they are non-linguistic. You want people actually talking in the language that the listener understands because that's the most distraction. Right now, if you listen carefully, You can all hear the HVAC, right? It's probably about 45 dB in here. But you were ignoring it until I pointed it out because that's your efferent nervous system. It's a steady state noise. It's easy to ignore. But if instead that was a bunch of people saying, wow, it's getting really late and I hope that it's not an ice storm out there and everybody's talking, right? It's really hard to ignore that because your brain is like a sponge. You're trying to absorb that spoken language. You're not trying to absorb this. So what we did in our, okay, we're going to pass through all this. I thought that I loaded this without all of this stuff because we already covered a lot of it. Sorry, my bad. Did it go backwards? Oh, it did? Okay. So this is a couple of things you have to know before you learn how to do a speech and noise test. Number one, Brian Taylor, Gus Mueller. They said every 1 dB improvement in signal to noise ratio is 7 to 10% improvement in word recognition score. You must know that because if you're doing the quicksand and somebody scores SNR 1 versus an SNR 50 of 4, that's a world of difference. That's 40% difference in the real world. And this isn't new. Mike Valente, Holly Hosford-Dunn, and Ross Rozier wrote this up 25 years ago. But I'm giving you this reference because it's easier to find if you want to look it up. Harvey Dillon said 10 years ago, for every 10 dB of hearing loss, you have to increase the signal to noise ratio by 3 dB just to maintain unaided intelligibility. Now this is critical because I've never met a dispenser or an audiologist who knows this or does this. This will change the way you dispense hearing aids as of Monday morning, I guarantee you. Pay attention, it's very important. Next 5 minutes, critical to how you take care of patients. So let's presume these patients that I'm about to show you have their brainless. We're just looking at their ears because we just spent an hour and a half talking about the hearing loss by itself is not really important. It's the hearing loss and the brain together. It's the result that's really important. So we're not considering brains on this because Harvey was just trying to give you a guideline. So if you look at the 3 frequency pure tone average, this guy 0 to 20, so he's got a 18 dB pure tone average. 0 to 25 is normal. So you'd argue theoretically, oh, he doesn't need hearing aids, he's normal. Okay, fine. But this guy has a 35 dB loss. Now this is where the trick comes in. If 0 to 25 is normal, this guy's at 35. So what's his hearing loss, SL? Sensation level hearing loss? 10. So how much do you have to improve his signal to noise ratio? 3. For every 10 dB of hearing loss, you have to improve the signal to noise ratio by 3. So this is how you're supposed to fit hearing aids if you do NAL or NAL2 or you read anything by Harvey Dillon. So you could fit this guy with directional because directional in a RIC or a right is going to give you 2 or 3 dB improvement in signal to noise ratio, which is about it. That's if everything's working fine. This guy has a 45 dB loss. So 0 to 25 is normal. This guy's at 45. So how much hearing loss does he have? 20. How much do you have to improve his signal to noise ratio? 6. What hearing aid do you have that can do that? Well, the first one that came on the market that could do that was Open One in 2016. We peer reviewed that, and I've got lots of publications on this showing that the average improvement with Open One, which is 3 generations ago for Open, was for Oticon, was 6.3 dB improvement in signal to noise ratio with the dome fitting. That's published. That's like beyond debate. We looked at directionals, we looked at beamformers, we looked at Open. Then we had Open S, which was a little bit better, and then we have Oticon More, which added another 2 dB signal to noise ratio. So this guy, if you're just fitting him with hearing aids, you don't actually have one that improves signal to noise ratios by 6 dB, unless you're fitting him with like an Oticon More, which doesn't use a standard digital processor. It uses a deep neural network, which we'll talk about in a little bit. So this is a real problem because this is a guy you're going to fit. He's going to tell you, I did great with you in the office, no problem. Oh my gosh, this sounds so good. But I went out to dinner with my significant other and I took them out, right? Because I couldn't understand what anybody was saying because you directionalize, directional, beamforming, compress. So pretty soon all the dynamics were gone. So his brain was just getting a little beam of sound, trying to make sense of it in noise. This guy, this is my crossover point. This guy's got a 55 dB loss. So 0 to 25 is normal. He's at 55, 30 dB SL loss. You have to improve his signal to noise ratio by 9. There are no hearing aids that can do that. That's a problem. So what do? Well, a digital remote mic, that'll improve the signal to noise ratio by 12 to 15 dB. Oh, my patient won't use it. Well, that's you in counseling. You have to counsel them that there are no hearing aids. And this is why you do the signal to noise ratio test. You do the SNR 50, and if you find out his SNR 50 is 2 or 3, well, he's fine. If you find out his SNR 50 is 5, 6, 7, 8, he's not fine. And if his SNR 50 is 11 or 12, and you're giving him you're giving him directional mics or beamformers, then improve his SNR by 2 or 3, he's still going to tell you it's terrible in noise. Right. So this is where I think we have a professional obligation to realize even our very best technologies will benefit from a digital remote mic or an FM. So give them a solution. It's like the backseat of your car. You don't want to pay for it. You wouldn't even order it probably if you had to pay extra for it, but it comes with the car and you're really glad you have it when you need it. Well, if you include the digital remote mic when you dispense hearing aids, it's going to cost you 150, 200 bucks. But now you gave them a solution for what to do in the restaurant, in the cocktail party, the bar, the restaurant, the tavern, whatever it is. They don't want to use it. Of course, they don't even want to use your hearing aids. Right? We covered earlier that when hearing aids are free, 58% of people who are eligible don't want them. Of course, they don't want an extra device. But it comes with it, like the backseat of your car, because you're going to need it. We're going to set these hearing aids. They're going to be excellent. We're going to do probe mic RealEar measures. We're going to do speech and noise. We're going to make sure they work. But sometimes you're going to be in situations where the noise is even louder than the primary speaker. The only thing to do, ask them to use. If they say no, they can't do it. Okay, that's their personality. You've done the best you could do. But to not even demo it or show them about it, I think we fail there. Yes, ma'am. Yeah, I'm not a big fan of the live listen feature on cell phones. The bandwidth of any cell phone, Todd Ricketts wrote this up in his new book from Vanderbilt. I think the book came out in 2020, yeah. And he said the bandwidth of phones is still 300 to 3,000 hertz. And you know, people put it in the middle of the table. They say, all right, everybody talk. It's like, oh, it's just as bad as it was. You know, there are no peer-reviewed studies showing that a microphone in the middle of the table is going to be beneficial. And people, like my phone, I just bought a 12, iPhone 12. And I thought it was a pretty good deal. I got it for like 750 bucks, right? So if I give you my phone to talk to, you drop it on the ground and the gravy or the soup, right there goes 750 bucks. But if you have these little $200 microphones that are about that size, maybe smaller, they come, you know, they're 150 bucks. They come with a warranty, 1 year, 2 year, 3 year, whatever your hearing aid is. So I think that whole idea of using the phone was good in the early days, meaning like 6, 7, 8 years ago, because it was a portable mic in some respects, right? But as far as sound quality, it's horrible. It's like an AM radio. So I wouldn't recommend it. I'm glad you asked because it's on everybody's mind. But I wouldn't recommend it. Get a real digital remote mic. When you're buying your hearing aids, it's 150 bucks, maybe 200 bucks. And it's got a bandwidth the same as the hearing aid. And it's got noise processing in the transmitter and the receiver. And it goes about 40 feet, which your phone won't do. So that's what I would recommend. This guy, mandatory, right? If you're not giving this guy an FM or digital remote mic, he's not hearing in most situations, and he's certainly not doing well in noise. So now that you know some more about this, I decided I would put up the definitions again. So the SNR 50 is the speech and noise level at which the listener correctly identifies 50% of the words. So somebody with an SNR 50 of 5, that means if I'm speaking at 70 and the background noise is 65, they get half the words. So that's how that all works. Like an SNR 50 of 12 means the listener needs a signal to noise ratio of 12 dB to get half the words right. So this is Mead-Killian's original graph, and you can see people with normal hearing, that's this line, need 2 dB signal to noise ratio to get 50% correct. People with mild to moderate loss need 8 dB. And so this is his in-depth scale. This is the most brilliant scale I've ever seen in all of audiology. So even though I don't like the Quicksand, I do use its guidelines. And I think this is such an important concept for all of us to have clinically when we're practicing and when we're dispensing hearing aids, because this shows you what to expect with different degrees of hearing loss. And if your patient is, so if the patient has a moderate loss, their SNR 50 is probably going to be about 8, 9, 10. And so your job is to get it towards normal, which is 8. So you can definitely do that with a digital remote mic or an FM. With really good hearing aids, you could probably improve it 6 or 7 dB. But this is so important for your realistic expectations and for your fitting guidelines. Has anybody ever seen this before? Because Mead published this like 20 years ago. It's really important. So these are a bunch of speech and noise tests. And this is the one that I developed with Dr. Benitez. She's a captain in the US Army. When she joined the Army, I pointed out to her that I was in the Air Force and that I tried to talk her out of the Army, but she went anyway. So, but no, Lauren is brilliant, and she just got married this past year. If you ever see this tape, congratulations, Lauren. And she's wonderfully bright, and she did all the clinical work. I was there when we were pilot testing all of this, but she and I worked it all out together. She did all the clinical work. I did all the theoretical stuff. AAA published it. It's totally free. If you just take a picture of this, you can Google it. You'll get it through Google. You can get it at douglaslbeck.com. You can get it on the AAA's website. I'm going to work you through it. It's really so easy. You won't believe how we made speech and noise testing so difficult. I don't know why we did it or how we did it, but it was not a good thing. Here's your patient. 1 meter in front, 1 meter behind, calibrated speakers. Notice I'm showing you the appendix. That's because we wrote an appendix to show you how to calibrate this in the sound field. If it's not calibrated correctly, none of it matters. And I don't want you to calibrate it. Have your people, whoever your instrumentation company is, E3 or whoever you guys use, have them calibrate it. It takes nothing. This is not a high skill for them. You know, they already do sound fields. So you just, and you could do it in the booth or outside. We did it outside because we had a tiny booth. So, but it has to be controlled by the audiometer because you're going to change the attenuators in 1 and 2 dB steps. And I'll show you how to do it. Take a picture at the end because it's a buildup. So you start with 70 dB SPL in front, and you can use CIDW 22s, NU6s, any digitized word list. Doesn't matter. It's got to be digital, cannot be live voice. And you do it at MCL or MCL +5. So if they have normal or mild thresholds at 70 dB SPL in the front speaker, you never change that. That stays the same. The only thing you're varying is the back speaker. You're going up and down, just like Houston Westlake. Houston Westlake is 10 and 5 dB steps. You're going to go 15, 10, 5, 3, 2, 1. Takes less than 2 minutes. So you start 55 dB for talk or babble, because people with normal or near normal need what? 2. People with mild to moderate loss need what? 8. How much are you giving them? Doug, I didn't know there was going to be math. Come on, go on. 15, thank you. Who said 15? It took a while, right? So you did serve wine at lunch to some of us, but that was, okay. So, so you got to get this. This is your starting point. But you give 3 words. Say the word went. Say the word should. Say the word though. They got all 3 right? Move on. Crank up the back speaker, the noise, by another 5. So now you're giving them a signal to noise ratio of what? 10. But you're at 60. So you give them 3 more words. Now you're at 70 and 60. If they get all 3 right, you go up to 5. Now this is where the problems are going to start, because people with normal or near normal need 2. People with mild to moderate loss need 8. Now you're giving them 5. So half these people now are going to really suck here. They're not going to be able to do it. So then if they can't do this at 70 and 65, then you're going to go down to 70 and 63. If they get that right, go up to 64 and just then double check to make sure you're right. I mean, you're giving like 18 words total. It doesn't take as long as it does to do a 25-word list. So you're at this point of a 5 dB SNR. You've only given 9 words. And then you go 3, 2, 1. Just bracket it, the same as you're doing. Oh, it can't be accurate. Really? Because it's a lot more accurate than your pure tones. Does this make sense? Okay, now is a good time to take a picture because that's the whole build out. But I mean, this is how easy it could be if you have calibrated speakers, and I would not put them in the booth unless you have a big booth. So if you have 2 in the booth already, you got to move one because it's got to be 1 in front and 1 behind. They have to be 180 degrees apart. They can't be 1 front left, front right. That will not work. Lots of psychoacoustic reasons. I don't have time today. But get this article published by AAA 2019. The test is free. You already know how to do it. You're just bracketing. You're just raising and lowering the noise. That's it. You find the point where they get 50%. Bingo, that's their SNR 50. All right, so one more look. Those are your guidelines. And in 2008, Rachel McCardle, who is the chief audiologist at the Veterans Administration, and Rich Wilson, who's probably written more peer-reviewed papers than all of us have read, Rich said the time is past due for speech and noise testing to be embraced as a necessary measure to give appropriate and ecologically valid care to our patients. That was 2008. But we don't do it. So my conclusions, patient's primary goal is improving speech and noise. Best practice means achieving the goals of the patient. If you know the SNR 50, everything changes. So here, this woman is actually a patient of mine. She's a PhD in electrical engineering. She's a genius. And she had her own small company. And she couldn't understand anybody saying anything. And so she sees audiologist at the local ENT, sees the local audiologist, and she complains about all this stuff. But she has normal otoscopy, normal ENT eval, SRT of 0, pure tone average of 0, word recognition under headphones, 100%. And she's told, oh, come back in a year. We think you'll be fine. You just need better lighting, sit closer. She's got a PhD in electrical engineering. Do you think she didn't try this stuff on her own first, really? She did. And normal audio. But so then she happened to see an audiologist who knew what he was talking about, tested her SNR 50, was 12. 12. What should it have been? 2. Yeah, so her life changed when she wore hearing aids because all of a sudden her signal to noise ratio was improved by 6 dB. So she could converse. And when she went out to dinner with husband, with workmates and stuff like that, she would bring a digital remote mic. And that improved her signal to noise ratio by 12 to 15. And she didn't want to wear hearing aids or a digital remote mic, but she did want to communicate. And that's a matter of how well you and I counsel the patients. If we're talking to them about making things louder, nobody wants it louder, not anybody. If we talk to them about making things clearer, we change the whole, the whole equation. Did you have a question? I'm sorry. Yeah.
So what do we put in NOAA for SNR 12 and a normal audiogram? How do
And the NOAA?
the audiogram's normal,
Yep.
but the SNR is 12.
Yeah. Supra. How do you program that? In the paper that I just showed you that I wrote with Dr. Benitez, we talk about how to program the hearing aids based on that. Generally, what you have to do is fake it. You have to trick the system. So we would put in, and none of the manufacturers will tell you how to program it. None, because there's a liability. So what you have to do, we suggested you'd put in an audiogram like 30, 35, 40, 45, 45, 50 as a starting point. And you must do real ear, because you have to make sure that soft sound, you're giving her 5, 6, 7 dB of gain. Loud sound's nothing. Because if you start blasting that ear, you might as well be the FDA. Oh, did I say that out loud? Because you're going to overpower that ear. So you have to use really good hearing aids that you can really control the SPL. And when I'm seeing medium and loud sounds come in, I don't want to see any gain. I just want gain for soft sounds. So I'm improving her SNR, and I'm not making the world much louder for her. I'm just making soft sounds louder. So that's a brilliant question. Thank you. And for diagnosis, the only person I refer to for CPT codes is Deborah Abel at Audigy. Debbie is like the smartest person in the billing and coding world. I love Debbie. She's been a dear friend of mine for 25 years. I never tell you what codes to use because I could be wrong. Debbie won't be wrong. Deb Abel at Audigy, ask her how to code it. I would say my opinion, which is probably wrong, supra-threshold listening disorder. But as far as how to program the audio, so you start, really conservatively, and you've got to have probe mic measures to prove that you weren't blasting that ear or you have a liability. So we already covered all of this stuff on what are the probable or possible etiologies. You were first. Sure. Did I have a difference in standard versus premium? No, we just fit. Yeah, we just in the Beck and Benitez test. Excuse me, we just used openness ones. So it was before Oticon More. But we just tested. People ask all the time, what's the difference like Oticon openness 1, 2, 3 or Oticon More 1, 2, 3? And none of the manufacturers test all of their stuff in populations because you wouldn't believe how expensive it is. It's unbelievable. And by the time we're done, we've come out with the next generation. So we do studies of 25 or 30, 35, 40 people in Denmark on the premium technology, and then the lesser technologies have less features, so we presume. But this is the beautiful thing. Test each patient on their SNR 50. If they're not doing better with an Oticon More 1 than a More 3, give them a 3. But don't guess. It takes 2 minutes to do a speech and noise test. And what you're really, I showed you the paper from Jason Galster, American Journal of Audiology. Jason was with Starkey at the time. It was like 3 or 4 years ago. Now he's the director of research at Advanced Bionics in California. And Jason said, the number one thing we do to improve speech understanding is improve the signal to noise ratio. Jason was absolutely correct. So these are just more, etiologies that would give you no hearing loss, most likely on an audiogram, but absolute super threshold listening disorders. I showed you this paper already. If you didn't take a picture of it, now's your time. And I showed you this one already. So our challenge is beyond hearing. It's to improve the opportunity for listening success. I'm going to just cover deep neural networks very briefly. Does anybody here know what a deep neural network is? Okay, so let me give you a warning. and I mean this because I love you. At 3 o'clock, I have somebody picking me up because I have a flight at 6 out of Newark. Oh, he's here. Thank you. So I am leaving at 3. So please ask questions now before we get into deep neural networks, because I can't miss my flight. I haven't been home in 2 weeks. Yes.
What do you think about auditory processing support.org or LACE for additional help when you've done all the best practices that they are getting back?
Well, LACE is Listening and Communication Enhancement by Robert Sweeto. It's brilliant. The problem that Robert reported after seeing thousands of people go through the program is it's incredibly boring, unlike Robert Sweeto, who is very entertaining. But people doing rehab on their own hardly ever works unless they're highly motivated. But most people aren't. They start to get the idea of what it is and they go, and they drop it. So what I would advise, and I have no evidence, the person who has the best evidence on this is a doctor of audiology named Carol Johnson. And Carol has written a couple of books on oral rehabilitation in groups and individuals. And I think the very most motivating thing is to have a fun oral rehab class. And I mean, like every Monday, you would have from 7 to 9, all of your patients invited to come in. And you tell them, if you come in for the 6 classes, we give you an extra warranty, 6 months, 1 year, whatever. You got to motivate them. There's got to be a carrot and a stick, right? But if they come, because then they start to learn to listen, and you could teach them, lots of different things about how to listen more effectively. Somebody brings in, okay, this week's assignment, write down your 3 most difficult listening situations. And when you have 6 or 10 people sitting there and they're all talking, and then you, because you're so much more adept at this than your patients, you tell them what they could have done or should have done or how to use the equipment to accommodate that situation. And you keep it fun and you keep it light. But most of them are going to go, I never thought of that. So that I think that the individualized oral rehab works. There are absolutely peer-reviewed papers showing that online oral rehab absolutely works, but you've got to have a motivated patient. And it's not really motivating to go sit in front of your computer. I mean, after 1.5 years of pandemic, none of us want to attend any of those classes anymore. So I would make it fun. And I would probably have a 1 glass of wine limit. I would pour wine, or I'd have coffee and pastries or something. Make it fun, make it social, but make it educational. That's the primary goal. Yes, sir. It's primarily directional, but it's not very active. So whoever's wearing it, it's only picking up sound for like 12 to 18 inches. And that's the beautiful thing. So you could wear it here, or you can wear it here, or in your pocket. I wouldn't put it in my pocket, but the closer it is to your mouth, the better, because it's not very sensitive for distance. Yep. They're not inexpensive. Right. 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 Yep. Yeah, so the question for those of you online is, do the directional FM systems that are commercially available work pretty well? And the answer is yes, they do in some situations. If it's a Thanksgiving dinner where 18 people are talking all at the same time, they're all a disaster. I would always use an FM rather than nothing. And if it's one-on-one with an adult, and the issue is cocktail party, restaurant, typical listening, I'd go with the smaller, less expensive digital remote mic. If I'm in a group situation, those FMs that have adaptive directionality, it's worth a try. I mean, I wouldn't say anything bad about them, but it's all going to depend on the acoustics in the room. That's the bottom line. And it's not just the acoustic, it's the, the reverb. Well, it is entirely the acoustics. I said that poorly. It's how loud is the most prominent speaker and how much louder is that person rather than the background noise. So the directional mic knows where to focus, and what's the level of reverb, and is the reverb time in that room, 0.2, which would be normal, 0.4, which would be a real pain in the neck. So all these things are going to matter. So I would absolutely, I give the patient both of them, let them try it. You probably get 30 days from whoever you're buying it from. let them try both. And I would counsel them that the difficulty is not going to be, can we make you hear? Piece of cake. I can make anybody hear. The question is, which one do you get more information from in a difficult listening situation? So try them both. The peer review stuff, I wrote an article with Harvey Dillon, must have been 2016, and Harvey said that any good digital remote mic, because again, these are 150 to 200, not 500 to 1,000. Harvey said at that time that he would expect any good one to be giving an improvement in SNR by 20. Now, I have not seen that. I love you, Harvey. I'm sure he's right. He knows a million things more than I do. But I've seen 12 to 15 dB improvements. And so I'm just an advocate for remote mics. Which one you use, it's kind of like hearing aids. Whichever one works better for your patient, that's the one I would use. So I would probably try both. There's certainly some people who would benefit from a directional adaptive FM. But I think for the average adult in the working world, probably the digital remote mic will be great. But everybody's different. It depends on, and that's why you're doing a listening and communication assessment. That is to decide where are their difficulties and how difficult are those positions. Somebody else, yes, ma'am. The best one, Carol Johnson, Carole Johnson. You could Google her. She wrote her last oral rehab book. I want to say it was like in 2012, but oral rehab doesn't change. The technology changes, but the dynamics don't change. And I think I'm probably wrong, but I think she's at University of Mississippi. She might be at Ole Miss. I don't know. She's somewhere in the South. But if you can't find her on Google, send me a note and I'll send you her email. I don't think she'd mind. Okay, so deep neural networks in 20 minutes or less. Deep neural networks, you'd be surprised. They're all around you. You're using them every day. This is not cut and paste. This is not simple technology. Deep neural networks are artificial intelligence, but I don't use the term AI because it's benign. When you say artificial intelligence, that could be the thermostat in this room. So if the temperature is set for 71, when it gets up to 74, it kicks it back down to 68, 71. Right, that's artificial intelligence. We are talking about 100 million levels above that. Machine learning is you set program 1 for speech and program 2 for noise. And what maybe the hearing aid starts to notice, because you've got an intelligent algorithm, that when it gets up to like 60 dB SPL, it kicks, you program it, you press the button, it goes into program 2. So pretty soon the hearing aid starts to learn, oh, it's 60 dB, go to program 2. That's machine learning. And then you have artificial intelligence, which is deep neural networks. And in biology, that's how you learn to walk, right? You're born on your back. Well, you get there. And then eventually you lift your head, you lift your body, and then you start stepping and your brain starts taking in all the sensory information from tactile, from vision, from hearing, from vestibular. And you are not born a blank slate. You are born a prepared blank slate. So humans have this incredible ability to listen and use language. No other being can do that. That's why we're at the top of the food chain. I raise really smart German Shepherds, but the smartest German Shepherd out there probably knows 10 words. That's it. And those are really distinct sounds, right? Sit, stay, come. I mean, they're very different. They're not like, but we can have tens of thousands of words, hundreds of thousands in over 1,200 languages across the globe. And we can attribute meaning to all of those sounds because we have human brains. So human brains develop biologic deep neural networks, but also fish learn to swim and birds learn to fly. So how do they do that? Well, they take vast quantities of input data from their sensory system, because everything came in through your ears, your eyes, your vibrotactile, your smell, and your taste. And your brain arranged that based on that prepared brain that you were born with. And no two are the same. I have two daughters, they're 29 and 31, and they were raised by the same mom and dad, same household, within 18 months of each other, totally different. And you know people like that. You're one of those people. Your brothers and sisters are not the same as you at all, even though they all have eyes and ears and they were even in the same environment. It's what did that brain do with the information it got? If you're lucky, your brain did miraculous stuff with it. If you're lucky, your sensory systems have provided all that information to your brain to make sense of. So that input data determines actually who you are. We know that children who do really, really well with speech and language and academic achievement, they are stimulated like there's no tomorrow as far as speech and language. Whereas kids who live in lower socioeconomic groups get about 10% of the speech and language stimulation as kids in the upper groups do. So we're looking at your biologic deep neural network is looking for patterns. It organizes that information, it uses the best fit outcome, and it self-checks to make sure that the output reflects the input. So the Oticon More is trained on 12 million speech sounds before you get it. And so that it knows what it's looking for. When you think about digital deep neural networks, by way of analogy, you're using these every day. You open your phone, facial recognition. You go to the airport and they scan everybody. You know those little black bubbles up in the ceiling? Those are cameras. And they're scanning constantly looking for the bad guys. And they know exactly who it is. I came in from Europe the last time I went before the pandemic. I was actually at a study group for the British Society of Audiology. I live in San Antonio, so I came in through Houston. And I didn't even have to stop and put my passport in. Total facial recognition. I have that World Traveler Pass, whatever it is. So you don't stand in the regular line, because I used to travel to Europe a lot for Oticon. And so I was prepared to just put my passport in. You didn't have to talk to anybody. You just put your passport in, it takes a picture, ding, you're good, and you go. So that's why those lines are always so short. It takes no time, no questions. You used to put your fingerprints on there. We don't do that anymore either. The last time I came in, right before the pandemic, I walked up to the machine and it went, ding, Dr. Beck, you may enter. It's like, what? I didn't even put my pen, and no fingerprints. That's how good facial recognition is. Speech recognition, you're all familiar with Siri. I won't tell you the details, but it's not cut and paste. It's not just a digital processor. It's a deep neural network. You can take any idiotic, moronic, brilliant, unbelievably complicated statement, say it to Siri, and she's going to give you an answer. And if she doesn't know, she'll say, here's what I found on the web, right? So these are deep neural networks. If you use a self-driving car, not yet, but self-driving cars, they're going to be here in 2 or 3 years. If you don't believe me, look at YouTube, go to Elon Musk, read. It will blow you away. And they're much safer than you. You and I don't drive that well. I know everybody here thinks that you drive really well. But you know how many people die on US highways every year? 35,000. Do you know how many accidents there are every day? 1,500. Right. Because, you know, you're like down in Manhattan, right? And you pull up to a stop sign, you look around and you see, right? Or somebody's eating their lunch while they're driving, and we're all singing along with the radio. We don't pay attention when we drive. We suck at driving. And then you go to a party, you go to a restaurant, you have a glass. Oh, I'm good with one. Oh, really? Because we all know that it physiologically totally slows you down to horrible. But, you know, so my point is, self-driving cars, I think we're all scared of them, but the bar is really low. So what if self-driving cars kill 10,000 people a year? I mean, that would be a catastrophe. That would be horrible. It would also be a whole lot better than the 35,000 who are dying now. You know, so I'm not ready for self-driving cars, but I don't fear them. I think by the time they're commercially available, they'll be really good. They'll be better than you and me, to be honest. Amazon. So if you buy a tie like this, I don't know what this is. This is like a silk blend or something. And supposing that I buy a tie at Amazon, I don't know, $32, right? And then like 3 weeks later, a new tie comes out that's kind of similar. They'll say, oh, Doug bought this for $35. Oh, it's a similar tie. Send it to Doug. That's a deep neural network that says, right? Hey, Doug, we thought you'd want to know about this, right? And I can hit delete, of course, or I could turn that function off. But most of us don't turn it off because we kind of want to see. You know, I just bought a stud finder. There are things that you buy in a drywall like this, and you want to know where the stud is when you're putting in shelves. So this is the way I learned to do it. So there's a stud right here, right? But there's a little handheld thing you can do for $35 that you just go zzz, and it shows you exactly where the stud is, right? So I bought one for like $35, and then Amazon like 2 weeks later says, oh, here's a better one for $18. You know, so. Yeah, right. So anyway, so that's a deep neural network. And so you're using them all the time. This is not cut and paste. So what we did with Oticon More is it's a deep neural network trained on 12 million speech sounds. I'm not going to go into this because I got about 14 minutes left. But what we do, remember I told you, we go directional, beamforming, and we compress. And then, so the sound going to the cochlea is already reduced. You've already taken the dynamics out. So for the brain to make sense of the sound, it has to orient to the whole sound, which you've already substantially changed by putting it through a hearing aid. We don't do that. We use a deep neural network, so we maintain the dynamics. We maintain intraoral loudness differences up to about 14 dB. The throughput time is almost instantaneous on intraoral timing differences. So we're maintaining all of those cues. The reason your patient takes the hearing aids off at the restaurant, because the brain couldn't orient because you took away all the information it needed. And you didn't do that because you're a bad guy. You did that because that's what we've all been doing. I mean, we've had directional now for 40, 45 years. We've had digital for 30 years. We are the first company that has completely on the chip a deep neural network. You don't need a secondary device. You don't need the cloud. It's all the processing done on the chip. And so the advantages are pretty apparent because you take, so this is speaker 1, speaker 2, background 4, talker babble 2, 3, 4, background, and the SNR here is 3. People with normal hearing need an SNR of what? 2. People with mild to moderate loss need 8. So this is 3. This is pretty challenging because you got 4 noise sources and 2 people talking. And basically we did 64 channel electrodes, and this is your 64 channel EEG, but you can synthesize this down just like you do an ABR. An ABR, you do 2,000 clicks and then you look at one trace. Well, you can do that with an EEG. You can get this down to one trace that you can make sense of. And then we compared this to a traditional, the top one is a traditional digital waveform from Oticon Open S1, 6.3 dB signal to noise ratio, but you overlay that on the EEG, it doesn't really correlate. That is, the sound out here at the microphones isn't really correlated with what the brain is detecting as amplitude, because your EEG is just a measure of amplitude over time. But then we took Oticon More deep neural network and it's 60% amplitude correlation. That's all you need to know. That's why people say, oh my gosh, that sounds so much better. Yep, because it's actually it's allowing the brain to orient to the sound, and then the brain focuses on what it wants to focus on, just like you're doing right now. So that's orient through the EEG. Focus we could talk about through selective attention, which is my ability to pay attention to who I want in the noisy scene that I'm in. We took 34 people, we put them in this sound scene. This is simple, this is complex. I'm not going to go through it because of time, but basically with Oticon More turned on, statistically significantly better than Open S1 and better than the deep neural network turned off. So that's how you measure focus. We can measure recognition using speech and noise, which we did. A bunch of folks comparing speech and noise with, this is Open S1, statistically significantly better with Oticon More 1. Now, the thing that I can't tell you is the total SNR here. I can tell you this was about 6.3 to 6.5. That was the baseline. In other words, we're just comparing deep neural networks to our most sophisticated digital processor, and it's another 1.5 dB better signal to noise ratio. If I had to guess, I would say that this right here represents a total SNR 50 of about 7 or 8. And then we found that if you personalize it, you actually do the Genie software correctly 2 or 3 weeks after they're born, you get it up to an additional 2 dB SNR over Open S1. We also found, I would love to go through this with you, but I have 8 minutes left, that we improved memory and recall using a digital deep neural network because people had a better signal, they had less noise, they had a better signal to noise ratio, it required less listening effort. So they could remember words more readily. And the final one that I'll show you is the tech slide. So all the technology you heard earlier this morning, I don't care. I just don't care. The only thing I care about is the outcome. I'm not going to read any of this to you. I couldn't care less about this. If my patients have an SNR 50 of 7, 8, or 9, because they're wearing a really good premium hearing aid, that's the only thing that matters to me. If you're a tech geek, and does anybody in this room know what a 28 nanometer chip technology is? And could you compare and contrast that, please, for me for a 14 and a 56? You know, I think it's ridiculous. I mean, it's not, it's very important for, engineers, but I'm not one. I am a clinician. So I'm not going to go into all of this stuff. Of course, you can stream it to any phone you want. With Androids, you have to be careful because some of the Androids, were built 6, 7 years ago before the protocols. So they don't adhere to anything. 90%, I'm guessing, 90%, 92% of all Androids you can stream. But don't guess. Try to hook it up. If it takes 20 seconds to hook up a phone. So if it works, great. And when a patient says, I have an Android, say, yeah, that'll probably work. Let's try it before we go far. Because if it does, or if you want, you could look it up. It's on the Oticon website. We say which ones we've tested and approved. But I think 99, maybe 95% of all Android phones built in the last year or two will work. Go ahead.
How much of that memory is actually used in finite? How much left over?
I don't know. It's a great question, but I'm have to ask one of the engineers. If you send it to me, I'll send it forward. Well, we always upgrade. Everybody upgrades their phones, their hearing aids for free. I mean, we have software changes, we have firmware changes, and they're always free. None of the majors charge for any of that. So they can be upgraded, but I thought you meant how much residual after all that. Yeah, I don't know. But I do know that, they're always retro and forward-looking compatible. And the cochlear implant industry was great at this. I mean, you can get a cochlear implant now, you could have a 20-year history of that implant, and still when they upgrade the speech processor, it'll work in your implant. So, yeah. Here's my final point. Most hearing aids compress, compress, compress. Oh, I don't know if this is going to work on this computer. We're going to find out. Is anything happening? Oh, too bad. This was a demo. Yeah, I transferred my stuff on a stick to put it on this computer. And it was going to show you that every single thing is compressed all the time on most hearing aids. Something's happening. Nope. Yes. Okay, watch over here. So this is, you set the compression at 65. All sounds above 60 or 65, wherever you set it, are compressed. Now look over here. This is called a floating window of linearity. So only the loudest sounds are compressed. Most of the sounds that go through our hearing aids are linear. And it's a very important concept because nobody likes compressed sound. Nobody. There's never been anybody who said, oh, that's much better. No, no. We do that to protect them. We do that to keep it at MCL. We do that to avoid acoustic trauma. But we don't do it because it sounds better. And it's one of the things that we talked about earlier, that a nice little video on that. Okay, so sound quality. Yes, you heard this earlier today. 8 out of 10 people. We looked at our top 2 competitors. We published this, and you can have a copy if you want. Oh, here's the study. I blew right past it. I just published this with my colleagues a month or 2 ago, looking at MUSHRA, which is how we determine FM and radio station quality of sound. The thing about quality of sound is totally subjective. There's 15 to 25 parameters that matter, that impact quality. So it's always a matter of people listening who have what's called golden ears, and they listen. And so 8 out of 10 of these people listening to all 3 of the best hearing aids on the market, 8 out of 10 chose Oticon More. And we saw this slide earlier with my colleague. So Cafe, we did best. Canteen, we did best. And the point that she, I'm not sure if she made this one actually, because I was out of the room when she had this slide up, I'm sure. So the thing about face masks is that the other competitors have a face mask program, which makes total sense. But we got the best quality rating on face masks, and we don't have that program. We just have a much better sound system. So when it recognizes 8 or 10 dB deficit in the high frequencies, it corrects it. So we were the most liked. And so closing slide, access to the brain through audition is essential to brain development. The brain can only organize itself based on the stimuli received. Hearing loss does not determine functional outcome. Performance with technology is what determines the functional outcome. This is from 2014, Jane Maydell and Carol Flexer's pediatric book. This is their 2nd edition. Really important point. So listening is where hearing meets brain. And I want to thank you for your attention. Thank you. And I wish you a joyous holiday. I wish I could stick around. I can't. I'm out of here. I know. He's kicking me out. Thank you.
Okay, we're going to take a 5-minute break now. Going into break though, we want to ask anybody that has never been an IHS member to put their name and contact information on a piece of paper and give it to Carla. IHS has graciously given us a membership to raffle off. So it's only for people who have never been members. If you've previously been an IHS member, you're not eligible. So if you want to get into the drawing, just write it down and drop it off to Carla. And you've taken care of the virtual, right? And Carla's taking care of everybody virtually.
It works for me.
I don't want that to be calling in, you know, I feel bad about that. Yeah, perfect, yeah. I'll be on that. I won't tell you. Well, that guy does everything. Yeah, there's, I can't remember which one it is. I know, but I just one on the job. So, I've done a lot of legislation. I can't remember which one it is. You can tell by my hair, right? But, right, you can have a, right, you can have a pension.
Right, so we're the law office.
Ooh. Gonna be a candlelit dinner here. I'm not picking up chicks. Just summertime. My presentation will be 3 hours long. Oh, no, go ahead. Yeah. 3 hours.
The midline is like,
3 hours.
I hit the little button and it said, send Zoom. I know. It's like, I love. Wait, we got to the left.
Yeah, she was gonna be, yeah. We're gonna talk about that too. I'll find that out for you, yeah. But that's funny.
I just, I'm like,
They look a lot easier. Don't get that, yeah, it's like. That was the whole. We have a conversation with them. Oh, but I was- First time I got here. Supposed to go on an angle. Nobody tells you that, right?
Yes, oh my God.
I see the next, oh, she's not there anymore. Okay, we're gonna get started in just one more minute if everybody will take a seat, and we're gonna have Eli from Caption Call give us an overview of their product.
Great to see everyone. Meet for victory.
And right after that, then we'll have Beth Christie from Phonak, who has spoken for us before, and I'm sure she'll be a nice closing to our wonderful educational day today.
They're virtual. Hey, mine is for sure.
Okay, real quick, before we have Eli come up, we're going to ask our past education chair emeritus, Chip, pick us a number between 1 and 9. Only Chip. Okay, so Chip picked 7, and that is Paul Fisher. So congratulations, Paul Fisher, and he actually, he just left a minute ago, so yeah, he had an emergency, so we have his contact information. Okay. You're up.
All right. You snooze, you lose, Paul. Okay. Hey, guys, thanks so much for having me out. John Russo wanted to be here, but not that much, obviously, not that much. How many people in here know John? I know a couple people. Okay, everybody and their mother. Yeah, that makes sense to me. Well, my name's Eli. I have the Eastern Pennsylvania territory. So I'm here representing Caption Call, and I just wanted to chat with you. I'm sure many of you are very familiar with what we do, but it's a captioning phone service for folks that are experiencing hearing loss in a profound way, in a moderate way that doesn't allow them to function the same way other folks would that don't suffer that hearing loss. And I think what's important for you at Caption Call is to kind of see how the progression works. So from the start, when you have your patients in, you're going to obviously run your diagnostic tests, assess them, and then at that point, you're going to be able to refer Caption Call. Where I think we make it easier for you, instead of having you fill out 15 different things and fax them and do the whole thing, we have a one-click system. So how many of you guys use NOAA or Cycle or Counselor, any of these products, right? If you use any of those, we make it easier for you to put your patients in a position to get the phone, a couple clicks and you're there, as opposed to having to do a ton of paperwork. So I think that's important. Things to remember, and I'm sure John's kept you up to date on all this stuff, but as providers, when you're advising your patients about kind of how Caption Call works, you no longer require a landline, okay? Because we can do it via Bluetooth, via your smartphone. You no longer need internet because we have a proprietary device, a cellular device that works with the cell towers to help you get captioning from that, okay? So that's huge. We talked for a second a little bit about the app. I personally think, just being honest, I think the app is just a little bit clunky. I would prefer that if you're having patients with smartphones that can take an app, rather you go ahead and just Bluetooth it into the phone. Within 50 or 60 feet or so, they're going to be able to access the phone, get the captions, and they'll have it'll be a very seamless transition from regular over to the Bluetooth. Something else to consider also when you're talking to your patients is with Caption Call, unlike other services that will remain nameless because I've forgotten them, we're going to do a red carpet install for all your patients, okay? And what that means is we'll send a trainer out to help them get set up with anything they need for Caption Call, even so far as adding contacts, going through the manual with them if they have questions. We can also do a boost of the audio up to 120 dB, okay? So folks that maybe, they don't want to have to read the caption the entire time, they're still getting some hearing, we're going to be able to help those folks as well. So we're not excluding anyone because there is a delay. Naturally, there's going to be a delay no matter what. Caption Call happens to be one of the lowest delay times in terms of captioning, but there's going to be a delay no matter what. And so you don't want to have to be constantly reading. So for some folks, if we can turn it up for them and amplify it, it makes their experience a lot better. I would just say that for you guys as busy people that are seeing a lot of patients, the takeaways really need to be, it's easy to refer. It doesn't take a ton of your time. It helps people immensely. It's at no cost. And I think that's the biggest one, right? To you or your patients. It's paid for via the ADA. It's cost-free. And it's something that's a resource for folks. It's a value add for you to a degree, right? But you're not getting anything other than what? A better patient outcome, which is I think what you all want. And ultimately a better quality of life for them. So I think if there's any questions, any concerns, or if you need me to relay anything to John, let me know. Does anyone have any questions? Anything I can help with? Did I miss anything? Yeah, and that's, I'm glad you mentioned that, because you should be reaching out, and even if it's just a text, doesn't have to be anything fancy, an email or an official phone message or something like that. Shoot John a text, because he's not here. You should all shoot him a text right now and say, where the heck are you? I don't even know. He's probably fishing in Florida. As he says, I gotta put my kids through college. That's what he always says to me. So yeah, please reach out. Don't hesitate. We're trying to make everything as seamless as possible. And we can always bridge the gap between us and you guys in the operations team and your patients, right? So I have a couple of people who I'm dealing with right now who I need to get them set up with new phones, take old phones. We'll definitely make that happen for you. And, you know, obviously, I hope you feel comfortable referring. And if you need anything, give us a shout, okay? Any questions? No PowerPoints, right, guys? Thanks so much. There we go. Thank you.
Our next speaker is actually going to be virtual. Beth Christie is joining us from Phonak. She's the territory manager for the Mid-Atlantic. She's going to let us know what's new with Phonak Paradise.
All right, can you guys hear me? I'm sharing my screen right now. I can hear the room. Can you guys hear me at all or no? Yes. You can? Yes. Okay. All right. So this is going to be not as interactive as I would normally like, but we will go through this way. So I'm going to set up the slides. All right. Most of you probably know me. If not, my name is Beth Christie. I'm the sales manager for South Jersey, Eastern PA, and Delaware. At the end of the presentation, I'll leave my information if you need to reach out to me for any further contact. I think one of the big things that Phonak really prides themselves on is creating a solution for everyone. From hearing protection, which we have our new Serenity line, which is universal and customized hearing protection for patients, to our mild to moderate patients from Lyric, Verto, and Audeos, to our severe profound with the Roger, Naida, cochlear implants, pediatrics, cross. We really do try to create a solution for everyone. And I know sometimes that can get confusing because we have so many products. So I'm here to try to clarify it a little bit and show you a few of our new products that just came out on the market. The newest product that some of you have seen and some of you may have already used is the new Cross P. I think this is not going to be a shocker to anybody, but some of the issues and challenges for these types of patients audiologically is reduced awareness, difficulties hearing in noise, reduced localization. And this, of course, can, hinder well-being, quality of life, and can increase loneliness. So this could be a serious challenge for a lot of our patients that are dealing with this kind of loss. And what Cross does, it basically helps with that unaidable ear. So we place the Cross system on the unaidable side, and then it sends sound and over to the normal hearing side. We can also create a bi-cross system where you have an aided ear. This is something Phonak has been doing for a very long time. We've had the Cross system for a very long time and have been very successful with it. Some of it has to do with the way that our hearing aid adapts with the Cross system. So with our new Cross P product, we have some different things that have come up to help improve speech understanding in noisy environments. So what happens is as you get into higher level hearing aid side, so we have 30, 50s, 70s, and 90s as far as the hearing aid side that you can choose with the cross. As you go up in hearing aid level, the actual hearing aid will help the cross to cut out background noise. So that's how the hearing aid helps the cross, and it works as a system to create better speech understanding. This will then help also to help the patient to follow the conversations wherever they're coming from. Again, because you're getting input and information from both sides, and it's sending it to that better ear side. Within the new Cross P technology, we have the Paradise Performance. So the chip that the patient will be listening through will be the Paradise, and it will be able to connect to smartphones, TVs, Roger products, and more. It comes in our battery operated and rechargeable, so it makes it easy to use. So these are all the different features that are within the new Cross P product. You can see there's a lot of features that may look familiar if you fit our Paradise line. Things like stereo zoom, speech enhancer, dynamic noise cancellation, AutoSense OS 4.0. These are all things that are in the hearing aid side, but because the hearing aid works with the cross, it basically becomes a cross feature and benefit. So these are all, again, things that are part of the Paradise line, but the cross gets to leverage it. So tap control, which was something big that was launched with our Paradise line, the motion sensor hearing. Again, all of these things are going to be leveraged with the cross hearing aid. So the cross is compatible with the rechargeable. So you can see the Cross PR is going to work with our Audeo PR, which is our Paradise rechargeable, and our Paradise rechargeable T-coil. And then we also have the Cross 13, which will be compatible with the Audeo 13. We do not have a 312. We have the 13 product line, and that's mainly due because of battery. So these are all the different couplings for the cross products. So you can see we have domes, slim tips, cross tubing. So whatever we need to do to help make the patient feel more comfortable, because we know the coupling can be very important for the sound quality for the patient. So this is the battery life. As you can see with the rechargeable cross, it's 12.5 hours. That's including streaming of TV, phone, media, loud noise, and includes the cross streaming. So that's a lot of strain being put on the rechargeable cross battery, cross side, as well as the rechargeable hearing aid side. And I know that for some that may be a little bit of a concern, but I will go through some information to hopefully not make it as much of a concern. But one of the things too is if you do have a patient that is in the cross products and you're worried that they're not going to be able to get through the day, you can always reach out to your representative. We can always get them like a little charger just to use in the meantime, just to kind of do a quick 30-minute charge if they actually need some boost. But if the patient is really needing long-term battery usage, you might want to move to the Cross 13, where you can see our hours of operation usage is a lot longer for the battery operated. When we pulled our data from the Cross B wearers, we've noticed that most of them have fallen between that 12 and 13 hour time range. So for the time frame for the 12.5 with the Cross, with the rechargeable, we don't see it as being too much of an issue. I know that a lot of my patients that have already started using it, they haven't had any issue with the 12 and a half hours, and that's conservative. So it could be longer just depending on how much they're actually going to be utilizing the cross side and how much they're going to be streaming and how much it's going to be pulling from that battery. So these are just the different hardware. We did bring back sandalwood color. So that is an exciting thing for some people. I know we got rid of the sandalwood with the Paradise line, but due to popular demand, we brought it back. So please do tell us things that you're looking for and things that you want from Phonak. We do listen, we create cases, and that's how changes get done. So we do want to make the best products and whatever it is that you guys need out in the offices. So please continue to let us know. You can also see here, we have our typical charger case and the power pack. So the power pack can be put on the bottom of the charging case, and that can help help the batteries help so that you can be unplugged from the wall. So that backup battery is give you up to 3 to 4 charges off of that battery power pack. We also have the charging care, which is a D-dry type of charging care. So you can actually charge your hearing aids, and then there's a UV light as well as an air dryer that goes through. So we do have some different options depending on what your patient's needs are. So here is some target fitting software considerations with the new Cross. We do recommend that everybody do the update for the Audeo side, because you will need to have that updated so that the Cross will recognize it and it will work. It's not a long update. So just make sure that you do that before you start fitting the Cross. As you're fitting it, you do want to make sure that you put a audiogram for both sides. I know some people traditionally haven't really put an audiogram in. We do recommend that you put, even in the better ear side, the cross side that isn't really going to be getting sound in, we do still recommend that you put an audiogram in that side. When you're in the cross balance section, just to review what cross balance is. So if one side, like in this picture, you have your right side is the cross microphone, and then your left side is the hearing aid side. When I raise the cross side, I'm actually lowering my microphone side. So it's a balance. I'm not turning overall gain up, I'm just balancing. So a patient may say, I'm really struggling on my cross side, I can't hear as well, I need to hear the person more. Then you can turn that cross side up. And what that'll do is that'll turn the other hearing aid side down. So it's basically a balance. And so when you do that, just note that you're not actually turning up volume, you're just basically turning up and down the balance. Now you can do the overall balance in our typical fine tuning slide, and you can just increase the overall gain of the hearing aid. Or when the patient is using the hearing aid side, the hearing aid can do the overall gain. So just a note for what exactly cross balance is. And you can see here in the software, you can kind of play with the microphone mode now. We've added this. So you do have the cross microphone off, or you can create omnidirectional or real ear sound. So you do have the ability to create a program with the cross microphone and change the directionality of the mics. We do have a the multifunctional button. So for the cross side, it's going to be, again, that balance. So when you're turning it up and turning it down, you're doing the balance for the cross side. And then for the hearing aid side, you're seeing here now is you're going to see an increase in volume and a decrease in volume. So you have the hearing aid side, and then you have the cross side. So they function separately and differently. So with the new Cross P, we're looking at improved speech in noisy environments, following conversations wherever they're going, proven paradise performance and universal connectivity with your smartphones and TVs and our rechargeable options. So a few updates for the, okay, I just wanted to check to see. Okay, we have a few updates with our remote support. Remote support, my phonak memory, and tap control sensitivity. Tap control sensitivity and cleaning reminders. So we have launched kind of our new updates for the app, which has been very, I think, needed for some of these things. Our new simplified remote support has been a great option for some people to be able to program remotely for their patients. Our old system was very tedious. As you can see, there was several different steps. Our new system is very easy. Fit the hearing aids in the office, pair it with the app, and then you launch remote support. It's very, very simple. So if you do have those patients that are unable to come back into the office for whatever reason, and you need to do some follow-up, or if they're going on vacation and you wanted to do some follow-up, our new remote support app is very, very easy to use. So a quick tutorial. Once you connect the hearing aids and you do the software upgrade and you basically go through your whole set, your fitting, and you save it, you'll see at the end, there's a remote support enabled, and there's a little checkbox next to it. So you'll know at that point that remote support has been enabled in those hearing aids. Once that has happened and the patient has downloaded the app and connected their hearing aids to the app, there's a little spot in the app that says remote support. They go to that and they click that. And then you can see here on target, it's in before you actually go into the open fitting session. You just go into the start remote support. It's before you even go into the target fitting. So you're going to create the remote support first, start that up. It's kind of like FaceTime. So you'll see the patient, and then you can dive into the fitting software and you can fit just like you normally would remotely. The other thing that we did was the My Phone Act memory. I'm sure some of you had heard some issues or maybe had experienced some issues with patients that were using our app, and when they created a program and the hearing aid or basically the phone kind of timed out, they would get kicked out of the program that they created in the app. So what we did was we created this My Phone Act memory. So we've kind of updated our app with the ability so that it won't get reverted back to AutoSense. You can access multiple devices. You can customize now and name up to 10 programs, which is a lot more than what we've had in the past. You can delete or rename some of our preset programs. So we basically enhanced our app so that you have the ability to make some changes and to add the different programs that you need, and that it won't, time out of the programs that you created. Another addition that we made with our new app was we have control sensitivity. So this is for tap control. So it'll be for your rechargeable patients. So the patients in Paradise rechargeable products that have access to the tap control. We were finding that a lot of people were either saying it was too sensitive, not sensitive enough, depend on what the patient was dealing with, if they had glasses on, so forth and so on. So we wanted to make it adjustable for the patient's needs. So you can make it gentle, normal, or firm. The patient can try it out in the office and target software to see what makes best for them, but they can also change it in the app. So they do have some ability to kind of play with it a little bit. The other thing we created in the My Phone app is the cleaning reminders. So you can create some reminders so that they remember to change their wax filter or whatever it might be that you want to remind them about. Just to note that right now the cross side does not have the ability to connect to the app. So when you are fitting our new cross product, just note that the patient can't use the app. They can still stream and they can still connect to the phone, but the app is not working currently. We have to do an upgrade with the app, another upgrade with the app being able to do that. And it's looking like we'll be able to do that in 2022. So please keep an eye out for that new update, because that will be coming out shortly. So with our firmware update, we have the ActiVent compatibility, Cross P compatibility, tap control sensitivity, improved fitting while charging, and Roger receivers in all trial products. So when you do the firmware upgrade for your products, these are the things that are going to be coming up, and I'm going to be going to a few of those new things as well. So here in tap control, we were just discussing that in the app. Well, this is where we actually have it in the software. So again, if you want to customize the tap control, make it best for your patient, you can create different, like whether or not when they're able to access tap control, whether it's just when they end and accept phone calls, whether they're streaming, whether they're starting and stopping voice assistant. So the way I look at tap control, I know not all of those things may be useful for some patients, especially I know I've heard the voice assistant could get a little bit bothersome, But I do think the pausing and resuming streaming for certain patients could really help, and accepting and ending phone calls. So if you have a patient with dexterity issues and they can't get that button to actually answer the phone, or they don't have the phone on them to do, to slide and to actually use the phone itself, what you can do is they can set up the tap control to answer the phone. Same thing with streaming. If they're listening to something on iBooks, or they're watching Netflix, and then someone comes and approaches them, instead of them trying to go and try to stop the streaming, put a pause on it, they can just tap real quick on their ear, start talking to somebody, answer the questions, and then they can tap and go right back into their streaming products. So I do see there's some instances that this could be, especially for potentially any of your patients that are, connecting to multiple devices and wanting to be able to stream a lot. This could potentially be something important, but only important if they can use it correctly, and if it's being used correctly as far as what they want to use it for. So that's why we also have the training and sensitivity. So now they can change the firm, the double, the normal and gentle tap. So you can go through while you're in the software and test out the tap control so that the patient knows what it feels like and knows how strong of a tap they need to do. And then they'll be able to use it when they have those specific instances that they want to use it for. So if you do have any NJAHHP trial devices, if you do the firmware upgrade, you will automatically be putting Roger 2 receivers into them. So this could be very beneficial if you want to do a trial of any of the Roger products with a patient. You don't have to worry about also getting a set of receivers. We will automatically install the receivers with the new update. So this is just something to kind of note. When you're in our streaming mode, we do have something with the hearing aid microphone. So this kind of helps out with creating a better sound quality, the enabling the microphones. So the microphone sound quality while you're streaming, we created it so that it's used to be at -6 dB. What we found is that when a patient was going into the streaming program and it was set at -6 dB, they almost felt like it was getting too quiet. So it was like almost sounded like the hearing aids were turning off. So what we did was we actually made it 0. So we kind of upped it a little bit. You do have the ability to go back in there and change it back. But we should see with the 0 a little bit more of a comfort with the patients and just a better streaming quality with the patients when they go into their streaming programs. So please feel free to, if you have other programs that you might need to change that to, we do have it at -6 dB for some of the other programs, but you can go through and change it to 0. All right, Audio Life. So this is our newest product that just came out. I'm sure some of you may be pretty interested in hearing about it. It is the world's first waterproof rechargeable hearing aid. So this is very relatively new. It's only been out for about a few months. It is completely waterproof, showerproof, and sweatproof. I will go through a few of the trials that we put it through to make sure it was able to do that. But some of the features with this product is it's actually all one piece. So we laser in the serial numbers, but there's no pins, there's no contact points. We did additional microphone protection, and you can actually see in the picture, the microphones are kind of slitted upward. So to help prevent water from getting in, there's silicone seams throughout the product, a Prylene coat on the internal circuitry. So it's almost like, it's kind of explained to me as like almost like an oil kind of that's like coated on the inside. I think of a duck, like how water just slides off the duck's back. Like that's how the inside is, like the water just isn't able to get inside of it. There's also, this is a Paradise product. So the same, sound quality that you've been using for the last year or so with our Paradise line, it is the same chip. So it has the same sound quality. It's just waterproof. And we really did some thorough testing of the product. So what we did was we did shower testings in salt water and pool water. So we did 500 dives in the pools and salt water to make sure that it was going to last, which I think is relatively unique. And then we also did shower tests with and without shampoo. And you can see in the picture here, it actually has the receivers it actually has the receivers that are attached to it as we did our testing. We also had 520 hours of heat and humidity. So for sweats and high temperatures, this product has been thoroughly tested in. So just to note, I know a few of my coworkers who are hearing impaired have gotten their hands on this product. This is an inductive charging product, so you'll just be dropping it into the new charger that I will show you in a few. But one of the persons that was trying it out, he's very into going to the gym and likes going to the sauna and steam room, and he's never worn his hearing aids in those environments. And he was able to do that with this. So he was very excited to be able to try it out. And after using it for several weeks, he did not have any moisture issues, as well as we've had another person that went outside and was using it gardening for several hours where she was sweating and it just had, you know, a lot of moisture and sweat all over the product. She literally took the product and just threw water on it. So by having the ability to last in water, you could drop the product in water. You can go in the shower. If you go and get your hair done, you can go and get your hair done and not have to take out your hearing aids. You can get your hair washed. So this product is really made for you to live the life the way you want to live without having to worry about your hearing aids. It is compatible with our current receivers. So there's no need to, you know, buy any extra products or anything like that. It's going to work exactly the same. We don't recommend it with the ActiVent receivers because the ActiVent receiver opens and closes. And if you're in a lot of water environments, I don't think it's going to make water's going to get inside the receiver and kind of cause some damage. But for the most part, with our normal receivers and putting a normal dome, as you put it deep into the ear canal, we notice, and, you know, again, you're not going to go diving with it because it does have, you know, the 3 feet is the limit for the depth that we want to put this in. But it is the water does not get into the ear canal to damage the receiver. So most of the time damage to receivers is usually due to wax. So you can feel pretty confident with giving your patient just a set of domes and a set of receivers and sending them on their way and them being able to not have any receiver failures. So this is our charge and go case. This has inductive charging, fully charged in under 3 hours, built-in lithium ion battery, up to 3 charges on the go. Currently, due to supply issues, we only have it available in the 90 level product. We do see it going to be launched throughout the product lines to the 30 level. And it is compatible with all the microphones and all our wireless accessory products. All right, so we do see an industry shift from decision based on lifestyles and communication needs to decision based on audiogram. So I think a lot of times we decided where the patients were going to go based on what their audiogram was. Now I think there has to be a little bit of both. That's going to be lifestyles and communication needs, and often their lifestyles and communication needs and their audiogram has to kind of all go into play. So typically for the hearing aid, we're always looking at the lifestyle communication needs. The receivers, it's always been just what's the audiogram and where does it fit? So now with the new ActiVent, we're going to be bringing in the concept of you can now, doesn't just have to be on the audiogram, it can also be lifestyles and communication needs because of our new smart receiver. So this is the world's first intelligent hearing aid receiver, and that is the ActiVent. What the ActiVent does is it's open when you want it to be opened and closed when you want it to be closed. How it works is it is in response to the hearing aid and what the hearing aid environment is, and then it actually forces the open and closure of the vent. So this graph shows when it's open, how the ActiVent is going to be working. And this is the typical patient. So the way I look at Activent is there's a lot of patients that come in that are relatively similar to this audiogram you have right in front of you, normal lows, and then they miss out on the highs. So you put them in an open dome because you don't want them to feel occluded, especially with a first-time user, right? So you put them in an open dome and then they go out and then they're in noisy environments and then they say, I'm really struggling. I'm not hearing that well in noisy environments. So then you switch them over to a closed dome, only for them to say, I'm really occluded. I'm not hearing that way. Like I feel like stuffy all the time. I don't really like this. So now you're bouncing between the two types. So what the Activent does is it basically can open and close for you based on the environments that they're in. You can also customize this as well, but that is the purpose of this receiver, is to be able to open when you need it open, close when you need it closed, and it goes by whatever is in the software as far as the programming. Some things you're going to want to consider though with this, it's not for everyone. So we don't want to use it. It is only available in an M receiver. So it's not going to be able, the range isn't going to be able to fit somebody with a severe to profound loss. We are going to be looking for those M receiver ranges. Ear anatomy and the ear anatomy is going to fall into play because we are going to do a customized tip for these types of receivers. So you would also too, most likely if they have like a very weird ear-shaped canal, you're not gonna be able to get a good impression. So they may not be a great candidate as well. And then as far as to if they're very waxy, they may not be a great candidate either because the wax will start to fill up inside the actual receiver itself. And then also when it goes from open to close, there is a popping noise. So with that pop, and the way I look at it, it's actually good to have the popping noise because when it pops, the patient knows that it's going from an open to a closed. So for example, if I go to my daughter's soccer game and I'm listening and I'm in an open dome, like open situation. So my Activent is an open. And then all of a sudden I get a phone call. The Activent will come on, it'll pop, and then I'll hear it get quieter. So it gets quiet. So then I can hear my streaming. And there is a very big difference from when you're in an open dome and streaming and when you're going into a closed dome and streaming. So there is that popping noise, but for someone who has hyperacusis, for tinnitus patients, those also may not be ideal candidates as well, just because of some of that types of sound quality. And also too, because they're going to be doing maintenance and cleaning this this receiver, you want somebody with dexterity. So again, it's not for everyone, but we do try to create as many tools for you, the professional, to be able to fit any type of patient that walks in your door. So we do have a candidacy checklist that I can send out to you that kind of just goes through some of the yeses and nos types of things for seeing which types of patients would be good candidates. We do have some kits, some Activent starter kits, which we can send out to your office for you to try it out. Especially if you have a patient in mind, definitely recommend trying it for like maybe, for whatever time frame you like to try things out with your patients for, just so that they can kind of see how it works in their environments. And then once they're ready to move forward with the purchase of the product, then we would go through and do a customized tip and, get the correct size and everything for them to purchase. We have done some clinical studies to show that with the Activent receiver, there's a 10% better speech understanding and noise than conventional acoustic coupling while providing natural sound in different listening situations. So, I mean, for 10% doesn't sound like a lot, but I mean, for somebody that's trying to understand speech, this is going to be something is better than nothing type of situation. It only works with our Audio rechargeable products. So I do want to note that. So it will work on all different levels, but it only works with the Paradise rechargeable products. These are the two couplings. So when you're doing your trial with the product, we have something called a universal slim tip. It's just like a soft dome that you would slide over top of the receiver. This is great for the demo purposes of it. We have a few different sizes within the kit. And then once you're ready for the patient to move on to it permanently, we recommend moving to the titanium, which is a medical grade titanium. It's a custom fit, creates optimal hearing performance. So when you're doing your upgrade on your hearing aids, you need to make sure that you do the hearing aid upgrade first before you attach the receivers. So do not attach the active vent to the hearing aid before you do the firmware upgrade. So make sure you do that first, and then you go and attach the receivers to it. So at Phonak, I know I went through a lot of information quickly. I didn't want to take up too much time. But at Phonak, we really do try to make a solution for everyone and for whatever situation that your patients are coming in. I think some of the new advancements that we've had with Activent, with the Audeo Life, the waterproof hearing aid, and with Cross is really going to help advance your practices and really make a difference in a lot of your patients' lives. So thank you so much. Here is my email address. If you don't have it already, beth.christie@phonak.com. My cell 630-465-2340. Please feel free to text me or call me. If you need me to come out to the office, or if you need any training on any of these products in more depth, please let me know. But thank you so much for having me today.
Thank you, Beth. Does anybody have any questions for Beth? We're good. We appreciate you. And thank you, everybody, for coming to the event today. I know we've lost a few. Thank you to Carla and ABS for really doing the work to put this together, and the facility for the great technology they've helped us with. So we hope to see you all next year. If you have any questions, if you need any information from us, contact us through the New Jersey Association site and we'll get back to you. Have a safe drive home. Thanks.
Thanks.
Now we have member appreciation.
Thank you. Hi.
Oh, hi, nice to meet you. Yes.
Hello.
Paul, good to see you. Good to see you. You too. You too. Hey, Sharon, do you want to come over here? We'll take a picture.
Yeah, thank goodness they're all out. My house is sold, so I'm good.
I'm almost got everybody over. I almost have everybody over.
Hi, Beth. Hi, Carla.
It's feedback. I turn on my computer. Let me- All right.
We have to
Okay, we
hurry.
have a
Today's
few
my birthday. It's time for a
Ready?
drink.
1,
It is.
2, 3, smile. All right, thank you. Thank you.
Perfect.
Thank you.
Thanks. Take care. Thanks for taking care of me.
Bye-bye. No problem. That's
Pretty weird.
Yeah, we got enough